A very warm good afternoon to all of you. On behalf of organizing committee, I welcome you all to the very first session of Fertivision 2020. This is a poster presentation session and we have 8 posters in the room. To judge these presentations, may I call upon our esteemed judges, Dr. Alok Sharma, Dr. J.K. Goel, and Dr. Dr. Rakhi Malhotra to please join the session. Dr. Alok Sharma, he is Assistant Professor, Dr. Rajendra Prasad Government College, Tanda. He is Founder Secretary of IFS Himachal Pradesh Chapter, and he is Founder Secretary of Indian Menopausal Society, Shimla Chapter as well. We welcome you here, sir.
Thank you, Dr. Shikha. Thank you.
Then next we have Dr. Rakhi Malhotra with us. We welcome you here, sir. Next, we request Dr. Rakhi Malhotra to please welcome, sir. Next, we welcome Dr. Rakhi Malhotra to please judge the session. Our esteemed judge, Dr. Rakhi Malhotra, she is Joint Secretary of Haryana Chapter of ISAR and Joint Secretary of Haryana Obsgynae Society as well. We welcome you, ma'am, here. Our third judge is Dr. J.K. Goel, served as specialist and senior specialist in armed forces. He was awarded Commander-in-Chief Commendation for his distinguished services in He is presently serving as Professor Saraswati Institute of Medical Services, Medical Sciences at Hapur. We welcome you here, sir. So I welcome our esteemed judges to judge these presentations. Next, I request our MOC, Dr. Rubina, to please take the session further and start with the posters presentations.
Thank you so much, Dr. Shikha. I would like to welcome all the judges, esteemed judges. And also I would like to wish the participants good luck. The first poster will be presented by Dr. Sangeeta Khattar, and she will be talking about outcome of pregnancy with increased knuckle translucency. Please, Dr. Sangeeta.
Okay, good morning, everyone, all my respected judges and participants. So I'm going to present. We did this prospective cohort observational study at Gangaram Hospital, and this title was, "Are we missing diagnosis in nuchal translucency 95th to 97th centile? A prospective analysis of increased NT more than 95th centile and their genetic outcomes in terms of chromosomal abnormalities and adverse pregnancy outcomes and any single gene disorders." So aims and objective was to find out the incidence of chromosomal abnormalities, I already told. And we compared the outcomes of the NT between 95th to 99th centile and the NT more than 99th centile, and proposed close monitoring in all patients with increased NT more than 95th centile, irrespective of the NT values. So fetal chromosomes were examined in 200 patients, and they were coming to our routine OPD, and euploid fetuses were followed by first trimester anomaly scan. All the patients were consented for patient karyotype with increased NT. This was the isolated increased NT on ultrasound. So first trimester, second trimester anomaly scan in euploid fetuses was followed by echocardiography, and pregnancies were followed 3 months after birth. Postnatal follow-up of children were also done, and results were collated. And out of 200 patients, 182 underwent invasive testing, and we ruled out structural chromosomal abnormalities. This was present in 50%. I'm not able to see my screen. One second. So this was present in 50 out of 182, that assigns to 27.4%, of which 15.2% were from group 1 and 40% from group 2. Group 2, that means NT more than 99 centile. Structural chromosomal abnormalities detected by microarray were from more from group 1, as quoted in other studies also. Additional adverse outcome in 16% fetuses, including 10.2% from group 1 and 27.6% from group 2. Testing for single gene disorders in patients with recurrent increased NT helped us identifying 2 single gene syndromic conditions also. One was in KM2TD gene and second was in PCSK1 gene. And these all are syndromic conditions. So in conclusion, we could have missed 12% fetuses with poor pregnancy outcome, having a mild increase in NT like NT 95th to 99th centile. If we restricted our surveillance to NT more than 99th centile only. So it's very important to counsel the patient regarding his NT even more than 95th centile. So thank you.
So, Dr. Sangeeta, what is your advice to the couples regarding this, your study? How do you like?
Yeah, if any couple come to us in first trimester, anomaly scan has been done and they present with increased NT, even with the isolated increased NT, we need to go for invasive testing in terms of CVS or amniocentesis depending upon the gestational period. And we should definitely go for microarray testing in each and every case, NT more than 95th centile. And as well as we should save the fetal DNA for further testing. Sometimes patients come with recurrent increase in NT in more than 2 pregnancies, then it becomes very difficult to find out the previous fetus DNA. So we always save the DNA. I recommend to save the DNA in every case because we had patients with recurrent increase in NT where we found 2 single gene disorders also.
Okay. Any other questions?
Doctor, you said in follow-up you did for the children also. Till what age you did the follow-up?
3 months,
After
ma'am.
birth.
3 months postnatal follow-up. Yes, ma'am. That was done by seeing the children.
At 3 months of age, what you were seeing? What you were analyzing at 3 months age?
Their major milestones in terms of, whatever milestone they have achieved, and in terms of
No, in 3
dysmorphism,
months, what milestones? At 3 months, what milestones you expect?
Ma'am, we expect social smile at least, and neck
Mhm.
holding. Neck holding is there, and
3 months neck holding. Are you
yeah,
sure?
ma'am.
3
3 to
months
4
a
months.
baby has.
Yes, ma'am. Yes, ma'am. I'm sure.
But it's after 3 months. That's what I want to emphasize.
3
Not
to
till
4
3.
months, ma'am.
You
But yes, ma'am.
See, be specific. You said till 3 months. That means after 3 months you were not analyzing the children, but neck holding doesn't come till 3 months. So only with social smile you were screening
And
the
facial
children?
dysmorphic features as well as any structural defects, ma'am, like organ defect, cardiac defects, any because in one child we diagnosed complex cardiac defect after the birth, ma'am. That was not diagnosed earlier.
That was missed in level 1 and level 2 ultrasound?
Yes, ma'am. Even
That
on the fetal
means-
echocardiography, ma'am.
That means these what you detected, that abnormality should have been picked up at level 1 and level 2 ultrasound,
Yes,
no?
ma'am. Yes, ma'am. That could have
But
been
it
picked
was
up. But we were always referring the patient for ultrasound and echocardiography to other centers, but they were good centers, but they could miss that TG was found in one child, ma'am. Transposition of great arteries that can be missed in various, ultrasounds also, and fetal echocardiography.
Okay. Thank you.
Okay. Next candidate, please.
Thank you.
Sarika
Moving
Gautam.
on to
Thank you, ma'am and sir.
Thank you, Sangeeta.
Dr. Sarika Gautam. So
Sarika
next,
Gautam,
Dr.
please.
Sarika Gautam. And
Yes, ma'am. Yeah. A very good afternoon. I am Dr. Sarika Gautam. I'm working as a faculty in Pandit B.T. Sharma PGMS Rohtak. So my poster is on the clinical pulse of placenta accreta spectrum, and it was created in the view to provide the one-page bullet point to the trainees, PG trainees, for the deadliest complication which they used to miss. So my material and method were the latest updated clinical guidelines, that is from 2018 to 2020, that is a RCOG, ACOG clinical committee guidelines, as well the Canada Obs and Gynae guidelines. So when I have given these pearls to my students, so they should know multidisciplinary team management is very much required for this approach. We need a senior obstetrician as well as a good radiologist, senior radiologist, to delineate this problem. And this delivery should be planned. If they are getting any referral patient or in a primary patient, so delivery should be planned at high level hospital, and that counseling should be given to the patient with massive transfusion protocol. They should know at the first visit that they may need a large amount of blood at the time of their surgery, and patient should be aware about patient as well as my trainees. They should be aware that elective surgery should be preferred mode of termination of pregnancy. So they have to advise the patient for the elective admission at least in the 3rd trimester. And then there is a suspicion of placenta accreta, then it should be treated as a case of placenta accreta syndrome. When there is suspicion, so it should be treated as a case of PAS if it is not proven otherwise. And patient with clinical risk factor. The clinical risk factor like previous surgeries on the uterus, they should be screened for the placental abnormalities itself at the 18 to 20 week gestational age USG, that is the anomaly scan. And the diagnostic value of USG and MRI when they were screened in the guidelines in the various high literature. So they were having the similar diagnostic value. So in the early antenatal admission should be advised to delay transport time in emergency situation. Cesarean section should be planned at 34 to 36 weeks. Antenatal corticosteroids should be administered before the planned delivery so that the lesser NICU admissions and good neonatal outcome. A senior obstetrician should operate the case if possible, and midline access should be preferred, and uterine incision should be given above the placental edge. Another thing is upon confirmation of diagnosis, if is there should not be any attempt to remove the placenta. This thing is the most important for all the PG trainees and the gynecologists. There should not be any attempt to remove the placenta, as well as in those cases where decision of hysterectomy is taken. When the decision of hysterectomy is taken before taking up of the case. Conservative approach of management, that is, if we are leaving the placenta or peripartum hysterectomy or expectant management, it all depends on the patient's status, desire of future fertilities, and facilities available at the institution. Sorry, the role of intravenous tranexamic acid to reduce the intraoperative blood loss is well appreciated in the American guidelines. And the role to use, whether to use uterotonics or not to use the uterotonics, it is still debatable in cases of peripartum hysterectomy. Thank you.
Dr. Sarika, what is the role of keeping placenta there and then if we are not removing?
So if we are not removing the placenta, so we have to transect this cord at as close as possible, and then we are screening the patient. We are following up the patients for the spontaneous resolution of the placenta. For these cases, if we are keeping the conservative management, we are not planning the hysterectomy. For these cases, we have to do the follow-up, and broad spectrum antibiotic rules are proven. So we have to give the broad spectrum antibiotic, and patient counseling is itself required for this secondary postpartum hemorrhage. If they are having any bleeding or any excessive amount of bleeding, they have to come back to the institution for the follow-up.
And how much percentage is there that your conservative management is successful?
In our institute?
In like generally in your institute, okay.
Okay, in our institute, I have.
Or how many placentas you have kept there and then?
Sir, in my this 5-year data, we have kept 5 patients for the conservative management, but in 3 patients, they have reported back with a secondary postpartum hemorrhage, and they have gone for the interval hysterectomy then.
Okay, so do you think it is the good method to conserve?
Sir, it only depends on the patient's condition. If we feel that patient is not, it all depends on the intraoperative status, preoperative status. If we are feeling that the conservation is going to benefit the patient versus the hysterectomy, then only then we should only try the conservative approach.
Otherwise, hysterectomy, peripartum hysterectomy.
Sir, if the patient is not, if she is desirous of the patient and her intraop status is good, then we can plan conservative hysterectomy and continuous follow-up in the institute.
Okay.
Okay.
I have a question, doctor.
Yeah.
You have said in your poster ki diagnostic value of ultrasonography and MRI are same.
Yes,
So
ma'am.
my question is ki in routine, do you go for MRI for every patient, or you are satisfied with only ultrasonography report?
No, ma'am. In sometimes the ACOG guidelines as well as the RCOG guidelines, they are saying if we are having a expert radiologist, then the matter is different. If we are having a radiologist who cannot differentiate, then the MRI is better approach than the USG. Otherwise, the incidence of the checking for the placenta accreta, USG is having the same sensitivity specificity as for the MRI.
So what are you giving advice to your patient? Your poster is pulse of on.
Yes,
so you must
for
be.
me, I would like to go for MRI. I would like to go for MRI as
now,
well.
my next question is: have you ever you have done conservative approach? Now, have you ever across come the patient again pregnant with the placenta preserved?
No, ma'am, I haven't seen any.
And what the literature says?
In the literature, they are having around 10 to 20% cases which are conceived, but they are having the recurrence rate is also higher in these cases. Recurrence of
so in patients where you have conserved placenta, you have left the placenta, do you do tubectomy side by side then?
No, ma'am. No. When the planning, ma'am, it is not having any role of tubectomy. If we have already planned a peripartum hysterectomy, there is no role to do the tubectomy.
Okay. So, every patient ultimately have to go for hysterectomy?
No, not. I'm not saying. I'm not saying. It depends on the resources available at the institute or the operation in which hospital the operation is going on. It all depends on the.
No, my point is, dear, if you are not doing hysterectomy, you are planned to do the conservative approach, you are planned to preserve the placenta, then what advice are you going to give to the patient for future pregnancy? Well, my question is this. Do you give any advice to the patient after discharging?
Yes, ma'am. Yes, ma'am. Of course, I will give the advice. I will advise to come for the further follow-up in the high-level institution so that we can follow her from the start of the next pregnancy. So whether she is going again for the recurrence of placenta accreta, and if she is having the recurrence, I will advise her the early admission to the institute.
Dr. Sarika.
Dr. Sarika, how much is the maximum period where that absorption of that placental tissue occurs? What is the maximum period?
Maximum, sir, sorry,
it is up to 60 weeks. And before going for peripartum hysterectomy, do you close that cesarean incision, or you go ahead without closing that cesarean incision on the uterus?
Sorry, I can't comment.
You always close. You always close.
I always close, yeah.
You always close before going for peripartum hysterectomy. You close that cesarean incision, then you go for peripartum hysterectomy.
Okay.
Okay, let's go for next candidate. Thank you, Dr. Sarika.
Thank you.
Can we proceed? The next participant is Dr. Renu Yadav. Dr. Renu Yadav, are you here?
Can you hear me?
Dr. Renu Yadav.
Hello.
Yes, please carry on.
Hello.
Yes, Dr. Renu Yadav.
I'd like to present. I'd like to present hysteroscopy, a primary tool in infertility diagnostic workup. The background is that hysteroscopy is a gold standard for the procedure for uterine cavity exploration. However, hysteroscopy is only recommended by the WHO. Yes, sir.
Dr. Renu, please remove your mask. Please remove your mask.
Okay. So, thank you, sir. Okay. Hello.
Yes. Now please.
However, Hysteroscopy is only recommended by the WHO when the clinical and complementary examination like the ultrasound or the HSG suggests that there is intrauterine abnormality. However, many of the specialists feel that hysteroscopy is a more accurate tool for evaluation. So the aims and objectives of the study was a retrospective study to assess the value of diagnostic hysteroscopy in a primary workup of infertility in a population of 550 infertile patients during 27 months from July 2018 to October 2020, in which 174 patients underwent the diagnostic procedure, in which we were using the Karl Storz rigid hysteroscope and using normal saline with Hamau endomat and the xenon light source and a recording system. And we were using a standard procedure to see inspection of the vulva, the vagina, the cervix, the endocervical canal, then the uterine cavity, the endometrium, and bilateral tubal osteal findings. And those findings were recorded. In our result, we found that hysteroscopy was normal only in 12.07% of patients. There were vulval findings in 2 patients, vaginal findings in 3 patients, and many cervico-isthmic abnormalities like a flattening of the papilla, multiple polyps, adhesions were present in 21% of our patients, with cervical stenosis being the most common abnormality. We also had one patient who had a very short cervical canal. The uterine cavity was generally normal in shape in 70% of patients. Observed abnormalities were septate uterus in 26 cases, intrauterine synecdoche in 29 cases, with absolutely grade 4 Ashermans in 1 case, endometrial polyps in 27 cases, and unicornuate uterus in 4 cases. The osteal fibrosis were observed in almost 15 patients. The endometrial abnormalities like fibrosis and inflammation were also observed. Thickened and mucosa was seen in 2 patients. The hysteroscopy was generally in the post menstrual phase. No significant findings were there in when comparing the primary and the secondary infertility. So in my conclusion, I found that abnormal findings in the infertile patients who underwent diagnostic hysteroscopy was almost up to the rate of 87%. And our data suggests that hysteroscopy should be a primary tool in investigating infertile women, and along with other investigations in the primary and the secondary infertility like the HSG and the ultrasound. So it seems to be a very cost effective and comprehensive tool with additional advantage of the direct visualization of the uterine cavity for a workup in primary and secondary infertile patients. Thank you, sir.
Thank you, Dr. Renu.
Thank you.
So I think you are doing hysteroscopy.
Yes,
so hysteroscopy, you are doing hysteroscopy for every patient.
No, sir. We are most of the patients we are advising them, and in which we find in the ultrasound there are more findings. Definitely, we advise them more, and try to do a hysteroscopy on most of the patients.
Most of the patients. Okay.
Yes, sir.
It is office hysteroscopy?
Yes, ma'am.
Office hysteroscopy?
Yeah. It is an office hysteroscopy using the Bertocci.
So, what do you advise? If you find some abnormality from diagnostic, you shift to operative on the same sitting, or you then again call the patient?
No, ma'am, because it is a diagnostic thing, so consent has not been taken. So generally is that we see first and then advise accordingly, and then take a next date for whatever operative procedure is to be done. Because I am doing actually only in injection tramadol. If there is some polyp or some septum or any other operative procedure, the operative sheath has to be taken, and secondly the anesthetist is to be called in. So I generally do it in the next cycle or next month.
So I think
And then you call again.
then I feel.
Yes,
but in
ma'am.
cases, but in
Yes,
cases where you are having a high suspicion of having abnormality and all, then you can go together
sir.
in the first go itself,
Yes, yes, sir.
rather than
Actually,
going
when
for
we
the second?
find, yes, sir. Yeah, when we find absolutely confirmed, like a septum has absolutely been diagnosed by a 3D or ultrasound, in that case, generally we prepare only for the operative part and do the necessary part in the first sitting itself.
Okay. Thank you.
Thank you, Dr. Alok. Thank you,
Okay,
Dr.
thank
Rakhi, and I
you.
thank
Thank
you all
you.
the organizers for giving me this opportunity. Thank you, sir.
Thank you, Dr. Renu. The next participant is Dr. Priya Agarwal, and she will be presenting on pregnancy outcomes after fresh or frozen thawed embryo transfer. Dr. Priya?
Yes, ma'am.
Yeah, please proceed.
Good afternoon, all. I'm Dr. Priya Agarwal, Fellow ART, Vasundhara Hospital, Jodhpur. And I'm going to present a poster titled Pregnancy Outcome After Fresh versus Frozen Thawed Embryo Transfer, a retrospective study. We aimed to compare the outcome in pregnancies conceived after fresh versus frozen thawed embryo transfer with respect to chemical pregnancy rates, live births, and birth weights. Ours was a retrospective study involving 191 patients with fresh embryo transfer and 117 patients with frozen thawed embryo transfers during 1st January 2019 to 31st December 2019 at our institute. Outcomes measured were differences in biochemical pregnancy, that is beta HCG more than 50 milli-international unit per ml, live births, and birth weights between the two groups. The study included females less than equal to 37 years of age and day 3 or day 5 embryos frozen via vitrification. We found a significantly higher pregnancy rate and live birth rates in the frozen thawed embryo cycles than the fresh cycles. The mean birth weight in FET group was slightly higher than the fresh group, but it showed no statistically significant difference. Other studies by VD and Suzanne also demonstrated significantly better outcomes in frozen thawed transfer cycles. However, some studies, like done by Wong, showed no significant improvement in the frozen groups. But it is noteworthy that despite being no significant difference between the two groups, however, they have found a trend towards better outcome in the frozen thawed embryo cycles. We conclude that frozen thawed transfer cycles are associated with significantly better pregnancy outcomes than fresh transfer cycles. Thank you.
Dr. Priya,
Yes,
I have a question for you. You have in material methods, you said you have taken only one criteria, frozen and fresh. Now, what about the similarity of the patients? I mean, there may be some different causes of infertility, na? See, some have a poor ovarian reserve, for some must be used a donor eggs or some other. Have you taken the same patients criteria in both the groups? You have not mentioned it in your poster.
Yes, ma'am. The criteria were similar. Ma'am, donor cycles were not considered in the study. And the patients with very poor ovarian reserve, like antral follicle count 1 or 2, they were also excluded in the study.
So you must have mentioned that these were the criteria which were included and these were the criteria which were excluded, and the patient were almost of the same. My second question is, have you prepared the endometrium in both cases with the same drug? That also you have not mentioned. See, the pregnancy does not only depend on the frozen and natural, na? So if you have to compare these two, you have to keep rest of the criteria same. Then only you can come to a conclusion. Now, what about endometrium? Have you prepared the endometrium in both the cases in the similar manner? That also you have not mentioned, because that also makes a lot difference.
Ma'am, in the frozen cycles, we have prepared the endometrium by starting estrogen right from day 2, and then we continuously monitored the endometrial thickness, and once it was more than or equal to 9 with a good flow, we started with the transfer. While for fresh transfer cycles,
and in luteal phase, you transferred, and then did you give any luteal phase support?
Yes, ma'am. In neutral phase, in both the cycles, we had given estrogen and progesterone support, and that was similar in both the groups.
Okay, and in the fresh, you Also, you given the estrogen, progesterone in luteal phase and in frozen
In
also.
luteal.
Huh?
Yes, ma'am. Yes, ma'am.
Okay.
Dr. Priya, what about the vascularity? I just wanted to ask. What about the vascularity of the endometrium? I mean,
Ma'am, in the frozen cycles, while we are monitoring before the embryo transfer, we monitor the vascularity after giving the estrogen support, like from day 10. And once the vascularity reaches grade 3 or grade 4, then we plan for embryo transfer. Similar is the case with fresh cycles.
thank you. Any other questions, judges, please? So,
No, thank you. No, thank you.
So moving on to the next poster, Dr.
Thank you.
Vaishali Verma. Dr. Vaishali Verma, you are around. So the next
Yes, ma'am.
he will be presenting on 3 consecutive ectopic pregnancy after intrauterine insemination, a rare case report. So please proceed, doctor.
Good afternoon, everyone. I am Dr. Vaishali Verma. I am second year postgraduate student in SGT Medical College, Gurgaon. Today, I'll be presenting my poster on the title 3 consecutive ectopic pregnancies after intrauterine insemination, a rare case report, under the guidance of Dr. Aditi Narayan ma'am. She is an assistant professor in my institute. So, ectopic pregnancy is one of the most commonly encountered obstetric emergencies with the incidence of approximately 2% of all pregnancies. It has been observed that its incidence is increasing after infertility treatment. The chance of a repeat ectopic in a woman with history of 1 ectopic pregnancy is approximately 10%, and after 2 ectopic pregnancies, it is approximately 30%. So the case I'm presenting is of a 31-year-old lady. She's gravida 6, para 0. She's been married for 10 years with history of 3 first trimester abortion. Last was in 2015. After that, she tried for spontaneous conception, failing which she started taking infertility treatment in 2017. She ultimately had an intrauterine insemination done twice in some private clinic in Gurgaon, each resulting in ectopic pregnancy. Both were in alternate tube. Last was 1 year back. They were both managed medically. Presently, she was admitted in the SGT hospital with history of mild abdominal pain, spotting per vaginum, on and off since 2 weeks, and her UPT urine pregnancy test was done, which came positive. There was no history of amenorrhea or ovulation induction, use of any contraception, or any abdominopelvic surgery. On examination, patient was calm, conscious, and cooperative, and well oriented to time, place, and person. Her vitals were stable. On per abdominal examination, tenderness was present in bilateral fornices and in the hypogastric region, and there was no guarding and there was no rigidity. On per vaginal examination, os was closed, uterus was normal size, fullness was present in the right fornix, there was cervical motion, tenderness was present. So we made a diagnosis of right ectopic pregnancy. Since the patient was hemodynamically stable, we went for a transvaginal ultrasonography, which showed that the uterus was empty and there was bilateral unruptured tubal gestational sac with no cardiac activity. Patient was managed laparoscopically and the specimens were sent for histopathological examination, which confirmed bilateral tubal gestations. So yes, bilateral tubal ectopic pregnancies are very rare and they are increasingly seen after assisted reproductive techniques, mostly incidence of 2.2 to 4.5%. Ectopic pregnancies can be life-threatening, so thus early diagnosis and timely management is necessary. And cases which are presenting with subfertility and ectopic pregnancy should be followed up to prevent morbidity and mortality. Thank you.
Dr. Vaishali,
Yes, sir.
do you feel that something better could have been done in the first instance itself? When the IUI was done, was
Yes.
she seen for the
Yeah.
diagnostic laparoscopy,
Yes.
hysterolaparoscopy was done? She had 3 abortions earlier.
Yes, sir. Sir, earlier, the both ectopic pregnancies were not treated in our institute. She came to us for the first time.
According to you, what could have been done?
Sir, since patient has no live issue, we always think of, and the patient is only 31-year-old, we always think for the fertility first if patient wants. But yes, if there is contraindication to manage conservative management, then we have to go for surgical management.
No, you are not understanding the question, dear.
No.
The patient had an
Yes, ma'am.
You could have been evaluated by the tester or laparoscopically before going for IUI in the first instance itself. She had 3 abortions earlier.
Yes, sir. After 3 abortions, she went for IUI, and because after that IUI, that pregnancy was tubal pregnancy.
Can I ask a question? Hello?
Yes, ma'am. Yes,
Okay.
ma'am.
Dear, what I want to know is, do you think 2 times ectopic pregnancy after 2 IUI, she was advised 3rd IUI? Was it okay?
No, ma'am. Only
I just want to
twice
know your
IUI
opinion.
was done.
Yeah.
This time,
Then it was.
there was
And
no.
both were ectopic.
Yes, ma'am.
Both were ectopic, na? In both they were ectopic.
Yes, ma'am.
Now 3rd time
Yes, ma'am.
also she went for IUI. Was it okay? You are satisfied with that thing? If you
No,
were the
ma'am. No,
treating
ma'am.
doctor, you would have advised her IUI, or you would have
No,
not
ma'am.
advised, or what you would have done? If she would have come to you with the 2 ectopics with 2 IUIs, now she wants to conceive, what you would have done?
Ma'am,
Okay, next. Okay, tell me, what is the recurrence rate? What is the recurrence rate after 1 ectopic? How much is the increased rate for 2nd, and how much is in if 2 ectopics? How much is the rate increase for 3rd?
Ma'am, after 1 ectopic, it is 10 to 15%, and after 2 ectopics, it is 30%.
30.
And multiple ectopics are very rarest.
And you said the after ART incidence of ectopic is more. Do you think IUI was the cause of the ectopic?
Yes, ma'am, it can be. Because in ART, we do ovarian hyperstimulation syndrome can occur. And mostly, if ARTs are done, they are usually due to infertility after primary or secondary. So there can be additional cause behind if the patient was previously treated for PID or there was any tubal.
Okay, thank you, Dr. Shali. Let's move to next candidate.
Thank you, ma'am.
The next candidate is Dr. Kavisha. She will be talking about the role of lymphocyte immunization therapy in recurrent pregnancy loss and recurrent implantation failure.
A very good afternoon to everyone. I'm Dr. Kavisha Lambate. I'm an IFS fellow in clinical ART at Wings IVF Hospital, Ahmedabad. The title of my e-poster is The Role of Lymphocyte Immunization Therapy in Recurrent Pregnancy Loss and Recurrent Implantation Failure. Both the conditions are being an important and problematic conditions for couples undergoing IVF cycles as well as natural cycles. The main causes are reduced endometrial receptivity, embryonic defects, it can be multifactorial, and as well as immunologic abnormalities. So lymphocyte immunization therapy can be a hope for women suffering with unexplained RIF and RPL. So the purpose to present this poster is to present cases of active immunization with lymphocyte immunization therapy to prevent these conditions. So the case number 1 is 28-year-old with secondary infertility with history of 4 spontaneous abortions followed by 4 IUI failure. All her investigations like hormonal profile, semen analysis, APLA, and karyotyping was normal. And we planned IVF, and we got about 9 embryos, out of which 4 were PGS normal. Followed by hysteroscopy was done, ERA was done, then lymphocyte immunization therapy given, and patient undergone single embryo transfer. And then after that, she was conceived and delivered an healthy baby. So this is a case of recurrent pregnancy loss. And the case number 2 is 35-year-old with primary unexplained infertility of 6 years. So after investigating her, we planned her IVF, and out of which 4 embryos were formed, out of which 2 were PGS normal. Then hysteroscopy was done, then FET done with day 5 transfer of 2 blastocysts, but patient did not conceive. After that, scratching was done, and followed by laparoscopic myomectomy and hysteroscopy and ERA, followed by 2 cycles of FET done with donor oocyte, out of which in 1 cycle she was conceived but spontaneously aborted. After that, she was planned for lymphocyte immunization therapy, and then FET with donor cycle of good quality embryos was done. Patient conceived and delivered a healthy baby. So this demonstrated a beneficial effect of LIT on improving the live births in RIF and RPL patients, especially if there were more than equal to 4 ART or natural cycle failure. So the conclusion of this is immunization with partner lymphocytes can be a treatment option for RPL and RIF patients if all other causes have been ruled out. Thank you.
Dr. Dr. Kavisha, huh? Yeah. Okay.
Yes, ma'am.
Tell me what you have telling the beneficial effect. Now, what is the disadvantage of using this therapy? Is there any disadvantage?
Ma'am, the cost is the main issue behind this.
How much is the cost?
Around, ma'am, it can charge around 50,000-60,000 around the patient charge, and
that is the main. Otherwise,
very less likely adverse reactions have been there, but the chances are less. As before this, we undergone the patients of HLA cross match of both the partners, so the chances are less, but they are still there.
What disadvantage could have? Any disadvantage, you know, what could have been?
Immunological rejection or any,
Okay.
What was the route you adopted?
Intradermal.
Intradermal.
Yes, sir.
Otherwise, what are the other routes available for LIT?
Sir, it can be
It can be
IV.
given intramuscular also, intravenous also.
Any other questions?
No, thank you.
Dr. Kavisha, just a quick question. How many sittings of lit therapy was given? Both the patients?
2 sittings of around 4 weeks gap.
Okay, thank you. So moving on to the next presenter, Dr. Jatinder Singh. Are you around, Dr. Jatinder Singh?
Yes, ma'am.
So Dr. Jatinder will be presenting on prediction of candidate genes for male and female infertility.
Is my screen visible?
Yeah.
Okay. Good afternoon, everyone. My name is Jatinder Singh. I'm a research fellow from Guru Nanak Dev University. Today, I'll be presenting my poster titled Prediction of Candidate Genes for Male and Female Infertility and In Silico Study. It has been observed that chromosomal aberrations are one of the main genetic causes of male and female infertility, among which structural aberrations may disrupt the functioning of various genes, some of which may be important for infertility. It is known that most diseases are caused by defects in multiple components interacting in a biological cascade. Therefore, it is imperative to characterize the protein interactome networks that may be responsible for that particular disease, in this case, infertility. Therefore, keeping these points in mind, we aim to identify candidate genes for research on male and female infertility from cytogenetic data using in silico approach. For this purpose, we already had the data of cytogenetic data regarding the frequency of chromosomal aberrations in infertile patients and healthy controls from the Punjab region via peripheral blood lymphocyte culturing and karyotype analysis. And therefore, we wanted to know whether certain genes were responsible for the increased frequency of chromosomal aberrations. For this purpose, we carried out a bioinformatic analysis to predict which genes might be responsible for the observed increased frequency of aberrations. After the analysis of cytogenetic data, it was observed that there was a high frequency of aberration in the infertile patients, both male and females, in certain chromosome loci, such as chromosomes 1, 2, 5, 6, 8, 10, 17X in both males and females, and Y in case of males only. In the CBI database, we identified that these loci harbored 1,367 genes, and further, we carried out a network analysis. Using this, we identified a network of 107 genes as shown in figure 1, which interacted directly. Further, we conducted a literature review to identify which genes have already published associations with male and female infertility. Using this data, we isolated 2 subnetworks specific for male and female infertility as shown in figures 2 and 3. Further, we carried out pathway enrichment analysis to identify which pathways might be responsible for the observed infertility and the observed increased chromosomal aberrations. Using this method, we observed that the nonsense-mediated decay pathway was enriched within males, and the FcRI epsilon pathway was enriched within females, and the RNA polymerase pathway was enriched within both the males and females. The genes that we found to be enriched within the pathways have only been studied in mice model with few to no reports on how they affect human fertility. These pathways can serve as candidates for further research on infertility. Now we have got the cytogenetic data from the patients, and we still have the sample, so we can check whether variants in these identified genes are responsible for the observed infertility and the chromosomal aberrations. Thank you.
Doctor, I have a question. What is the practical implication of this study? How will this study help practically?
So the patients that we checked for the cytogenetic aberrations were mostly those couples who were trying to conceive via IVF. And most of these couples were not even able to conceive, despite even some were not even able to conceive after 4 cycles of IVF. So we wanted to see whether certain genetic variants were responsible for the failure of those IVF procedures. So we observed that compared to healthy controls, the infertile patients had a very high frequency of chromosomal aberrations. So
that I've come to know from your poster. What I want to know is, you will advise after 3 cycles or 4 cycles of IVF, if patient is not conceived, you will advise this genetic mapping, chromosomal
genetic testing. So through this, we have
and how will it affect it? How will this testing will help in their future treatment of infertility?
So we have predicted these genes. So through further testing, through further research, because we still have the samples, we can check whether those variants are present in more amount in the infertile patients. So through that, we can, if we get any significant results or significant associations, we can advise that these may be used in testing, genetic testing, so that if certain variants were found, so we can say that the IVF may not be successful for those patients. So we can advise them not to go for any certain procedures, and and we can say that to check for the IVF, to check if these variants are not present, so we can say that they can go for IVF.
Okay, so you will say those patients that don't go for further IVF, huh? Okay.
Yes, ma'am. Yes, ma'am.
Okay. In your study, all the patients were those who had gone for 3 IVF and then failed?
No, ma'am. Most of the patients were those who had gone for at least 2 cycles of IVF and had not conceived despite that. Some patients were there who had not conceived despite 4 cycles.
And how did you manage to make the balance and rule out the other causes of in those patients? Rest other things are very normal, and only the cause was found was this. You mean to say, huh?
No, ma'am. We considered both cases of primary and secondary infertility. In most cases, in some cases, it was found that either the females had some abnormalities like tubal blockages, or any other. In the males, we found some had seminal parameters. But in most cases, there was no reason found, and they were classified as unexplained infertility. So we carried out this analysis.
Infertility, huh? Okay.
Yes, ma'am.
Okay. Thank you.
Thank you, ma'am.
Thank you.
Coming to our last. Any more questions,
No. Last.
Okay. So coming to the last presenter, Dr. Chandana, she will be presenting on double ectopic pregnancy dual management, and she'll be telling us about management.
Very good afternoon to everyone. I'm Dr. Chandana, MCH resident from Sri Ramchandra Medical College, Chennai, who will be presenting a case report on double ectopic pregnancy dual management. So here I'm presenting a very rare case where there was a concurrent tubal with an ovarian ectopic pregnancy following an ovulation induction drug with ovulogens. The main interesting part of this case is that when there is an ipsilateral ovarian with a tubal ectopic, it's actually a diagnostic challenge. So first of all, the incidence of this double ectopic is unknown. It's very rare to get an ipsilateral ovarian as well as a tubal ectopic. And if we get such a situation, it is really a challenge to diagnose it. Now coming to the history, she presented to us with this history. Mrs. X, age 30 years, with a married life for 1 year, 3 months. She is a PCOS phenotype A. She came to us with all these history. In January 2020, she took ovulation induction drugs with aromatase inhibitors and gonadotropins. She developed 5 dominant follicles. It was basically planned for a natural relation cycle. 5 weeks later, she presented to the same hospital with complaints of pain, abdomen, and spotting. They diagnosed a left tubal ectopic, which was because of free fluid in the abdomen and a serum beta HCG of 6,500. She was taken up for emergency laparoscopy. There was a ruptured left isthmic ectopic. Left salpingectomy was done, and the histopathology was consistent with the tubal ectopic. Now she came to our unit 4 weeks later with a history of pain, abdomen, and spotting. And on ultrasound, we detected a left ovarian ectopic pregnancy with a CRL corresponding to 8 weeks with a serum beta HCG of 44,179 milli-international units per mil. She was treated with ultrasound-guided intersac therapy, and following that, within a matter of 65 days, that is approximately 2 months, her beta HCG was 3 milli-international units per ml. What is the main learning point from this case is that definitely the incidence of, there is a higher incidence of multiple pregnancy whenever we induce her with either oral ovulogens or gonadotropins. But definitely we have to keep this, that there can be an increased chance of even multiple ectopics when we treat her with ovulation induction drugs. And apart from that, even when we do a definitive management for an ectopic, maybe there is a role for serial follow-up with beta HCG, so that in such rare instances wherein there is a possibility of another ectopic, maybe we can pick it up early and treat her. Thank you.
Doctor, क्या नाम?
Dr. Chandana.
Yes, sir.
Dr. Chandana, what are the features or signs when you say it is an ovarian ectopic?
Sir, on ultrasound, so basically previously it was a histopathology based criteria, which is Spiegelberg. Now to detect it on ultrasound, there are ultrasound based criteria, which is presence of a hyperechogenic ring with hypoechogenic contents, with definitely a fetal pole, which is diagnostic with a yolk sac. Fetal pole with cardiac activity is diagnostic, but definitely the follicles surrounding the gestational sac with a Doppler, which is showing peripheral vascularity, ring of fire, which can be confused with the corpus luteum, but definitely a hyperechogenic sac is a very characteristic of an ovarian ectopic.
And what is the incidence of this?
Sir, ovarian ectopic, individually, the incidence is 1 in 7,000 to 1 in 60,000 pregnancies. But a concomitant ectopic, the incidence, like with tubal and ovarian, the incidence is unknown. It's a very, very rare phenomena.
Okay.
Dr. Chandana.
Yes, sir.
You told that left ovary is normal when you dealt with that isthmic pregnancy. So
yes,
how it can be that having a pregnancy and it's absolutely normal?
Sir, they have, when they've done a scan, they have seen that there was a corpus luteum. That's what they have told. And intraoperatively, there was absolutely no mentioning of the appearance of that, whether they could see any ectopic, because all this was done at a local hospital, and she came to us with these reports. And the report just had that it was a left tubal ectopic, and only she had a scan report which said that there was a corpus luteum in the left ovary.
She had a married life of only
Yes, sir,
3 months.
just 1 year,
She
3
went
months.
into ovulation induction with estrogen inhibitors, gonadotropins and all. She had more than 5 dominant, she had that 5 dominant follicles. Still, she was left for that natural cycle.
Yes, sir, she
They
was
should
left
have
for a
been
natural
cancelled
ovulation.
cycle, or she should have been taken for that. That is wrong. She should
So
have
your
been
voice is
taken
not
for
very clear,
either.
sir. Sorry.
She would have been cancellation. She would have been that she should not have been left for natural cycle. That there should have been that cancellation of the cycle. With more than 5 dominant follicles.
Time now. I'm sorry to interrupt. We are running short of time. Sir, you.
Okay, no questions from my side. Thank you.
Is there any other question?
No.
Okay.
Okay. So thank you so much, everyone. It was a wonderful session. Thank you, judges, for taking out time for this session. And thank you so much, all the presenters. It was a wonderful, wonderful posters. The result will be announced in the valedictory function. And thank you so much, everyone. Dr. Shikhar, anything else we need to do?
Yeah, Bess, I just wanted to thank our esteemed judges for sparing out their precious time. And I want to thank our main coordinator, Dr. Shalini, as well. Thank you, ma'am, for your kind guidance.
Hi, everyone. I welcome you all to this Fertivision 2020 and hoping for great success of this conference. And today we have this oral paper presentation session. So first of all, I want to invite our esteemed judges. So first of all, I'll just share my screen. Yes.
And just click on the share screen button.
Yeah, I'm clicking, but my window is not opening. I don't know why. Something else.
Yeah, ma'am, we can see your screen. And we can see.
You can see my screen? Okay, just
no,
a second.
No, ma'am.
Okay, anyway, my screen is not opening, but I'm inviting our judges for today, Dr. Saroj Kumar Madam, Dr. Kiran Arora Popley, and Dr. Madhu Nagpal from Amritsar. And now I invite our first presenter, Dr. Giraj Swaranka, with abstract number 6 and title, Results of Endometrial Receptivity Analysis and Reproductive Outcome in Patients with Recurrent Implantation Failure. So Dr. Giraj, to please start.
Okay. Yes. Good afternoon, everyone. I am Dr. Giraj Prasad. Am I audible, ma'am?
Yes, you are.
Yes, thank you. First of all, I would like to thank the team Fertivision 2020 for providing this opportunity. I am Dr. Giraj Prasad from Mansal Hospital, Department of Reproductive Medicine, Bhopal. As we know that many of the patients who undergo IVF does not get pregnant despite transferring good quality embryos. So the good quality embryos is an important factor, but another important factor is the uterus, which is ready to receive the embryo. And the third thing which we need to give consideration is the timing of the embryo transfer, which must coordinate with the menstrual cycle for the that phase. So for most of the women, the best time of transfer is the same, but in some patient it may be different. When talking about recurrent implantation failure, there is no uniform consensus over the definition. Various authors have given various definition in different literature. So according to Collin et al., failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycle in a woman under the age of 40 years. So factors which we have discussed embryo, which include the gamete factor, the culture condition, and the environmental factor, and the maternal factors, which include the anatomical factor, the endometrial factor, and the genetic factors. So we have discussed about the endometrial receptivity and window of implantation, which opens 5 days after the endogenous or exogenous progesterone action and then closes 2 days later. So how we will evaluate this endometrial receptivity? Various methods have been given in the literature, that histology by Noyes et al. That is used for a long time, immunohistochemistry, ultrasound Doppler with the endometrial thickness and the blood flow indices of subendometrial blood flow and uterine artery indices, the microbiota and the omics. We in our study have evaluated endometrial receptivity by the test named endometrial receptivity analysis. This test is basically based on a molecular profiling of the tissue, and it identifies the transcriptomic signature of the receptive endometrium. And it consists of a customized array of 248 genes that are expressed at different stages of the endometrial cycle. Results are analyzed using a computational predictor using a principal component analysis. This test has a very good sensitivity and specificity of about 99 and 88%. And Garrido Gomez et al. In 2013 had demonstrated the reproducibility of this test over a long period of 3 years, and Rius Alonso et al. Has suggested that when correcting the window of implantation by doing personalized embryo transfer in such patients of recurrent implantation failure subgroup in endometrial factor is the cause, then reproductive outcome can be improved. So this study was conducted in Department of Reproductive Medicine, Bansal Hospital, and endometrial factor was evaluated from July 2016 to July 2020. Apart from routine infertility workup, a mandatory hysteroscopy and 3D TVS and couple karyotype were done for all the patients and were normal. In inclusion criteria, we have included patients with previous 2 IVF cycle failure with morphological good quality embryos, which was documented in the summaries, or we have the pictures of the previous embryos, and patients who consented for ERA. And in exclusion criteria, patients with uncorrected uterine and adnexal pathologies were excluded. So endometrial biopsy was taken in a hormone replacement cycle. TVS was day 2. TVS was done to check whether the endometrium has shed properly or not. After that, patients were started on estradiol valerate in a dose of 6 mg per day, and that was continued till an appropriate thickness of more than 7 mm was obtained. Progesterone was started in the form of vaginal progesterone gel once daily at night, and injections suggest 100 mg, that is micronized progesterone, every alternate day for a period of 5 days. After 5 days, on day 6 morning, endometrial tissue was obtained with the Pippel's catheter, and it was transferred to a cryotube containing 1.5 ml RNA stabilizing agent, and then kept at 4 degrees Celsius in refrigerator for 4 hours, and then was transported to iGenomics India. The test results were available in 2 weeks. In their methodology, they have described that they, after endometrial biopsy, they extract the RNA from the tissue, and this RNA was analyzed and further then classified. The endometrium was classified depending by the ERA predictor as receptive or non-receptive. And in cases of non-receptive endometrium, a personalized window of implantation was defined for such patients. So usually 2 good quality embryos were transferred after the ERA results. In our study, we have included 34 patients which had a history of recurrent implantation failure. Out of that, a total of 21, that is 61.8% patients showed receptive endometrium, and 38.2%, that is 13 number of patients showed a non-receptive endometrium. And in non-receptive group, majority of the patients showed a pre-receptive endometrium, that is 11 patients showed out of 13 a pre-receptive endometrium, and only 2 patients showed post-receptive endometrium. Blastocyst transfer was done in 25 patients out of these 34 patients, and a pregnancy was achieved. 16 were in the receptive group and 9 were in the non-receptive group. So pregnancy was achieved in 11 patients in the receptive group, and 5 patients in the non-receptive group. In receptive group also we simulated the same cycle which we have followed in the ERA cycle, and the miscarriage rate was 18% and 40%. So in non-receptive group, when we compared the total pregnancy rate with it in the same duration of our IVF population, so it was comparable. So in endometrial receptivity at the time of window of implantation is a crucial moment of the menstrual cycle, and its understanding has been one of the main goals for researcher working in human reproduction. In our study, although the number of the subjects were limited, but we found that 38.2% of patients with RIF showed a displaced window of implantation. These similar results were shown in the previous studies by Ruse Alonso, by Dr. Nalini Mahajan and Hashimoto et al. In 2017. The strength of our study that majority of the
sorry, Dr. Gyas, to interrupt you, but your time is almost over. You're left with 40 seconds. Yes.
I'm almost done, ma'am. The limitations for small sample size and invasive nature of the cost. To conclude, the displaced window of implantation is one of the reasons for RIF, and around 2/3 of patients with history of RIF had other factors also. So directly jumping on ERA and expensive test, we must check for the other factors firstly. And there is a subset of patients with RIF who can achieve a pregnancy rate as good as the general population with personalized embryo transfer based on the ERA results. So ERA can be recommended to such patients. Thank you.
So now I request our judges to kindly take over, and if you have any questions.
Okay, I'm Dr. Saroj. Dr. Giriraj, your presentation was good, and I want to ask you, we are taking biopsy on 5th day of HRT cycle, and receptive or non-receptive endometrium report found after 2 weeks. That means total on 19th day of the cycle. So yes, we are getting after this we are getting 13% more pregnancy rate. Okay, so at what time we are doing personalized embryo transfer?
Ma'am, we are doing in the frozen cycle.
At on which date? Day.
Ma'am, again we will start
on the same cycle or in the next cycle?
In the next cycle, ma'am. We will do a frozen transfer. Yes, ma'am.
Okay. Good. Okay, thank you.
Thank you.
We can start now next.
Hi, I'm Dr. Kiran. Can I just ask you, do you believe that on the basis of your study, is it a good idea to let women have recurrent failures before you offer ERA, if ERA is, predictably so good in preventing miscarriage or failure of implantation? Should it become a standard of care for every woman who's going through IVF?
No, ma'am. Actually, what my study is saying that there is only 1/3 of patients are the endometrial factor is responsible in 1/3 of patients of
1/3 is quite a lot of women, isn't it?
Yes, ma'am. So firstly, we should rule out if the embryo conditions were not good, and we should rule out other factors like endometrial polyp or submucosal fibroid. Those factors, if we have ruled out,
that would be taken care of in the first cycle, isn't it? It's not after recurrent implantation that you would look for polyp or obvious thing, isn't it?
Yes, ma'am.
So my feeling is if it was so huge, 1/3 displacement.
Yes, ma'am. So we should advise if other factors have been ruled out, then we should advise. Ma'am, your voice is broken. Sorry.
No, I wasn't speaking. So it gives me a feeling that ERA and I'm sorry. Can you hear me?
Yes, ma'am. Yes.
I'm sorry. Yeah. Then probably, what is the additional cost of ERA?
Ma'am, it is 40,000.
Yeah. And women probably spend around 1.5 to 2.
1.5 for IVF, yes, ma'am. So, yeah.
And ERA is, unless probably there is a reason to subsidize it and then offer to everybody if actually it helps in implantation. Why should anybody have a failure first and then go for ERA? That's my feeling. Okay. Considering that 1/3 of women are this thing.
Yes, ma'am.
From what I know more studies are needed, but
yes,
not all the studies have shown an effective an effect in this way. Changing the day of transfer based on ERA, isn't it?
Yes,
in fact, very few studies a lot of studies don't support it. So we have a long way to go.
Interrupt
Yeah,
Dr.
yeah.
Kiran, but the time is over for this.
Yeah, sure.
Thank you, ma'am. Thank you.
So we are moving on to the next paper, next presenter, that is Dr. Anita with her abstract number 40 and titled Role of Intrauterine ABCD-TM on Clinical Pregnancy Rate in Patients with Recurrent Implantation Failure. So Dr. Anita, to please take over. Dr. Anita, are you here?
Yes.
Yes.
Hello.
Yes, yes, you're audible and we can see your screen.
Okay.
Yeah.
Oh, I can start now.
Yeah, you can start.
Okay. Good afternoon, everyone. I am Vasanthi Palanivel, Scientific Director, Sarajan Biotherapeutics Private Limited. I am here to present the results of our study, Role of Intrauterine Autologous Blood Cell Derivative, which is ABCD, on clinical pregnancy rate in patients with recurrent implantation failure. Repeated implantation failure due to suboptimal endometrial lining is a major challenge in reproductive medicine, and thin unresponsive endometrium is hard to manage. And if all available treatments fail, then surrogacy is a reasonable option. So PRP is a new model treatment, which is platelet-rich plasma for thin endometrium, and gaining attention of IVF experts. Efficacy of PRP is attributed to biologically active growth factors that the platelets secrete, including pro-regenerative, proliferative, angiogenic, chemotactic, and anti-inflammatory, anti-apoptotic activity. For example, a leukocyte-rich PRP will have a pro-inflammatory biochemical environment, which is characterized by a high protease activity, which decreases the effectiveness of growth factors and regeneration process. And also specifically infertility, embryo implantation, and pregnancy favors only anti-inflammatory environment. A thorough knowledge of the classification of PRP should help experts better understand this new therapy, where the efficacy is based on the specialty and the specific condition. This forms the basis for developing ABCD, a cell-free, implantation-friendly, anti-inflammatory growth factor concentrate exclusively suitable for IVF. So recommending surrogacy is going to get incredibly harder with norms getting stringent, and fertility experts are going to be under immense pressure than ever to turn their patients into parents. So in infertility, every event is time bound, and to avoid cycle cancellations, we need fast acting solutions that will accelerate the tissue regeneration. So what is ABCD? ABCD is very different from conventional PRP. And this is created after a lot of research and innovation, which is a ready-to-act cell-free platelet derivatives as against a cellular concoction in a buffy coat or crude PRP preparation. It is well-standardized protocol and process innovation, and implemented over thousands of procedures, and multiple doses can be created at once with a shelf life of up to 24 weeks at cryo storage or minus 20 degrees. So this particular preparation has been evaluated at across multiple centers. So our objective of this study is to evaluate the effectiveness of this particular variant of PRP for improving endometrial thickness and receptivity of infertile women with recurrent implantation failure undergoing IVF, ICSI, FET at Miracle Advanced Reproductive Center, Chennai, Tamil Nadu. This is an IEC approved single arm self-controlled study, and data collected for the period of October 2018 to October 2020. 117 patients with 2 to 3 failed IVF cycles with ET less than 7 were included, and endometrial pathology and bacteriological screening positive patients were excluded. So this is how the preparation goes. So after obtaining the informed consent,
on menstrual cycle day 5, 6, or 7, any of these days, 30 ml blood will be prepared from the collected from the patient, and then 3 doses of 0.8 ml of ABCD will be prepared. The first dose, which will be instilled with IUI catheter on the same day, and dose 2 and 3 will be frozen for future use. So second dose will be instilled after 5 days of the first installation, and dose 3 will be instilled 2 days before embryo transfer. So clinical pregnancy will be determined by positive HCG and 2 weeks after ET, and determination of fetal heartbeat in transvaginal ultrasound 5 weeks after embryo transfer. So out of 117 patients, we found 57 patients became pregnant. 3 patients were lost to follow-up, and 3 patients' cycle was cancelled due to no improvement. Clinical pregnancy rate was 54, which is 46%. So 50 patients did not conceive, and out of 54 clinical pregnancies, 12 women had a miscarriage before 12 weeks, and 27 patients delivered healthy babies, which is 23% live birth rate. And 15 patients, which is 13% of the patients, the pregnancy is ongoing, uneventful pregnancies are ongoing. And there were 0 side effects recorded. So it is demonstrated that the use of autologous platelet and growth factor based therapeutics improved the implantation, pregnancy, and live birth rate of the patients with refractory thin endometrium and implantation failure. As the diagnosis of implantation failure is always tentative, direct clinical efficacy of ABCD in this indication is difficult to assess, but these studies highlighting the need for anti-inflammatory environment creation for successful implantation. And this is because ABCD is standardized to contain 6 to 8-fold higher amounts of growth factors than the physiological level. The implantation friendly anti-inflammatory cytokines helped, and also the regenerative growth factors, which are more higher in the concentration, helped the entire tissue remodeling and regeneration. So this data motivated us to start a multicentric trial, which we have already registered with CTRI, and more data we will be able to present it in 6 months, publish it in 6 months. Thank you. So now I request our judges to take over.
Okay, Dr. Anita, I'm Dr. Saroj.
Yes, ma'am.
And I want to ask role of ABCD, yes, autologous blood cell derivatives in patients with recurrent implantation failure, and pregnancy rate is only 49%. How much endometrial thickness increased after 3 doses of this? You prepared the plasma, and autologous cells derives in study used only, I think, IUI failure patients only, not in IVF failure patients. Can we take IVF failure patients also in this study? And is it necessary to insert 3 times these cells in endometrium?
Yes, so this study, actually the pilot study and the validation of the product started in 2016 and 17. We have started with a single dose and multiple volumes, the dosage volume, everything we have standardized, and we found the maximum pregnancy rate and minimal miscarriage rate and a very good live birth rate was found when we have given 3 doses, and especially 1 dose 2 days before embryo transfer helped a lot of implantation failure patients to conceive. This is with more than 3 cycles failed patients with very good quality embryo. And with the answer to your first question is, we have seen on an average 1.6 mm than the pre-treatment thickness is improved.
Okay.
I request our judges to kindly make it fast.
Dr. Kiran, okay, hand over to Dr. Kiran.
Dr. Madhu, ma'am.
Yes, I'm here very much. Well, there is a question from my side that you say about 50 patients did not conceive. So can you try it again in the subsequent cycle?
Yes, ma'am. We have recruited them in the next cohort study. So we will be submitting the results, publishing the results.
So what is the maximum you can try 2 cycles, 3 cycles?
We have tried up to 3 cycles. In few interesting case studies, patients who had 9 times failed IVF, they improved after 2 cycles, and in the 3rd cycle, which is their 12th IVF cycle, they conceived and delivered.
Okay, so how you counsel for the cost effectivity of this time and again?
Yes, ma'am. But again, when with respect to the cost of surrogacy, this is much lesser.
Okay.
Yes.
So we would be very happy to know the results even after 2nd try or the 3rd try. And then know what is the maximum number of tries you can do in it. Otherwise, good attempt, very nice. Thank you.
Yes, thank you, ma'am. Yeah,
Thank you, Dr. Vasanthi. So now we move on to the next presenter, Dr. Rashmi Yogesh, with abstract number 43, and her title is Autologous Stem Cell Therapy for Thin Endometrium. Dr. Rashmi, please take over and share your screen. Dr. Rashmi?
She's here.
Can we, if it is taking time, can we move on to the next presenter?
No, Dr. Rashmi is on.
Dr. Rashmi, yeah, Dr. Rashmi is here.
Hello.
Hello, Dr. Rashmi, please share your screen.
Dr. Sukriti, there is some issue with her network. Can you forward?
Can you hear me?
Yeah.
Hello.
Yeah. Yeah, Rashmi, should we move on to the next? Okay, Dr. Rakhi, are you here? Dr. Rakhi Rai, Dr. Rashmi can present after you. Dr. Rakhi, are you here?
Hello. Hello.
Yeah, is it Dr. Rakhi?
Yeah, I'm Dr. Rakhi.
Yeah.
Just give me a minute to share my screen.
Yeah, it's okay. So Dr. Rakhi's abstract number is 55 and her title is Assessment of Tubal Patency with Selective Chromoperturbation at Office Hysteroscopy versus Modified Mini Laparoscopy in Infertile Women under the theme Endoscopy. Yeah, so Dr. Rakhi is starting. Yeah.
Hello.
Yes, Dr. Rakhi, please start. We can see your screen.
Okay. Good afternoon, ma'am. Today I will be talking over the assessment of the tubal patency with the selective chromoperturbation at office hysteroscopy versus modified mini laparoscopy in infertile women. So as we all know, the tubal factor is the leading cause of the female infertility, and till date, the diagnostic hysterolaparoscopy with chromoperturbation is considered to be the pivotal one for the diagnostic evaluation. But there are certain risks which are associated with the use of the laparoscopy in the form of risk of general anesthesia, the safety, the risk of adhesion formation in the long term, and the possibility of the trocar site herniation. But the office hysteroscopy can help us to replace all these associated risks of the laparoscopy for if only the assessment of the tubal patency is required in patients with the infertility. So far, none of the study has compared the assessment of the tubal patency with chromoperturbation on office hysteroscopy versus a mini laparoscopy. The various studies have been done which have compared tubal patency with chromoperturbation with the laparoscopy. Here in 80 patients of 80 infertile patients, they were recruited who were posted for either hysterolaparoscopy where the tubal status is not known or with the confirmed corneal block on the HSG, and patients with the confirmed hydrosalpinx on the HSG or confirmed tubal blockage on the previous laparoscopy or acute inflammatory disease, pelvic inflammatory disease, they were excluded. The procedure was performed between the postmenstrual date 5 to 10. First, the patient patient underwent the office hysteroscopy using the 2.9 mm telescope without anesthesia via vaginoscopic approach without any cervical dilatation. The uterine cavity and the tubal ostia, fundal contour, cervical canal were assessed Then the diluted methylene blue dye 2 to 10 ml was injected slowly, and each tubal ostium was assessed separately. The eddy current of the blue dye, that is a visualizable flow at the ostium, and the disappearance of the blue dye from the uterine cavity to the ostium was documented as the evidence of the patent tubal ostium. But in case of the tubal blockage, the uterine cavity becomes blue due to the backflow of the dye, and the same procedure was repeated on the other side to assess the other ostium. After office cystoscopy, general anesthesia was given in all those patients who underwent the office cystoscopy. Mini laparoscopy was performed with the 2.9 mm telescope with 3 millimeters of the accessory ports. The uterus, bilateral tubes, and ovaries were assessed. The methylene blue, initially the methylene blue dye, presence of methylene blue dye in the pouch of Douglas was confirmed as a corroborative of the findings of the office cystoscopy, and then that dye was aspirated, and then 20 to 30 ml of the dye, methylene blue dye, was injected through the intrauterine Foley's catheter, and both the tubes were assessed separately for tubal patency. So coming on to the results. All the patients, they were having the infertility, out of which 80% they were having the primary infertility. There are various parameters which were assessed on the office cystoscopy included, but then 92% of the patients, they had the normal uterine cavity, and 3.7% patients, they had septate uterus, with 2.5% patients, they had the pale endometrium. The patent right ostium was seen in 77% of the patients on office cystoscopy, whereas the patent left ostium was seen in 78% of the patients. On mini laparoscopy, on 83% of the patients, they had the patent right tube, and 86% of the patients, they had the patent left tube. And various other parameters like the shaggy uterine surface, endometriosis, adhesions, they were noted. The ovarian surface, problems of the ovaries, they were noted down, and the peritubal adhesions were seen in 5% of the patients, with hydrosalpinx in 8.75% patients of them. So coming on to the comparison of the office cystoscopy with the mini laparoscopy for the tubal patency, out of the total of 125 tubes, tubes which were found to be patent on office cystoscopy, 119 were also found to be patent on mini laparoscopy, whereas 6 were found to be blocked on mini laparoscopy, which were found to be patent on office cystoscopy. And out of total of 35 tubes which were found blocked on office cystoscopy, 17 patients, they had the patent tubes on mini laparoscopy, and 18 had the blocked tubes. So the net result became like specificity of the office cystoscopy found to be 75%, with a sensitivity of 87%, and the positive predictive value of office cystoscopy is 95%, negative predictive value of 51% of the office cystoscopy as compared to the mini laparoscopy. So the office cystoscopy was found to be 85.6% accurate in predicting the tubal patency. The mean operative time was also more in the mini laparoscopy group as compared to the office cystoscopy. In the office cystoscopy, the time was noted down from the insertion of the hysteroscope to the vaginoscopic approach to the completion of the procedure, and during the laparoscopy from the time of incision to the time of the adhesive plaster application. So coming on to the discussion.
Dr. please hurry up, your time is running out.
Okay. There are few studies are available in the literature which has compared the results of the hysteroscopy, tubal patency on the hysteroscopy. The study done by the Habibaz et al., who found that compared the diagnostic hysteroscopy, found the fluid which was found on diagnostic hysteroscopy on the ultrasound in the pouch of Douglas. The Torak et al. Did a selective pertubation with office cystoscopy with methylene blue dye. Perry J et al. Through the air infusion saline into the during the flexible office cystoscopy. Kata G used the office cystoscopy guided selective chromoperturbation. Yusel et al. Did with hystoscopic chromoperturbation with methylene blue, and Ott G et al. Studied the visualizable flow at the office cystoscopy, that is of the saline. So office cystoscopy was found to be a useful procedure as an outpatient procedure with vaginoscopic approach. No anesthesia was required. And the inner aspect of the uterine cavity can also be visualized with the reduced post-operative pain and better patient acceptance. As compared to the mini laparoscopy, which can't be done in the outpatient procedure, and anesthesia is required, and duration of the surgery was more, and it is more invasive. So hystoscopic chromoperturbation can be used as an alternative to laparoscopy with high sensitivity and moderate specificity for assessing the tubal patency, with added advantages of the lack of, as I already discussed, the lack of anesthesia and less time and better patient acceptance.
Yeah.
Thank you. Science is always in progress and the future depends on what you do today and where you can shake the world. Thank you.
Thank you, Dr. Aki. Now I request the judges to please take over.
Yes, can I ask a question?
Yes, ma'am.
Yes, Raki, can't see you, but still I want to ask you a question. How would you segregate the cases with unilateral patency or bilateral patency on hysteroscopy? Because the dye in the uterine cavity is going to cover both the ostia.
The eddy current was visualized at each ostium. While we were injecting the methylene blue dye, the eddy current, that is a visualizable flow, was seen at each ostium independently. The
Okay,
flow of the dye in the uterine cavity comes later on, but first we see the flow of the dye through the ostium. The visualizable flow is seen through each ostium.
Okay, was the amount of dye different when it was patent clearly or partially?
The amount of the dye when?
Yeah, you said no 3 to 10 ml.
Yes,
so did you find some difference in the amount of the dye used? If the tubes are patent, obviously little dye will be used. So if
yes,
it
ma'am. Ma'am, most of the time the almost 5 to 7 ml of the dye was used, and it is easily identifiable. The flow of the dye was easily identifiable at around 5 to 7 ml through the ostium.
So what percentages of results correspond
Maximum we
with
have
your
given 10
laparoscopic
ml of the dye.
finding?
Sorry, ma'am.
On laparoscopy, what percentage of the cases really were right on your assessment on hysteroscopy? That you had said unilateral and it was unilateral on lapro. You said bilateral on hysto and it was bilateral on lapro.
It was 95%.
Okay, that's good enough. 95 is good enough. Okay, thank you.
So I don't think we have more time. Should we move on to next? Judges?
I have only one small question.
Okay.
After how much time you are assessing that dye is coming back to the uterine cavity? How much time?
Ma'am, initially we see the visualizable flow at the ostium. If that is seen, so that is indicative of the patent tubes. If it is not once seen, maximum we inject almost 10 ml of the dye was injected. If by that time it was not seen, the visualizable flow was not seen in the ostium, that was, and the backflow of the dye was there, then it is considered to be a blocked tube.
Okay, good.
Thank you.
I just have one.
Yeah, ma'am. I think so. Dr. Reema,
yeah,
you can take over. I think, in case
thank
some
you, Dr.
questions
Sukriti.
they can ask later. Yeah.
So moving with the next presenter, Dr. Rashmi, are you ready? Dr. Rashmi's co-presenter will present the this paper. And the abstract number is 43 with the title Autologous Stem Cell Therapy for Thin Endometrium under the theme Endometrium and Fallopian Tubes. So you can start, Dr. Rashmi.
Yes. Hello.
Yes, you can start. Yeah, please start.
Yeah, this is regarding the use of autologous stem cells for persistent thin endometrium. In fact, we had a total of 4 patients. All these 4 patients had difficulty in conceiving because of a persistent thin endometrium. The endometrial core was always less than 6 millimeters. One patient who had repeated DNCs had a persistent thin endometrium under hysteroscopy showed multiple adhesions. And after having done an adhesiolysis, after 2 months of the adhesiolysis, despite HRT, her endometrium was not building up. It is then that we decided to do autologous stem cell therapy on her. Post that, after 3 months,
Dr. Rashmi, you are not audible.
Hello?
Yeah. Now you're audible.
Yeah, in the previous 4 IVF cycles, she always had an issue of thin endometrium, and every time she underwent an embryo transfer, she had to go on HRT for a minimum of 4 to 5 months. When she came to us, despite giving her tamoxifen and gonadotropins, her endometrium would never get a typical triple line appearance. It used to go up to 7 to 8 millimeters, but it would always have a hazy appearance. And that is when we decided that we should do a stem cell therapy on her. After having done a stem cell therapy, a proper triple line appearance started coming in. She had good vascularity, and thereupon we did the embryo transfer. She conceived with twins, and she's given birth to a son and a daughter. In the third patient, we got a beta HCG positive only 2 days back. So out of when we actually send the abstract, we send that 2 patients out of 4 were pregnant, and now we have 3 patients who have conceived out of the 4 women who underwent the stem cell therapy with us. So we've got quite encouraging results with the stem cell therapy. What we've done in all these cases is that we aspirated around 45 ml of blood from the bone marrow and prepared 3 samples with the help of Sirajin. The first sample was injected the same day of the biopsy, the iliac crest biopsy. The other 2 samples were frozen. We did these 2 infusions over 2 months on the 7th or 8th day of your menstrual cycle. Though we were asked to do hysteroscopically, the first time we were not confident in doing a hysteroscopic subendometrial infusion. That's the reason why I did a pipple biopsy with the endometrial curette, created raw areas in all the 4 walls of the endometrium, and then instilled the stem cell infusion. The second patient who had multiple IVF failures, we had to do a hysteroscopy for her. So in the first sitting, we did the hysteroscopic subendometrial injection. The other 2 cycles, we only did the infusion after doing endometrial scratch with pipple. The other 2 patients also, we had to do the similar thing because they were not willing for hysteroscopy considering the cost involved, and they had already undergone hysteroscopy in the past. Because despite not doing a endometrial injection, only with a simple endometrial pipple curette followed by the infusion of the stem cells, we have got good results. We are quite encouraged, and we wish to do those for refractory thin endometriums. Dr. Vasanthi would share the PowerPoint presentation with some references for the same. Hello, am I audible?
Yeah. Dr. Rashmi, are you done?
Yes, I'm done.
Okay, so over to judges for the questions, please.
Yes. Can I ask one question, Dr. Rashmi?
Yes.
When did your patient deliver?
My patient delivered 4 months back.
Okay, so did you see the endometrium at 6 weeks? Do you plan to see it at 6 months, whether it has left a permanent effect or is it still thin?
The volume is...
Have you seen the patient at 6 weeks and seeing the endometrium again?
Yeah, I have seen the patient when she was 6 weeks pregnant.
Yes, what was the endometrium like? Still thin or improved? Hello?
No, at at 6 weeks of pregnancy, I did not really focus on the endometrial thickness. I looked at the tropoplastic reaction, which was very quick. Hello?
Madhu is asking 6 weeks postpartum.
I did not focus on the endometrial massage.
6 weeks postpartum.
Postpartum, no, I haven't. I don't
Any
deliver
idea
patients, I
for
refer for a
because what I feel is, has it left a permanent effect or was it just temporary to give you a pregnancy and gone?
Dr. Madhu, postpartum, probably the lining would be thin anyway, isn't it? I think maybe
yes, and then 6 months. 6 months.
After
6 months, I'll probably call her. Yes, I can probably call her after 6 months. She's just completed 4th month.
It would be very encouraging if you find there is an improvement which is left for some time, rather than just having a pregnancy delivered and
yes,
then
ma'am, I'll definitely do that.
So that's what I feel. So okay, if
Yeah,
you are giving
that's
stem
a
cells,
very good input for me. I'll definitely
yes,
do
thank you.
that.
I just have one comment. I wish we had a video also. It would have helped us to know, how deep, how far.
Yeah, thank you.
Thank you.
Actually, I would like
Yeah, we'll probably take the video next time.
one point that in published literature, they have mentioned that the results last for up to 6 months, 6 to 9 months. The endometrial lining appears to be thicker up to 9 months.
Okay. So thank you, judges. Can we move ahead with the next presenter? Yeah. So the next to present is Dr. Amrita Singh. Her abstract number is 59. Topic is to study the association of progesterone levels during stimulation with pregnancy outcome in IVF ET cycles under the theme clinical ART. So Dr. Amrita, over to you.
Everyone, I am Dr. Amrita Singh and I am here to present my research paper titled To Study the Association of Progesterone Level During Stimulation with Pregnancy Outcome in IVF ET Cycle. Aim of the study was to assess the potential role of progesterone level on cycle day 2, day 6 and on day of HCG administration for the likelihood of pregnancy in women undergoing downregulated controlled ovarian stimulation for IVF autologous fresh ET procedure, and the outcome measured was clinical pregnancy rate. Now, starting with few questions: why the progesterone level rises in the stimulated IVF cycle? What is the impact of raised progesterone and how much is the clinical significance cutoff values and implication of measuring progesterone? This is a graph showing natural cycle rise in progesterone in the late follicular phase. We can see that there is a rise of progesterone in late follicular phase in natural cycle. How this progesterone is synthesized: progesterone is formed in granulosa cell and then it diffuses to theca cell for hydrolysis, because this is 17-hydroxylase activity is only present in theca cell. In early follicular phase, LH acts only on theca cells to convert pregnenolone to progesterone and further to 17-hydroxyprogesterone. But during late follicular phase, LH receptors are heavily expressed on granulosa cell and it has a stimulatory effect of 3-fold stronger than FSH. Now, this progesterone, when produced in excess, this will acquire access to circulatory blood flow. This is a pictorial presentation of the same. But what happens to the progesterone rise in controlled ovarian hyperstimulation cycle? There are several hypotheses. There is increased LH receptor sensitivity due to higher cumulative exposure to estradiol in conjunction with FSH. There can be incomplete pituitary suppression by GnRH, and it could result in some LH secretion sufficient to stimulate granulosa cell to produce progesterone, despite not being enough to trigger ovulation. There may be some disruption of certain signaling pathway in the oocyte granulosa cell regulatory loop. There are reports which says there are elevated levels, elevated late follicular phase serum progesterone have been reported in 2 to 35% of ART cycles. Now, what is the effect of progesterone? Progesterone, when produced high in late follicular phase, it contributes to embryo endometrial asynchrony, resulting in implantation failure. The usual cutoff is taken to be 1.5 ng per ml on the day of trigger, but variable ranges from 0.7 to 3 ng per ml has been reported in the literature. Furthermore, the universal use of threshold of more than 1.5 ng per ml for progesterone on the day of HCG trigger has been challenged by studies which have proposed that detrimental effect of circulating progesterone may already set into motion below this arbitrary cutoff of 1.5 ng per ml. Now, how this study was done, it was a retrospective observational study with 160 patients undergoing downregulated IVF fresh embryo transfer cycle. Two stimulation protocols were used, the GnRH agonist protocol and antagonist protocol. And both the cycles, both type of cycles were closely monitored for ovarian response with transvaginal scan, estradiol, progesterone. Outcome was measured in terms of clinical viable pregnancy, and for hormonal assay, blood sample were drawn from on day 2, day 6, and on the day of trigger, strictly between 9 to 11 a.m. owing to the pulsatile release of progesterone, and it was subjected to radioimmunoassay. Statistic was analyzed by independent t-test, and the score of 0.05 was considered significant, the p-value. Now the result, the clinical rate which we found in our study was clinical pregnancy rate was 31.25%. That is out of 160 patients, 50 conceived. The difference in mean of serum progesterone level on day 2 and day 6 of the cycle in pregnant and non-pregnant group were statistically not significant. However, the result of serum progesterone on the day of HCG trigger in pregnant group was 0.92 plus minus 0.37 ng per ml as compared to non-pregnant group, which was 1.24 plus minus 0.79 ng per ml, which is definitely higher. And this result was highly significant statistically. Now, this is a table showing comparison between different parameters of pregnant and non-pregnant groups. We found that for both pregnant and non-pregnant group, mean of age, duration of infertility, day 2 FSH, LH, and antral follicle count were comparable, and the difference was not statistically significant. The day 2 progesterone and day 6 progesterone levels, the difference of mean was also not statistical significant. And as I said earlier in my slides, the progesterone level in day of HCG trigger was higher in the group of non-pregnant patients, and this result was statistical significant. This is a graph showing the pregnancy group in red line, and we can see that on the day of HCG trigger, the pregnant group has had lower progesterone level than the non-pregnant group. Now the discussion, let's have a look on what other studies says about this progesterone on the day of trigger. Use of universal late follicular elevated progesterone threshold as an ART outcome predictor has proven to be harder than originally expected, owing mostly to the fact that
only 1 minute left.
Yeah, excessive progesterone production is highly frequent encountered in good prognosis women with an otherwise healthy multifollicular response, but that threshold is not linearly related to the pregnancy. This Rentis et al. Did a study. It was a systematic review and meta-analysis, and around 55,000 patients' fresh IVF ET cycle were analyzed, and they found that 0.28 to 1.1 ml and ng per ml of progesterone was highly significant, was highly associated with increased live birth rate and clinical pregnancy rate. And this fertility sterility study in 2018, McHill's, they did threshold analysis and cost analysis, and they found that lower threshold ranging from 0.4 to 1 ng per ml classified in majority of the cycle as abnormal, and as well as they required a very large number needed to treat to increase one live birth, and the statistical and cost effective threshold clustered between 1.5 and 2 ng per ml was the conclusion of this study. Conclusion of my study is role of progesterone is very crucial for the implantation and continuing pregnancy, and high late follicular phase progesterone level is detrimental to pregnancy outcome. This study suggests that single serum progesterone on the day of HCG trigger is usual predictor for successful pregnancy outcome. However, threshold of progesterone elevation and magnitude of ovarian response should be taken account should be taken account together. Thank you.
So, judges, you can take over for the questions. Any questions?
Doctor, well, one question is, yes, carry on, Dr. Kiran.
What was the range of progesterone? You said that in the non-pregnant women, the average was 1.2. Do you have a range?
Yes, ma'am. Yes, ma'am. I have the range. This was the range of the range of my pregnant group was just the range of my non-pregnant group was between between 0.8 to 2.2.
Yeah. So you were not canceling any cycles on the basis of progesterone, high progesterone. So you were not using any cutoffs for cancellation. Is that right?
Basically, the cutoff of cancellation, what we fixed was more than 2, just like 2.5 or something like that.
So you transferred with 2.2, right? So your threshold was higher. I'm just
Yes, ma'am, we transferred, although in some patients the progesterone level were high, but we transferred taking in account like the good endometrium, the triple line, the endometrium was not luteinized in ultrasound, all these findings, the younger age group, all these findings taken together, if the progesterone was higher, then we overlooked that and we transferred. But for a poor responder, if progesterone is 2.2 or something like that, we didn't do the transfer.
So there is a comparison between the LS surge. If LS surge level is good and progesterone level is, I think, more, even then we can transfer the embryo.
Ma'am, the range is very variable. In most of the study, the range is very variable. Most of the time it is said that if a patient is high responder, then with high progesterone level on day of trigger, we can transfer with good pregnancy results. These are the studies. So altogether, there are other variables, other factors also which we should take into the account.
Yes. Okay.
Did you consider the profile of the patient while calculating progesterone? Did they match?
Yes, the demographic details, the age criteria, the duration, and the duration, the level of day 2 hormones, they were comparable in both the group. There was not much difference.
How much was the extra cost in one cycle for doing all these tests?
Which test, ma'am?
Cost of these tests, extra.
Ma'am, these tests are included, the FSH, LH, these tests are included in the normal cycle protocol, like we do FSH, LH in the starting of the cycle or a cycle before at the time of investigations. So it will not cost any extra to the patient.
Thank you.
Thank you. Thank you, judges, and thank you all the presenters.
Thank you.
Thank you, ma'am. Thank you
For the
ma'am.
wonderful presentations, and I request all the judges to please mail their results to Dr. Monica Verma's mail ID, or you can WhatsApp on her mobile number.
Okay.
Thank
we can
you
click
all.
a picture and send. We can click a picture.
Yeah, you can click a picture and send. That's it.
Yes,
yeah.
yes.
I'm sending
On the WhatsApp, Dr. Monica, I'm sending on WhatsApp.
Yeah, fine.
Okay. Even I'll send on WhatsApp.
Now we have the inauguration coming in, so please wait for the inauguration.
Okay.
Thank you all.
Good afternoon, everyone. On behalf of the organizing committee of Fertivision 2020, I welcome you all. After the remarkable oration on embryo culture, let us start with our next session in Hall B. I invite our chairpersons for this session, Dr. Madhuri Patil. She is the clinical director of Dr. Patil's Fertility and Endoscopy Clinic in Bangalore. She is also the editor-in-chief of Journal of Human Reproductive Sciences and on the editorial board of Endocrine Society Journal from 2020 to 2021. She is also the associate editor of the Onco Fertility Journal and founder chairperson of Karnataka chapter ISAR. Dr. Geeta Khanna, she is the director of Ajanta Hospital and IVF Center, Lucknow, and founder secretary of the IFS UP chapter. She is also a member of the executive committee of the IFS, and she is a winner of several awards and accolades. Dr. Himanshu Roy is the chief consultant at Srijan Fertility Clinic in Patna, and he's the secretary of IFS Bihar chapter. He's been doing infertility practice in 20 years and is an active member and faculty at various conferences. I request our chairpersons to please start the session.
Good afternoon, everybody. And on behalf of IFS, I welcome our first speaker of this session, Professor Ben Mole, who is Professor of Obstetrics and Gynecology at the Monash University and Monash Health. He is also the professor at the Obstetric and Gynec Department at University of Aberdeen. He would be speaking to us on management of unexplained infertility prior to IVF. Dr. Ben Mole, please.
Yes, thank you for that kind introduction. It's good to know that I'm in Hall B. That's kind of a new experience, so to say, in this Zoom time. And I'm just starting my slides, and I'd like to have a confirmation that you can see my slides. Is that correct?
Yes, we can see your slides.
Okay, good, great. So I would like to thank the organization of Fertivision to invite me. I have good memories of previous meetings, but today I'm just speaking from Melbourne. It's just after 9 o'clock here, and it's great that the technology still allows us to communicate. So my disclosures, I'm going to say a little bit about tubal flushing, and I have a connection with the company Courbet, but I don't have any direct financial interest. I was asked to share my CV, so I've studied in Amsterdam, got my PhD there, and as said, currently I work at Monash, Australia, as well as Scotland, University of Aberdeen, and my professional diagram is a day without randomization, is a day without progress. And the other thing about my CV is this. So this is me a long time ago, 1965. You can see my mother here. She is now 88, still living in the Netherlands, and I come back at the end of the talk. So I spoke about unexplained infertility. Is diagnosed, first of all, there should be infertility. So in the definition is that couples try to conceive for 12 months or more. And then there is no clear diagnosis. You can obviously investigate as deep as you want. But in general, I would say normal semen analysis, patent tubes, or at least one patent tube, ovulatory cycle, normal uterus. I think ultrasound is sufficient. Maybe hysteroscopy, assess ovarian reserve. And I think also important to mention that you should always ask couples whether intercourse is normal, because there will be couples that actually have a sexual problem that can be easily solved with home insemination, for example. So then if we have made the diagnosis of unexplained infertility, then the question is what to do, IUI with hyperstimulation, or IVF. And I always fall back on this article, quite inspiring, because it is a cohort study from a clinic in the Netherlands that followed couples for a period of 3 years. And what this shows is first that you can be quite reassuring to your patients, because over a period of 3 years, 70% will have a successful pregnancy. That's black. But then also blue is actually the number of natural conceptions. So you should never exclude that there are natural conceptions. And that's actually the biggest contribution, bigger than IUI or IVF or ovulation induction. And if you then focus on unexplained infertility alone, then even the prognosis becomes better. You go to 80%, 4 out of 5 will have a baby, but also 3 out of the 4 babies will be conceived by natural conception, and that's an important thing to keep in mind. So one way to deal with that, I think, is prognosis. So I think it is very important if you see someone with unexplained infertility to ask yourself what is the probability that natural conception will occur. And this is a system to do that. This is a scoring chart. So women's age is important. How long are people trying? Was there a previous pregnancy? What is the sperm motility? And then if you add that up, then the higher the score, the worse the prognosis is. But if you have couples where that prognostic index is relatively good, then you still come to a 30 to 40% chance of natural conception within a year, which I think is important. That model that we have created, you can see that here, actually holds pretty well. If we have a predicted probability of 60 or 50 or 40%, then indeed 40 to 50, 60% of the couples are going to conceive. You can also do it, I showed it on a paper score, but you can also do it in an electronic form. University of Aberdeen has a scoring system. We are developing one in Australia, and this helps patients in establishing a prognosis. We have developed that model further. This is a newer variant of the model where there are more factors involved. So that's one key message, is think about prognosis. And then the importance of that is demonstrated in this trial where we randomized IUI with hyperstimulation versus no treatment. And we did that actually in couples with an intermediate prognosis. And what we found is that in the first 6 months after randomization, there was actually no difference between no treatment and IUI. So this shows that if you have couples with a relatively good prognosis, that it is very justified to do expected management. We followed also that couples for 3 years. And whether you started early or a little bit later with treatment, there was no difference. Then we have looked at the question, if you do IUI or start immediate with IVF, is there a difference? It was the INES study. It is this paper published in the BMJ. And here you can say, and this is poor prognosis couples, that whether you start with IUI with hyperstimulation or IVF, single embryo transfer, or IVF in a natural cycle, there's not much difference after a year. So I think that IUI is really a good treatment to start with as compared to IVF. And this slide shows that you should still also consider natural conceptions in that period. And this slide on IUI demonstrates that if you have a poor prognosis, that IUI is better than expectant management. So I showed before that if you have a good prognosis, that IUI doesn't add. But if you have a relatively poor prognosis, this is a study by Cindy Farquhar, then IUI is adding over no treatment. So how should you do IUI? There were some RCTs, but not super big RCTs. This is a very large cohort study from China, Third University Hospital, where first of all, it shows that natural stimulation IUI gives a reasonable pregnancy rate of about 6%. If you stimulate, then you increase that pregnancy rate, and letrozole is, I think, the best drug because it increases the pregnancy rate, but it controls the multiple rate. So I would say there are RCTs underway that if you do IUI, that if you stimulate with letrozole, that you get the optimal balance between safety and effectiveness. And then we should realize that the amount of studies that we do is actually limited. So there is an enormous amount of studies comparing different FSH studies, regimens in IVF, but there is actually only one study that compared IVF to expectant management. That's a study of Huge that shows that if you have IVF or unexplained infertility with a considerable duration of infertility, that IVF adds over expectant management. So are there alternatives? Yes, I think that we should first of all have a complete diagnostic workup, and I also think that we should realize that tubal testing and tubal flushing increases pregnancy rates. This is a study I did in the Netherlands, oil-based versus water-based contrast for HSG in infertile women. And this is the result. If you use oil-based contrast, then we had after 6 months a 10% higher pregnancy rate as compared to the pregnancy rate with water-based contrast. So I think that for couples with unexplained infertility, they need to be informed that tubal flushing helps, and I think oil is better than water. And then we should also realize that unexplained infertility is a diagnosis that is made because we are limited in what we actually can measure. And I'm quite convinced that in 5 or 10 years from now, the diagnosis unexplained infertility will be different and it will be less. So I think that, for example, endometrial receptivity and a better understanding of that will help us in understanding causes of infertility. And I think here about the work of Carlos Simon and potentially the ERA test that can help us. And one other thing to realize is that there is an increasing number of studies that shows that treatment of contractility during IVF with atosiban or other drugs improves the pregnancy rate. And that could mean potentially that actually a myometrial contractility could also play a role in unexplained infertility, but we're currently not looking at that. So having said that, I want to have some attention for the enormous amount of IVF that we do, because we're really increasing the numbers. There's a kind of older slide showing the increase in Europe, slide from the Netherlands showing that in 1990, 50% of the IVF we were doing for tubal factor. Currently, that is only 10 to 15%, and realize that the amount of tubal factor is the same. It's just that we are doing much more IVF for unexplained infertility and mild male infertility. These are those statistics that I showed, and the picture is exactly the same in Canada. 2001, 2012 is an enormous increase in the amount of IVF. These are data from Australia. And if you look in these figures, then you see that the amount of IVF for tubal infertility and endometriosis stays the same, but the increase is in unexplained and male factor infertility. A more recent slide, and yeah, I think this demonstrates the concern we have. This is Denmark, but the persons who designed this slide also have pictured as an in vitro fertilization market, and they picture the volume, numbers of treatments, and the value in dollars. So we're in a process of moving away, I think, from medicine to business, which is, I think, debatable, and we should have that discussion. So are we doing any good? Yes, definitely. I think if there's long-standing unexplained infertility and alternative treatments like IUI or tubal flushing haven't helped, then IVF is doing a good thing. But we should be aware that we might also do harm. We've addressed this in this article, I think now 5 years ago. We addressed the question, are we overusing IVF? And one thing we should realize that if you compare IVF pregnancies, even if they're singleton pregnancies, so we all know that creating the multiples is a problem, But even the singleton pregnancies after IVF have an increased risk of stillbirth, perinatal mortality, low birth weight, prematurity, etc., etc. It's not super big, but if you're going to do more and more IVF, then potentially you're increasing that harm. There is a risk of increased risk of birth defects that is specifically there if you do ICSI. Older paper from Michael Davis, but also this week there was an article in Human Reproduction with a large cohort study that indicated that babies conceived after ICSI have an increased risk of congenital anomalies. Effect of culture media on outcome. You would say it's all innocent, but this study from Maastricht, the Netherlands, shows that if you have two types of culture media, Vitrolife and Cook, that you don't not only have a difference in pregnancy rates overall, where Vitrolife is better than Cook, but also that there is difference in birth weight, and that the babies in the Vitrolife group are heavier on average than the babies in the Cook group. So we are definitely, if we do IVF, influencing nature. One of the concerns is potentially cardiovascular effects. Realize that according to the Barker hypothesis, differences in birth weight have an impact on cardiovascular health. Difficult to say because the oldest IVF baby is just over 40 now, but we see an effect also of ovarian hyperstimulation on the IVF offspring. Animal research shows that if you compare babies or animals conceived with ART to naturally conceived animals, that there is difference in birth weight and other abnormalities. So we should consider safety versus effectiveness. If a treatment is effective, then we are allowed to take some risks. If our treatment is not effective or we have less invasive treatments, then I think that safety should be prioritized. So last couple of slides, how we can use it. These are data just published in Australia. What we did here is a cohort of 500 infertile couples in one clinic, and we applied a diagnostic and prognostic algorithm. So what we found is that you're diagnosed with tubal blockage or very poor sperm quality, you need treatment. Red is what would happen without treatment, blue is with treatment, and there's no doubt here that these infertile couples need treatment. This is PCOS and ovulation, need also treatment, but it's questionable whether it should be immediately IVF. First 6 to 12 months ovulation induction is doing a lot of good, I think. And then this slide that shows that if you have unexplained infertility, but you have a good prognosis, that actually ART is not adding that much. And only if you have a poor prognosis, then ART starts to contribute. So summarizing, unexplained infertility is an important category of infertility problems. Think about prognostic models and natural conceptions. 6 cycles of IUI, I think, with letrozole should be offered, and consider tubal flushing with oil-based contrast. IVF is a necessary treatment for some couples, but it should be the treatment of last resort. And then I come back on my opening statement. I showed you my birth certificate, 1965. This is the announcement of the marriage of my parents. So this is not Ben Mol me, but Ben Mol my father. They married in 56, 9 years before I was born. I'm the oldest son and I don't have any sisters. So from that you can derive that my mother suffered 9 years of infertility in an area where there was no IVF. And when I did the tubal flushing study, she told me actually that she has a tubal test in November 1964, and that was 1 month before I was conceived. So we are in 2020. I cannot be with you. I hope that somewhere in 2021, times will be better and I can join you. Although I think that Zoom also has exciting possibilities. I give the word back to the chairs. Happy to have any questions, and I wish you a very good conference. Thank you.
Thank you, Ben, for that brilliant lecture. We would be taking the questions at the end of the session. So I now request Geeta Khanna to introduce the second speaker.
A very good afternoon to all of you. The field of ART is changing constantly by advances and innovations. In a quest to maximize success, add-on and interventions are often adopted and sometimes overutilized, while the principles of evidence-based medicine seems to be less strictly adherent to. The topic of add-ons or adjuvants have been heavily debated. So friends, let us hear from a renowned speaker, Dr. Hung Yu Ernest. Now I invite him to give his deliberation. Dr. Ernest is a clinical professor, OBGYN, Hong Kong University, editor of many journals, including Human Reproductive Medicine and Open and RBM. His topic is, what is the role of add-ons therapy in IVF? So the stage is yours, sir.
Well, thank you very much for the kind introductions. Unfortunately, we can't actually travel to India to meet you face to face. But I think it's a very exciting platform so that actually many more can join. So I would like to share the screen first. So I hope you can see the screen. So this is my CV, and I have nothing to actually declare related to this talk. So the title actually is what is the role of the add-on therapy in IVF? We understand actually IVF is an effective treatment of infertilities. As Professor Benmore said, although it's the last resort, but we see actually increasing number in many places. But the live birth rate actually is not up to the standard or the expectations of many patients, because the live birth rate actually range from 30 to 40% reported in the Europe and also in the United States. Well, that means around 25 to 30% of the embryos were implanted. Well, we actually have the figures from China, which I think recently published in Human Reproduction, which I think the official figure so far. Well, IVF actually is simple procedures involving a few steps. Certainly, it's quite different from the natural conception and also the IUI. It involves the period of ovarian stimulation and then the egg collection, fertilization in laboratory, either by conventional method or by intracellular plasmic sperm injection, and then put back the embryos. But because of the live birth rate is not up to the expectation of many patients, so many optional things has been offered to patients on top of the standard fertility care. Well, certainly this is at additional cost, not to mention about the possible and potential risks to the patient. And this is a study actually done in the UK, and many claims actually were made on the benefit of the fertility treatment, but from the website, there's actually still a lack of supporting evidence site, which I think is important for the patient to consider. So the HFEA actually developed this traffic light rating system. I think is very good, easy to understand. The green light actually means that at least one good qualities randomized control trial, which shows that the add-on therapy is effective and safe. And the amber light actually is conflicting body of evidence, and the add-on therapy is not recommended for routine use. And of course, you can understand the red light just like the usual traffic. You shouldn't actually offer it, and there's no evidence that add-on is effective and safe. So this is the you can find actually in the HFEA website. And unfortunately, you can't see a green light at all. And I actually have highlighted some items which I'm going to discuss with you in the following time. That includes assisted hatching, embryo glue and mutual scratching, PGTA, and also physiological XC. Assisted hatching is not a new method. We know the importance of the sonar pellucidars, which surrounding the egg and protect the egg, and then from polyspermy, and it's very important in the sperm-egg interaction. And suddenly it becomes naturally hardened after fertilizations. And then in the first few days of the cleavage embryos, but then because of the development of the embryos into the blastocysts, then the expansion of the size and also the lysine produced by the cleaving embryos, then the sonar pellucidar become thinner and thinner, and then the embryos hatch. And then there were direct contact between the hatch embryos with an endometrial lining. And this method was actually pioneered, you can see, 30 years ago, and it's a considered a method to improve the potential of implantations. But whether this is really is the case. Sonar thickening or hardening has been proposed in a number of conditions: increasing age of women, high FSH, in vitro cultures, or patients who actually haven't got pregnant after a few embryo transfer, or after the freezing and thawing process. So there are different ways that you can do it. So then you can use a mechanical method, exit, enzyme. I think more commonly now, you actually use it in the laser. And then you can actually basically do a breaching. That means get a hole there, or you actually get a thinning, which would try to actually advance the hatchings by a day or so. I've done some studies. You can see actually it was quite some time ago in the frozen cycles, because the theory is the freezing and thawing can harden the sonar, and then we at that time we placed the keeping embryos. But basically it's a double-blind randomized control trial. So the women's, the clinicians, and the nurses was actually not aware. Only the embryologists performing the assisted hatching would know. So the women were actually randomized into two groups. One is actually having the assisted hatching. At that time, we do actually sonar thinning, so that only outer half of the sonar was actually thinned by the laser. And then we actually have looked at the implantation rate and then the pregnancy rate, and there seems to actually no difference, okay, between the sonar thinning versus control. So, and then we actually run another randomized study, because we think at that time the thinning may not be actually really improving the success. So we actually do the sonar breaching as well. So we use a laser, and the laboratory staff burn a hole, a very precise one, and then we compare this. Indeed, we find that actually sonar breaching was associated with a reduction in the implantation rate and then the pregnancy rate. And we actually also have a group we actually decline to be recruited and randomized. And then we look at that there's no actually any difference with sonar thinning versus the decline group. That is what we actually have published in the previous study. So we don't think actually the sonar thinning was associated with a higher pregnancy rate when we compare with the control. So we don't actually recommend that for the frozen cycles. And if you look at the meta-analysis, and this was actually not too recent one, is 2012, you can see there were 31 randomized control trial, nearly 200 clinical pregnancies reported in around 5,700 women. And you can see there's a slight increase pregnancy rate in the group randomized to the assisted hatching. Okay, the odds ratio is 1.13. but there's no actual difference, no significant difference between the assist hatching group and also the control groups. There were 9 randomized studies report the live birth rate. So the conclusion is the assisted hatching will significantly increase the clinical pregnancy rate, but only for statistical significance. So there's also actually a guideline on this topic more recently by the American Society for Reproductive Medicines in 2014. So there's insufficient evidence that assisted hatching improved the birth rate. Although there's good evidence that assisted hatching improved the clinical pregnancy rate in poor prognosis group, say who actually fail a few IVF cycles. But the most important parameters that the woman of fertility treatment is the live birth rate, not the clinical pregnancy rate. So the second one is the pre-implantation genetic testing for aneuploidy, PGT-A. I think it's well known, actually is coming in many places. More and more women actually try to get pregnant at later stage because of the work and because of the career. And then we know that actually the pregnancy rate drops significantly approaching the age of 40, and then afterward even more significant. And there's a very high risk of miscarriage. And this actually is a study, population study, published in the Nordic countries in, you can say, 20 years ago. And I think this will be the same, I think, for the recent years. And looking at the different time frames in the 70s, 80s, and late 80s, and basically you can see a low miscarriage rate in the 20s to early 30, and then it rises gradually after the age of 35, and then get up to 80% at the age of 45 or so. Of course, this is mainly related to the very high aneuploidy rate. This is a well-coded study because it's a very large database with the trophectoderm biopsy and with comprehensive chromosome screening. And it has been shown that the aneuploidy rate, which explain the miscarriage, explain the non-implantation, increase after the age of 26. And actually there's more and more chromosomal abnormalities with increasing age. And so you can see here that the patients actually after 26, there's a gradual increase, and then in the later 30 is increased more rapidly. That's probably reflected clinically by the lower live birth rate, a high miscarriage rate. So pre-implantation genetic screening is aimed actually to screen the chromosomal abnormalities in IVF with the aim to improve the implantation pregnancy rate, of course, the live birth rate, reduce the miscarriage rate, and maybe actual reduction in delivery of babies with chromosomal abnormalities. And it actually goes through the PGT 1.0, where at that time, taking biopsies from embryos at around egg cell stage, day 3, we take one cell, we use the fish. And then with the technologies advanced, then we're now moving to PGT 2.0. We are doing the biopsies from the blastocyst, taking a few cells. We're using the comprehensive chromosomal analysis, either by the array CGH, now more commonly with the next generation sequencing. But where are we now? This is a study you can see was published again nearly 10 years, looking at the pre-implantation genetic screening. That is the PGT 1.0. 9 randomized control trial, or actually taking the biopsies. That should be a typo. This is day 3, using the fish technique. And with this technique, actually, that will significantly lower the live birth rate in women with advanced age and repeated implantation failure. And I think the RCT quite strongly, despite the fact that in the early stage, people think that we do not need RCT to confirm. And this is the PGT 2.0. There's only 3 small randomized control trial when this meta-analysis was published. And then you can see that the embryo selections can increase the clinical pregnancy rate per transfer. And the more recent start multi-center trials was published in Fertility Sororities, and including 600 women, much larger sample size, randomized in the two groups. The group actually randomized to PGT-A, and then the second group is actually based on the morphologies only. And you can see that the ongoing pregnancy rate, there's no significant difference, and whether it's per cycle or per transfer. And only subgroup analysis in women aged 35 to 40, then you can see. So whether we need actually further refinement, definitely we need further study. So physiological XC, I think actually hyaluronic acid is a major component, not only the zona pellucida, but also actually is important in selecting the sperm, and actually has been shown by study that this hyaluronic selected sperm have reduced level of DNA damage and aneuploidy. There are 3 small randomized controlled trials using the hyaluronic acid selected sperm can improve the embryo quality, live birth rate, decrease the miscarriage, but we need actually large scale study to confirm whether this is the case. Well, this study was actually done in the UK. It's a quite large study, actually nearly 3,000 couples. And then they try to actually look at a very small difference between the 2 arms using the standard XC or the physiological XC with selection of hyaluronic acid. But you can see the term live birth rate, which is important because that makes actually the transfer of the 2 babies, 2 embryos is not a good choice. And you can see that the outcome, the term live birth rate actually did not significantly differ between 2 arms. It's 27.4 in the physiological XC versus standard XC. There's no significant difference. So embryo glue, again, the culture media actually surrounding the embryos is important, and hyaluronic acid actually is existing in the female tract, increase the cell-to-cell adhesions and produce a viscous solutions. It can facilitate the integration of embryos in the viscous intrauterine fluid. And this is an RCT cocaine 7, well, you can see this is 2014, 17 RCT, and then nearly 4,000 women. And then the great majority actually report the use of hyaluronic acid. The conclusion is improved clinical pregnancy rate and live birth rate with the use of the functional concentration, okay? But the quality is actually quite moderate, and quite a lot of them actually were not full publication, just abstract. So with this in mind, we actually run a randomized study in our setting. We use again the frozen embryo transfer cycle, randomize the patient, actually 550 in the 2 groups. And you can see here the clinical pregnancy rate, like the clinical miscarriage rate, ongoing pregnancy rate, live birth rate, basically of these 2 groups, no difference. So endometrial scratching, this is again start with some non-randomized study, which show quite a significant doubling of implantation rate after 2 to 4 injuries. And then that comes to a number of small scale, not very well performed randomized trial. And then this comes with the cocaine meta-analysis, 14 trials published in this meta-analysis 2015. And then you can see here only 1 trial. The endometrial scratching was done on the day of retrieval, and there's a marked reduction in the live birth rate. So this is not detrimental. This is detrimental to the live birth rate. There are 13 trials which done in the previous cycle shows increase in the live birth rate and ongoing pregnancy rate. But what is actually more study now coming up? When actually we focus endometrial scratching prior to the first IVF, then we can see there's actually 7 RCT, and this is a meta-analysis published very recently last year. And prior to first IVF, there's no significant difference between the groups in terms of clinical, ongoing pregnancy rate, and live birth rate. And we have actually published a study, I think in 2014, some years ago. At that time, 300 IVF patients randomized. They are not actually repeated implantation failure. And then we found actually when the endometrial scratching done, in the preceding cycles before the IVF, then this does not improve the ongoing pregnancy rate. And we actually have a subgroup which actually have repeated cycle. On the other hand, we show actually the ongoing pregnancy rate in this group was actually significantly lower when actually we performed the endometrial scratching. So this is the whole group, so 150 versus 150, and then the live birth rate actually no difference. And then you can see that actually the non-endometrial aspirate group actually is slightly higher than that, but I think the sample size is not good enough to show. But when we actually do the subgroup analysis, repeated cycles, then those actually have endometrial scratching have actually only about 50% of the live birth rate. So this is quite worrying to us. And I think that comes to the very large randomized study published early last years in New England journals, 1,300 women randomized, and then into endometrial scratching and also placebo groups. And you can see that the live birth rate in the endometrial scratch group and the control group basically the same. Subgroup analysis didn't find any difference in the live birth rate if the patient actually failed 2 IVF cycle before. So that fits into the repeated implantation failure. So my conclusion is actually very simple. I think we should actually look at the HIVA green light, the traffic light, and then we shouldn't actually offer the patients those therapy which again doesn't actually show up green light. We should actually perform well, large scale, well, good sufficient size randomized control trial to confirm the benefits before we're offering to our patients. Thank you very much for your attention.
Doctor, and we will have questions in the last. And now I invite Dr. Himanshu Roy to invite the next speaker.
Thank you, ma'am. Good afternoon, dear friends, and good evening to people in Europe, and maybe a very good early morning in people in Australia. So these are the times when we have to wish accordingly. So I am presenting, the honor of presenting Mr. Arne Sande, HOD of Lab Medicine, Women's and Children's Health, Norwegian University, and Editor-in-Chief of the iconic publication from Oxford University Press, Human Reproduction Update. And his topic will be, how will the world of scientific publishing look in 2 to 3 years from now? So he will be talking about the future, all the information that we are getting, how it is filtered, how it will be served to us. So from the horse's mouth itself, I hand over the screen to Mr. Arne Sande, please.
Thank you for the nice introduction. This is my CV. You already touched upon it. Relevant for this lecture is, of course, that I'm editor-in-chief of Human Reproduction Update. So this lecture reflects my personal views. So I'll divide it into 3 parts: things that will happen, things that may happen, and things that should happen. So you all know, are familiar with this system where you come up with an idea, you write it down, send it into a journal. The journal might send it to the peer review, comes back to you, reject or not, then goes to the technical part of it, technical editors, production editors, and so on. And then it's sent out to libraries or personal subscriptions. Which the issue now, of course, how should money flow in this system? Traditionally, it's been the libraries that have paid subscription, or it was personal subscriptions. So is it the reader or the writer that pays? And that is going to change now, at least in my part of the world. So you're all familiar with this too. Also, you want to read an excellent article in Update, and you look at it, it's so immensely interesting, and then you try to read it, and then you say, well, you don't have access. So either you have to have a personal subscription, or your institution is to have a subscription. So there's something called the Plan S. It's a coalition S, a coalition of funders of research. And they say that research funded by public or private grants must be published in open access journals. And secondly, maybe even more importantly, is it made immediately available in open access repositories without an embargo, meaning that it's the researcher, the writer, that owns the rights to the article. So they must have the copyright of the publication and essentially can do whatever they want. And the publication fees should be covered by the funders or universities, not individual researchers. And they also say that publication fees should be standardized and capped. So I'll come back to that too. And universities, research organizations, and libraries should align their policies and strategies. And hybrid journals like Update, where you can opt to have it open access immediately by paying a fee. And this is same time the subscription journal. That's not according to the Plan S principle. So there's a lot of coalition founders. I'm not going to go through lists. If you're interested, you can go in and look. And essentially there are institutions that pay for the research. So who is the Plan S coalition? Many or most European research funding bodies, the European Commission, and big and important research trusts in Europe and the US. And it's supported by research organizations in Africa and in China, who's not signed up for Plan S, either yet or ever, we don't know, is US federal funders, and India and European Research Council. So it's not a universal thing yet. It's still primarily a European initiative and part of Asia. So what will happen? The Coalition S will carry on. They will try to make this happen. And the dilemma faced by journals like ours is, shall they flip to open access or risk losing many high-profile papers because the authors are funded by organizations supporting Plan S? I mean, if you're a US researcher and you got from a big US fund research, then you have to publish in open access journals. So the journal, even though open access for journal is a challenge economically and there's certain issues, they might risk losing the most important papers. So my prediction is that they will flip to open access. So removal of paywalls, well, it still costs money to properly run a scientific journal. So who is going to pay what they call APC, article processing fees? Well, it's the author, directly or indirectly. So authors, if you see it from the author's perspective, authors that receive funding from research bodies supporting Plan S, they have to publish in open access journals. And the publishing fee is covered by the funding body. So for the researchers, that's okay. For authors working in certain institutions, even though they don't get funds directly from some of the supporting bodies, is part of the university strategy or the national strategy. But authors without funding from external bodies or working in institutions that are not supporting Plan S, they can publish in journals with paywalls, as they do now. Or they can publish in open access journals and pay the author fee. So we don't know how this will end up, how the landscape would look in, say, 3, 4, 5 years. But I guess it's going to get much wider acceptance around. So the author fee, and you immediately understand what this should cover, this editorial office, the publisher, all what's going on in between that you send in your paper and it eventually appears in the journal. And for most journals, they also want to generate some surplus, like for Update, it's for ESHRE, so the parent organization. Other publishers have other organizations they send some surplus to. So then you come up, what is the cost for the editorial process? It's really very different between journals. Say if you have a journal, a new startup, and you publish almost everything that you get into the door, and you have a fee for all of them. Or if you're a journal that publishes 5% of the submitted papers, that are top journals. And they can only, according to the system, now charge for the published papers. So manuscripts are referred and then rejected involves almost as much work as manuscripts that are accepted. That means the costing profile, the economic profile between those journals is quite substantial. So Nature, for instance, now said they're going to open access. And they said we need 9,500 euros per published manuscript to make this go around. And of course, Nature is a journal that rejects almost all papers. So, but 9,500 euros is way above what was anticipated as a likely author fee. So what will happen then if the Plan S coalition insists upon a standardized and capped fee? The journals that accept a majority of submitted papers will be favored. So you have a shift in which journals that do well economically and the current high-ranking journals will have challenges. So this might be an incentive to start accepting more papers for good or bad. So that is my prediction, is my personal opinion. What will most likely happen? And my prediction is that many of the higher ranking scientific journals will flip within the next few years, because all in all, it's going to be beneficial for them, although there's a lot of issues. Things that might happen, there's different initiatives around. One is that a lot of people don't like the impact factor system, and that journals are ranked by impact factors, and they want to reduce or remove the influence of impact factors. The prime argument is that you should not judge the quality of manuscript based on the impact factor of the journal. That has some bearing, it has some truth, but they want to sort of remove it at all. They also want to remove and reduce the influence of journals. So sort of the extreme argument here is that anyone should be able to post their research freely on the web. And it's going to be up to the readers to judge it. I think that's an extremely dangerous position currently, because what we do need now, I'm going to touch about in the last part of my lecture, is that what's published as science should be trustworthy. The refereeing process is maybe another issue. The current system of peer review has flaws, so you might want to change it. Open review, non-references, peer review on a period online before it sort of is finished. I'm open to discussing these things. That might be an improvement, but skip it as is that everyone can post a manuscript on the web without having to go through a peer review. I think that's again a dangerous position. So we could have talked a lot about this, but I'll just go to the next thing, which is maybe things that should happen. And that is to detect and prevent publication of scientific fraud. And fraudulent studies may be incorporated into clinical guidelines. And then you're sort of a double bad whammy. So if you look at the exponential growth in peer-reviewed journals, and I think all of you have repeatedly getting emails from obscure, unknown journals that said, yes, we'll publish your paper tomorrow. We can even publish an old paper, no problem. So these are predatory journals. And what's even more worrying is that the amount of retracted papers is enormous. So these are papers that some of them are fraudulent. Some of them are just outright fabrications. And they might end up, as I say, in our clinical guidelines. So why is this happening? Well, there's huge career pressure. We all know that. And it goes by the number of publications quite often. There might be a weak education in ethics and malpractice. And fraud and malpractice seem to be widespread and go undetected. And it's also a weak individual and institutional action and responses. And maybe a contributing factor is the massive expansion of journal titles. And not all, as you know, not all publishers are in it for the science. There's quite a few that are in it just for the money. And they want to reduce the quality of the peer review process to get the papers through. So we all aware of the evidence-based publication of evidence medicine, and there's this pyramid, randomized controlled trials and systematic reviews are on top of it. And I think it's even more important than ever that we secured the quality of this publication, these studies, because we are entering, as you all know, sort of a post-factual era where fake news, conspiracies, and alternative facts is flourishing. And we should be very careful so that we don't contribute to that, in the sense that people can point to us and say, well, that study was just fake. And they are right, it was fake. So we should be more vigilant in detecting scientific fraud. So if you look at prospective randomized controlled studies, of course you have the properly done multi-blind, multicentric with individual participation data available to scrutinize the study, sort of the gold standard. There are, of course, some with minor flaws. Could be former errors without major influence on the outcome. But then you have, of course, major flaws, consent randomization, data reporting, which has a major influence on the validity of data reported. And then, of course, we know that you have also outright fabrication, just invented studies. So since systematic reviews and meta-analysis are on top of the pyramid of evidence-based medicine, so as you would understand, of course, even a meta-analysis done properly by experts will be flawed if it turns out that some of the studies that was included was also flawed. So this is one of the speakers in this session, Ben Mould, sent me this as a reminder what's going on. This is from the Journal of Anesthesia, who's been trying to look back into the submitted randomized controlled trials that they got. And they find quite an astonishingly high number of the studies that's already been published by anesthesia. And I'm not saying that anesthesia is a bad journal, but in retrospect, they suspect that a large proportion of the studies are either fake or so fatally flawed that you can't trust the data at all. They're wrong. So what anesthesia, this is a retrospective study. This is the number of submissions going up. And then when they introduced individual patients or participants' data to be able to scrutinize the study, the detection rate of false or some studies are studies that are so flawed that you can't trust them, is going rapidly up. So in an editorial, they said that hundreds of thousands of zombie randomized trials circulate amongst us. I don't think we should be saying that this doesn't happen in our field. The anesthesia is just somebody is really trying hard to identify this. So if you go back to my home turf update, they have been looking, a group that's been looking at retrospectively into randomized controlled trials, and then said, what if you look at those trials that made individual participant data available to share, and those who didn't? And they said, could identify quite clearly that those trials where you had access to individual patient data is a higher quality. And if you look at the anesthesia, you can even use the analysis of the individual patient data to weed out the trials that are not good enough. So my thoughts, editors of medical journals should discuss whether all RCTs must provide access to individual patient data in order to be acceptable for publication. This is my view. I'm not saying that we have agreed on that, but I think that this is what I mean. So, and we should prevent fake news, because that will fall back on us heavily. So I think it's imperative that scientific journals increase their efforts to prevent fraudulent clinical trials being published. For RCTs, I think we should demand access to individual patient participant data. And there should be done an analysis of this data prior to publication. We're not there yet. And there's, like Professor Mo was in the panel, he's trying to, and his group is trying to develop techniques to analyze an RCT. So this could be done by all editors. And for systematic reviews, I think in the end, eventually only include RCTs with individual patient data. And in the meantime, maybe we should report data with or without these studies, see if it's different. So future, sort of from my perspective, things that will happen, plan as an open access. It might affect you differently around the globe, but I think eventually, because the funding bodies behind it are so influential and so big, I think it will happen almost everywhere. Things that may happen as a change in the refereeing process and the importance of impact factors. I'm not sure. The refereeing process maybe will be refined. But things that should happen is to increase the efforts to prevent fraudulent science to be published. That's imperative for us to be able to retain our standing in the communities. Thank you.
Thank you, Professor Sunday, for your beautiful presentation. So I will hand over the screen to Dr. Madhuri Patil for the questions and answer sessions.
Ben, I would like to ask you, as a screening test for the tubes, would you prefer doing an HSG or would you prefer doing a laparoscopy?
Yeah, thank you. I think HSG is fine. I think laparoscopy is a bit too much if you have no indication for endometriosis, and if your HSG is normal. So I wouldn't go for a laparoscopy for everyone.
The other thing is there are certain subtle abnormalities which present as unexplained infertility, like you have mild endometriosis or a subtle tubal pathology, premature aging, or even immunological fertility or sperm dysfunction. So would you like to rule out all these before you diagnose unexplained infertility, or you would just ignore these?
No, I think obviously if you don't try to explain, then you end up a lot of times in unexplained, so to say. So there should be a reasonable effort to find abnormalities, but in my opinion, they should relate really to a poor prognosis or a really indication of disease, and there should be a treatment possibility with it. So I personally think, for example, that the WHO criteria for abnormal semen are too loose, so to say. So we scare people, and so I think if your total motor count is 10 million or 15 million or even 8 million, that's not that bad. But there's always a gray zone. There is blocked tubes, there is open tubes, and there is always the patient with one-sided tubal pathology, etc.
So what would you do to, because there are many semen analysis being reported according to the WHO criteria. So would you add on any more investigations on the semen so that we rule out the other sperm dysfunction, if any?
No, I don't. I'm not a great believer in that. I didn't make a detailed assessment of all the DNA fragmentation tests, etc. I've spoken on that last year at ESHRE. I don't think they add a great deal to what we can offer our patients. Just one, and if it's in the gray zone or if it's abnormal, you repeat the semen analysis. For me, that's enough.
Would you do a trial wash to see what's the total motile concentration you get after a wash, or?
Yeah, but you learn that anyhow if you start to do insemination. So I think an initial assessment is good, and then I think one of the side products of doing IOI is that you get informed monthly about the semen quality, which can change management. We have some patients in our IOI studies who, for repeated poor semen analysis, then qualify for IVF or ICSI.
Yeah. Would you like to, when you're doing an IUI, you've got a sample, you process the sample. So would you think we do a sperm survival, I mean, for the quality control, but would you think a sperm survival, because there were 1 or 2 papers, but they were quite some time back, who looked at the sperm survival and probably predicted whether the sperm quality was good or not. So would you recommend doing a sperm survival in these
No, I wouldn't recommend it. I don't know any data that show, and I know the literature quite well, that show that makes the outcome better. So I don't see benefit in that.
I mean, any other chairpersons have any question for Professor?
Yeah. There was a question that out of this Pandora box of add-ons, which one you prefer most? Yeah, which one you would had a good experience of that you used in your clinical practice and it was very effective? I want to know your experience also.
Well, I don't think actually the data actually shows really actually should be recommended to a patient. So as you can see, if we think actually there's no good data, then we prefer actually conduct a study in our centers or maybe with some other centers as well, rather than actually offer the add-on therapy to the patient without good evidence. As I mentioned, actually, there's no actual green light in the FDA, so we are not actually offering this to our patients. And I don't think actually, unless we have more data, more robust data, otherwise we should not actually offer the treatment.
And what about other adjuvants in the form of medical adjuvants in the form of GCSF and all other medical growth hormone and all? Do you use in your clinical practice all this or not?
I do not use it in my clinical practice, and I don't mention it just because number one, I don't actually have any experience in using that. Number two, if you actually look at the evidence, I don't think actual evidence is really good enough for you to really use it. So I think you can actually read, I think there's on some therapies review published in Fertility Sterility, which I think is a good review in different area. We shouldn't actually think that something actually given to patient is really good. And a lot of patients believe that we have very good evidence, and then we shouldn't actually use this, patient's trust, and then we will lose the trust from the patients sometime later.
Add-ons are so costly. Sometimes the basic cost is doubled because of the add-ons that we definitely see in our practice.
Yes.
So I think Himanshu, you go
yeah.
to.
Yeah, Dr. Benmol, I wanted to ask you that you mentioned about doing 6 cycles of IUI, and we are seeing now the system that people are jumping to IVF very soon, that they don't give too much trial of IUI. They think that this is ineffective treatment. So what's your call on this, that whether we should do these 6 cycles in all the patients, or do you have any criteria in which you do an IVF earlier rather than later?
Yeah, thank you for that question. I think that the semen quality is important. If you run into very poor semen quality during your IUI, you might convert earlier to IVF or ICSI. I also think that 6 cycles is not written in stone, so there is patient preference, obviously, and individual choices. But in general, I think we should use the lower or the less invasive treatments more. One of the concerns I have is that you go immediately to the most heavy treatment and it doesn't work, that patients are left alone and they're actually missing out on opportunity. I think we should mainly aim to get the cumulative live birth rate as high as possible. And if you jump too fast to IVF and you bypass IUI or you bypass ovulation induction, then yeah, you potentially harm the cumulative chances of your patients. I'm quite concerned, but we see it everywhere. We see everywhere in the world a slight increase of IVF at the expense of the less invasive treatments. And let's not deny it. There is a commercial argument behind it. I was quite impressed to see that slide of Denmark as a market rather than as a patient. Yeah, I don't know. I've been vocal about it in the past. I've been heard also in Australia, but I'm 55 and I'm going to continue to speak out. And I would address everyone who is listening in the Zoom meeting to consider the less invasive treatments first and give it a little bit of time.
Yeah, I would also just like to add that many a times we see that some patients who insist, no, they want to go for IVF, though we've advised them IUI. And then when they fail, they don't come for some time, and you see that they come back with a spontaneous pregnancy. So I think counseling on the part of the physician plays a very important role as to how you counsel the patient. And if you counsel them that it's better to go for a non-invasive technique rather than going for an invasive, I think this would really make a difference.
Yeah, but realize also many colleagues say, yeah, patients come to us and they demand it, but they obviously demand it based on the information they get also from the internet. So I think we have a global responsibility to come with good patient information, good guidelines, etc., etc.
I have a question for Professor Sunday. Actually, you said that we could probably take author fees, and many of the impact factor journals really do not collect any fees, because if we start taking fees, I mean, they expect that the article has to be published, and probably then we would not be publishing good quality articles. So I think a double blinded peer review process, I think, is the best to maintain the quality of the journal.
I agree that the refereeing process there's room for improvements, absolutely. And how the money will flow in the future is a bit uncertain. We know how it will now operate in part of Europe, but I don't know how it will affect you in India, since India doesn't signed up to the Plan S. So you're still in a system where you have it's free to publish, but you have to pay to read.
No, I have also been an editor of this journal, and basically we give it free to all our members, the journal, and it is the society which pays for the publication. We don't charge the authors also.
Okay, yeah.
So,
that's possible. Yeah.
Yeah, so I mean, though we are now publishing for almost more than 13 years, but still that's what we are continuing, and we are paying quite a bit from the society, and basically if we get advertisements, probably that covers the cost, or it doesn't cover. But what I feel is, if we start taking, I mean, if authors start publishing on the web, or if we publish by paying amount, many a times what happens is a lot of biased data is published, but it could be fabricated also. And as you said, the patient data, getting information about the patient data, I think is very, very important, because many a times then we know what's the flaw with the study that has been done.
And that the open access or not doesn't automatically has an influence on the quality of the papers published. No, that's up to the editor policy to increase the vigilance, and also introduce methods that are practical in a daily basis to spot problems with a trial, and then perhaps go deeper into it and see if there's just minor issues or major issues, or even, as occasionally found, outright fabrication. So I think, but to my opinion, it's absolutely imperative that we are getting better, because we lose so much out in the confidence from patients and the society if we are not doing it better. Fake news, we are publishing fake news, and we shouldn't.
I mean, it really takes trouble for you to publish the right papers, and many a times we see the same author publishes, just makes a little change and publishes in 2 or 3. So I mean, that also, I mean, the editor should take care of.
Dr. Sunday, I wanted to ask that, do you see artificial intelligence or machine thinking coming into writing the papers? When people will not be writing, the paper will be written by the machines. Do you see that in foreseeable future?
My co-panelist, Ben Moll, is trying to fund a project which is partially involving AI to help us, because editorial offices are not immensely big, and there's a limitations of our abilities to go through everything. So if you have artificial intelligence, standardized models to pick out the ones that might be a worry, so you might go into going deeper. I don't think we get anywhere without having an assistance of artificial intelligence or data modeling or something. It's so complicated to go through a trial, every submitted papers for a fairly small editorial office. So no, in the future we need assistance. And will you add something to about your project of?
No. I mean, so thanks, Arne, and I'm very pleased that it's on the agenda. So thank you for picking that up. And it's a problem for all of us, but I think it starts with awareness, and it starts also with getting it out of the taboo setting. And I think you're doing that. I think there's also a big step to make in people who want to speak out of it, and I'm glad you do that. So yeah, there's no choice. It is extra work. It's sad that we cannot trust all the people in the world, but it's everywhere, right? If people have to pay tax, they make fraud. If they want to win an Olympic medal, they do it. So yeah, if they want to write a good paper, they unfortunately do it also. And you're right that the biggest concern is that there are patients at the end of this pipeline, right? I'm afraid that in the presentation from Ernest, a lot of the positive findings we have on add-ons are based on low quality and fabricated research. If you see that big difference in studies on assisted hatching, for example, the scratching papers, it's all very poor quality.
Ben, there's a question for you. Is the total motile sperm count a more precise estimate of males' fertility rather than the WHO criteria?
Well, it's a gradual scale. So, and I don't think that that if you have a total motile count of 21, that you're perfectly healthy, and then if you have 19, that you're completely abnormal. So, but I personally think that over a total motile count of 5 million, you have considerably good pregnancy chances, even with maybe IOI, and I wouldn't jump to ICSI too quick. I mean, we just completed a big study in Vietnam that was presented at ESHRE. That was normal sperm. ICSI doesn't give a benefit over IVF there. So, and that also in relation to the congenital anomalies that I showed, and the paper in Human Reproduction this week or last week, I think, we really have a responsibility here in not only creating as much children as possible, but also creating healthy children.
Then there's another question for you. What importance would you place to the duration of infertility when offering IUI versus IVF? Say if the woman is married for 7 years versus 3 years.
Yeah, I would always try IUI first for a couple of cycles. Because I think so the data from China, for example, that I showed are in a population where the average duration of infertility is 4 years, and still you see a considerable pregnancy rate there with IUI. So I mean, you should obviously look at the age of the woman and also how much time you have, right? Over 38, 40, time is going to press, but I don't think that 3 months of IUI make that much of a difference.
There's another question for Professor Andre. Himanshu, would you like to ask?
Yeah, you can go ahead, ma'am. You can ask.
A delegate is asking any quick way for a reviewer to assess if the number quoted in a study is correct or not, and it's whether it's correct or not. If there's any quick way for a reviewer to assess.
Not a quick fix. No, I'm afraid not. So it's nothing that pops easily, a checklist that gives you an easy answer on that one, unfortunately.
Yeah, Dr. Ruma Satvik had a question for Dr. Andresande, that she wanted to know that how will the peer review process will change? Like how would open peer review process will be an improvement over the current system? So
No,
just in one or two, yeah.
It's a good question because I don't know the answer. It's no, I'm quite happy with the current situation, but there's a lot of people saying, well, it should be open. I should know who's been criticizing my paper. That bastard, that's all wrong. So the idea is that reviewers will be more polite and so on. No, I'm quite happy with the current system. So it's the editor's responsibility to sort of go back to the reviewer and say, you can't say that, you have to well behave. No, but there's a lot of people saying, well, it should be open. So you should know who's reading and judging my paper. Well, I think all in all, the current system works.
Yeah.
Well,
I think a double-blinded procedure is best, where the reviewer doesn't know who the author is and the author doesn't know who the reviewer is.
But it's very difficult to have it blinded because most people write in my institution and since my papers, and I've showed previously and so on. So I think it's difficult to have it sort of blinded, double-blinded.
There's a question for Dr. Ernest, that what would you say ICSI for all is also a kind of add-on therapy and we should avoid, or are there some data over it? But because these things, the recommendations are changing so much. So what is your view on that?
You mean ICSI for all?
Yeah.
I don't think actually there's a good evidence that ICSI would improve the pregnancy rate in non-male factors and also mild male factors. On the other hand, I think ICSI reduced the pregnancy rate, and certainly the data actually is not a very recent one, because I think published in the UK's more than 20 years ago. I think people just actually think that it helps, and I think Ben probably has coordinated some studies in Vietnam and also in China, which I don't think actually there's good evidence that ICSI will improve the pregnancy rate. Not to mention about the risk of the congenital and also chromosomal abnormalities.
So the next question for Dr. Ben Moll, that during your practice, during the last 20 or 30 years that you might have been doing the practice, how have you seen the incidence of unexplained infertility in your practice decreasing? And what do you think would be the major area of research which we will again decrease the incidence of unexplained from the total known cases? What is the next thing from which we are going to get some answers?
So I'm not sure if we see a decreasing amount of infertility, unexplained infertility. I see an increasing amount because we declare couples earlier as infertile. So what I showed is that I think up to 10 or 15 years ago, a large amount of the IVF that was done was driven by tubal pathology, endometriosis, etc. And as a percentage that is decreasing, but the absolute number of procedures for tubal pathology actually stays the same. So what we're doing is we're doing more IVF for unexplained infertility. And so that's the first answer, the first part of the question. Otherwise, I think that we should study more in detail why unexplained, and I touched upon that infertility plays a role. So for example, if we see now that treatment of endometrial or myometrial contractions during IVF has a beneficial effect, then maybe there is also a patient category earlier that has a problem with myometrial contractions that can be treated in an isolation, right? It's a bit strange first to do IVF, and then if you have potentially pathologic contractions, you start to do that first. Same is true, I think, for endometrial receptivity, where I think we're only at the beginning of understanding what is happening there. And another thing that surprises me is that I think both in research but also in clinical practice, we seem to forget once we go to IVF what the cause is of the infertility. So it's just IVF as our disease entity, but I think there are substantial differences between somebody who has unexplained infertility and somebody who has tubal blockage. For a woman with tubal blockage, potentially the other fertility mechanisms will be normal, I expect, but we're not approaching it that way. To give one other example, I think you should, for example, interpret a semen analysis different if somebody comes with unexplained infertility for somebody who comes with PCOS. If the woman is not ovulating, then we should be much more liberal in accepting an abnormal semen result, and first let her ovulate and see what happens. But it seems like we do IVF, and then it seems a one size fits all approach, which I think a missed opportunity.
When you're doing an IUI, would you prefer doing about 3 to 4 cycles with oral ovulations, that is letrozole, and then if she does not conceive, at least giving a try with gonadotrophins for 2 cycles, because probably there's a slight increase in the pregnancy.
Little bit. We did a study in that, not in unexplained infertility, but in PCOS, and the additional value of gonadotrophins was limited.
Probably in PCOS, the main problem is anovulation. So as long as the woman ovulates, it's fine, because that's what seen. But in unexplained infertility, they say that there's correction of some subtle abnormalities which is seen when gonadotrophins are administered.
I don't believe that there are clear data that show that gonadotrophins help. I mean, what is potentially important is assess endometrial thickness. And if the endometrium is thin, I think, for example, on Clomid, then I think there is a good reason to change. We have shown that.
Okay. One question to Dr. Ernest. Role of additional diagnostic method like ERA. Do you go for this, Dr. Ernest?
I think actually there's some publications, a randomized trial on patient who actually is IVF naive. But the first theory actually goes to repeated implantation failure. But we haven't actually seen the randomized trial. I think it's ongoing, but I think for quite some time already. I'm not certain of the results, how we actually change our practice in those with repeated implantation failure. Well, I think we need actually more large-scale study to show that the cost benefits rather than just actually some improvement in the success.
One question, should laparoscopy be done in all cases of unexplained infertility before going for IVF? There's a question from the audience.
I think Ben has already answered that. So
No. I really think that we should stay away. I think a laparoscopy is expensive. And there is. I think if the HSG is normal, or you do a HICO-C that is normal, I think that is sufficient. Better put your money in treatments, I would say, rather than extensive diagnosis.
That's good.
I think we have another 1 minute to go. If there are any more questions, we could take.
Okay, if there's no questions, let me encourage the people the colleagues in India also to contribute to research. I mean, you have such a fantastic enormous population, and there are some colleagues I work with already who do that. But I would encourage everyone who is on the meeting and listening to contribute to that. That would be fantastic.
We will like to do that. We'd love to do that. And again, the question of patient data and the privacy of the patient data is something which we need to work upon before we can do that. So Dr. Arne Sunday will be telling about that thing, what is privacy of the patient data.
Ben, do you want me to forward your COVID questionnaire to people? I would do that.
Yeah, that would be very nice. Thank you.
I can do that. I can send it to all the ISAR members from my side.
That would be great. Thank you.
And IFS members also.
Yeah, I can send it. I mean, I don't have the email IDs, so you can give it to me and I can send it. Not an issue.
Okay, I think it's time now, 5 o'clock. It's 5 o'clock. Yeah.
Yes, I would like to thank all our speakers and our chairpersons for such a wonderful session, and it was very informative. And the President's oration has started in Hall A. I would request all of you. You cannot access Hall A through this link, so you'll have to leave and access through the delegates link for the President's oration in Hall A.
So good evening, everyone. We are now back. Hello, am I audible?
Yeah, we can hear you, Dr. Anupam. Go ahead.
So the next session for the day is now panel discussion. And to moderate this session, I would invite Dr. Abha Majumdar. She is Director and Head, Center of IVF and Human Reproduction, Sir Gangaram Hospital, Delhi.
Can you show your CV slide, Dr. Anupam?
I'm sharing my screen.
No, Dr. Abha has
Dr.
shared.
Abha has to stop share.
I'll just stop share. Okay, now you share yours.
Is it visible now, my screen?
No, it is not. Share again.
Okay, just wait a minute.
It's not visible, Dr. Anupam. I'll share it.
Yeah, Dr. Manishi, please go ahead. Yeah. Dr. Anupam, are you there? She can announce at least. Manishi, you go ahead and announce.
Okay. Welcome everybody. After the coffee break, we'll start the next session where we have a panel discussion. Our moderators are Dr. Abha Majumdar. She is the Director and Head at Center of IVF and Human Reproduction, Sir Gangaram Hospital, Delhi. And she's a past president of IFS. And next is Dr. Sangeeta Sharma. She's consultant IVF and reproductive medicine and center head at Jaipur Fertility Center. Our esteemed panelists are Dr. Manish Bankar, is the director of Nova IVF Fertility, Ahmedabad. Dr. Sankalp Singh, is director reproductive medicine unit at Kraft Hospital, Kerala. Dr. Shweta Mittal, she's senior consultant at Center of IVF and Human Reproduction, Sir Gangaram Hospital, Delhi. Dr. Rashmi Sharma, she is Director Origin Fertility and IVF at Delhi. Dr. Rajapriya Ayappan, Managing Director Srinivas Priya Hospital, Chennai, and she is Secretary IFS Tamil Nadu Chapter. Dr. Neeru Thakral, Fertility Specialist, Morpheus International IVF Center, Gurgaon. Doctor.
That's it.
Yeah. Stop sharing now, yeah.
Yes.
Dr. Abha can share her screen now.
I'll share it. Welcome everybody to this digital platform of Fertivision 2020 and the 16th Fertivision. I'm extremely impressed by the way the first day is running, and we will start straight away with ART complications. I have a great panel with me on this. We've already been introduced. What we've done is divided all our panelists into 3 groups. Group 1 is Dr. Manish and Neeru, Group 2 Shweta and Sankalp, and Group 3 Rashmi and Rajapriya. The first question would be directed to Group 1, second to Group 2, and third to Group 3. We have in total 6 case scenarios. I'm going to talk on complications of assisted reproductive technology treatment. and complications associated with treatment of the woman, like side effects of drugs in the form of ovarian hyperstimulation syndrome, risk associated with sedation or anesthetic agent, risk associated with oocyte retrieval, such as hemorrhage, infection, and torsion. And we will also look into complications of surgical sperm recovery risk, infection, bleeding, testicular atrophy, but something very surprising from this. And we will also look at the risk or complications which arise with the outcome, that is pregnancy, multiple pregnancy or ectopic pregnancy and heterotopic pregnancies. So this is all we are going to discuss today. I just brought in some retrospective data to you about 24,000 oocyte retrievals, and you find that the commonest complications are hemoperitoneum, pelvic pain, vaginal wall bleeding, bladder lesions, infective complications, and anesthetic complications. However, out of all these 96 cases, 24 surgical procedures were done, bringing the complication rate to about 1 in 250 cases, and the surgical procedure required in about less than 4, so that would be about 1 in 1,000. Having said that, what is it we have to be more careful about while doing our oocyte retrievals, and which are the patients who are most susceptible to it? Younger age, lower BMI. So thinner the patient, younger she is, more chances of problems. Oocytes retrieved, more the oocytes retrieved, more the duration of retrieval of oocyte, and last of all is expertise of surgeon. Having said that, I move to complications ahead. The case one I'm going to present, and then alternate cases will be presented by my co-moderator. So this question is for Manish and Dr. Niru Thakral, but others can pitch in. Please make your rooms silent so that no other voices come in. Mrs. SP, unexplained infertility, BMI 25 meter square, AMH 3.2 nanograms, underwent COS for IVF, antagonist protocol, recombinant FSH 200 IU, which was reduced to 150 after 5 days. Terminal E2 was still 3,413 picograms. GnRH agonist trigger was given. 26 oocytes retrieved on the 26th October 2020. So this is a very recent cases. These are all real life cases which I picked up. Post aspiration vaginal toilet normal, no bleeding. 1 hour later, complained of acute pain, abdomen with dizziness, vital stable, ultrasound, some fluid in POD, and Morrison's pouch. So my question to the panelist is, what is your differential diagnosis?
So
Manish or Niru could pick up this
yeah,
question.
I think this is not an uncommon scenario where a patient post-retrieval complains of lower abdominal pain, especially when we have such a high number of oocytes retrieved. Uh, since the clinical findings are not alarming, I would suggest we need to keep the patient under observation. If you are worried, you could get a blood counts done, so at least it will give us a baseline information on what the patient's hematocrit hemoglobin is. Keep her under observation for the next couple of hours. Keep an IV line open, because the two things that you're worried about in this scenario, one is an intra-abdominal bleed, and second is a very early torsion, because both the things are both the things do tend to mimic each other, and in both the scenarios the immediate treatment would be to keep the patient under observation.
Yeah, very good, Manish. And I'm sure you can look at the counts now. I've just given that we did what you said.
Yeah.
Now, pre-aspiration hemoglobin was 10.8 gram percent.
Yeah, so I think
Anyways,
this is still not an alarming fall. I
still
think
manageable.
I would still keep the patient
Right.
under observation and see how she behaves.
So first differential diagnosis will be the intra-abdominal bleed. Second will be the OHSS. Because
Yeah, right.
hemoglobin
So,
pile is little alarming in this case,
And
even
yeah,
though
now,
vitals are stable. But
one thing
still,
we should not be, ignoring is torsion, because I've seen ovarian torsion so early after pickups of a large number of oocytes. So these are the two things which you should keep in mind.
that's very interesting, Manish, that you can see a torsion within 1 hour of oocyte pickup. Well, we insisted on admission, but patient refused and went home as felt better and was related to a doctor. She came back at 1 a.m. early morning with dizziness and pain and vomiting. Like you said, we should have kept her under observation, but these patients are all daycare patients and she refused. How will you go forward? Now, these are her findings. Hemoglobin dropped to 7.6. We gave her all this through the night.
I think this is a patient in whom, to be on the safer side, I would maybe put in a telescope and see whether there is any active bleeding. Or and second thing, when you do the ultrasound, put the color on and see that she's not having a torsion as well, because
Okay.
so again, since there is a further 1 gram drop in hemoglobin from what you had seen immediately post-operatively, and she's still symptomatic and has come back to you again, maybe
Yeah.
there's some point in putting in a telescope and ruling out internal hemorrhage.
Yeah, my view is
Telescope at
also
this
same.
stage, yeah.
I
Okay.
will also like to put the scope because hemoglobin is falling too much
All
from 10
right.
to 8 and then
So,
7.
we gave 1 unit of blood, repeat ultrasound in the morning, same amount of fluid, and we did look for torsion. The blood flows to ovary were normal. So, repeat hemoglobin in the morning was 8.3 after giving 1 unit of blood. And till evening, we had to keep her with great insistence, and she was discharged. Now, suppose the scenario was this: if the hemoglobin was 1.2 gram in the morning, further dropped after even giving her 1 bottle of blood, both our panelists feel that we should have put in a scope. Any other panelist out of group 2, 3 would say otherwise, because you know she's a hyperstimulated patient, large ovaries, very hyperemic, and there would be considerable ascites also inside. Anyone out of
I
the
would
group
like
2,
to,
3 would
yeah,
make a different comment, or everyone
yeah.
I think if the
believes in
PCV is, yeah, yeah, if the PCV is falling, then we will start suspecting, hemorrhage. So if we can distinguish between hemorrhage and fluid coming, because such early the OHSS fluid will not come ascites.
Right.
So
Yeah.
it would still go in favor of a hemoperitoneum and acute surgical emergency more than anything else.
Yeah, we
So all
don't
the
see
panelists feel,
OHSS so early.
no,
Even
we're
though
not talking, but you said, Manish said you put in a scope. Everybody agrees that you should have put in a scope by this time, or you would give more time to conservative treatment?
And we should give a little more time
Bit
because
more time.
the torsion pain will be really, really terrible, not
No,
amenable to
she's
the injection.
that way. Pain is not so severe for her. It's very little. It is more of scared. If you see, her symptoms were relieved here.
Yes.
And urine output was okay. She was all right. But suppose the hemoglobin fell lower, then Manish, you would have gone in with a scope.
I think this is a very catch-22 situation. I mean,
Yes,
the
that is why I
parameters
brought
are
it
borderline.
here.
I think retrospectively what you did turned out to be right. But if the hemoglobin had dropped half a gram more, you would have your heart
Yes.
in your mouth. So
Yes.
I think this is where your experience comes in, because you cannot simply treat the patient based on the blood reports and everything. You need to
Right.
see the overall picture.
Exactly.
Maybe
Did you
is her
not see my last
tachycardia?
sentence? Thanked God and discharged her. It was just lucky that we didn't have to go in with a scope.
I think
Otherwise, we would have been in a
one
mess.
thing we can check is her pulse remaining stable, or is she developing tachycardia? Because I think hemoglobin would drop later
Yes.
than that. So maybe
Yes.
something on the pulse count would have given us an idea. If the pulse is stable, then maybe I would still like to keep her under observation.
Under observation.
Yeah.
So the last word is that we would want to observe her till we find that there's no way out and we have to go in with a scope, because it's going to be very messy inside. Large ovaries sort of oozing from everywhere, and it may not be. So as a take home message, what would be your sort of take? I brought this earlier. Manish or Niru, what would you say what should be the take home message after looking into this case?
observation is essential. It's very, very essential. In observation, pulse BP monitoring is very, very essential. Secondly, hemoglobin, yes, we definitely see urine output because our vitals are stable, so then we can have satisfaction. If the pulse is high, then I would like to put a scope and sleep nicely in
Okay,
the
so
night.
that's gone. Now, suppose this was the same patient which we sent home. As a rule, last 3 years we are doing this. Before sending home after OCR, 4 hours later, all patients have to have ultrasound evaluation of fluid in pelvis and assessment of vitals before they go.
Yeah.
So this is case number 1. Well, she made 4 blastocysts out of those so many oocytes, all were vitrified. She's just had one transferred on 26th November. Let us see what happens. Case 2, Sangeeta, please go ahead. Sangeeta? Dr. Sangeeta? Dr. Sangeeta, are you there?
Yeah, am I audible, ma'am?
Yes, now you're audible.
Okay.
Yeah.
Yeah. So this case goes to group 2, which is Dr. Shweta and Dr. Sankal. And she was Mrs. S, 29 years old. The BMI was 27. primary infertility, underwent IVF ICSI for male factor for the first time. Gonadotropins were started in the dose of 225 IU. It was an antagonist protocol. The terminal E2 levels were 2200 picograms per ml. She was triggered with recombinant HCG 250 micrograms. 12 oocytes were retrieved and a fresh DRE3 transfer was done with 2 embryos. And after 2 weeks, beta HCG was positive. Now at 6 weeks of gestation, the patient presented with acute pain in lower abdomen, more on left side, along with vomiting. So what can be the possibilities? Dr.
Okay,
Shweta,
so if we analyze this case, she was like a normal responder with a fresh embryo transfer and 2 embryos are transferred. I like to do a transvaginal scan at 6 weeks, but if in case it has not been done, so if a pregnant patient comes with acute pain, the first thing I want to rule out is that is she harboring an ectopic, or is she harboring a heterotrophic pregnancy? This is very important because 2 embryos have been transferred and all our ultrasonologists are tuned. Even if we are doing it ourselves, we need to be tuned that we are looking at. And then others could be, yes, a stimulated ovary. So here with pregnancy can go through a torsion and it's on the left side. So I'm not even thinking of appendicitis or and then there are the non-gynecological causes, which we need to keep in mind, and especially if she was endometriotic cyst also, then that also needs to be kept in mind.
Right.
Sankalp,
So Dr. Sankal, yeah.
And a corpus luteal hemorrhage. And a corpus.
Right. Okay. So an ultrasound was done for this patient, as Dr. Shweta said, and it showed both the ovaries were enlarged with multiple large follicles. Left-sided probe tenderness was there, and also an intrauterine single gestational sac was seen. The beta HCG levels at this time were 12,000 milli-international units per ml. Doppler flows were put on the ultrasound and it showed that this is the left ovary. So left ovary, the flows, they were partial, but it was not certainly ruled out whether it's an ovarian torsion or a tubal pregnancy. So what would be your next step in managing her, Dr. Sankal?
By the look of it,
diagnosis was a little inconclusive. So how would you manage? Yeah. She was still in pain.
Yeah, by the look of the ovaries, it doesn't look like a hyperstimulated ovary by the picture which is there right now. So I don't expect the ovary size to be huge and the OHSS being the primary cause. Now, if we are not sure, and I expect that in the ultrasound there was no intra-abdominal fluid collection which was seen as well, which could have suggested to us that it might be a heterotopic or an ectopic pregnancy with little bit of bleeding intrauterine. If these things are not there, then we should be going ahead with the conservative management, because if it's this type of situation might arise in a cases with where there is a partial torsion of the ovary, but it is not tossed completely around its pedicle. It's only a partial certain degree of
torsion. Yeah, but she was having acute pain in lower abdomen. The pulse was 100, the blood pressure was still 100 by 70 millimeters of mercury, but she was in acute pain and it was not relieving.
I would be giving her antispasmodics and painkiller right now.
Yeah, all those things were given.
Right.
If she has not responded to this, then I would counsel the patient and we'd go ahead with a laparoscopy. Okay.
Yeah.
Because
Shweta,
in that case,
so I think a daily Doppler flow is only thing, keen vigilance, because yes, I agree with Dr. Sankalp that if no relief with analgesia, then we must suspect torsion and we can go ahead with a laparoscopy.
Right. So a laparoscopy was performed and it showed left ovary which had undergone a torsion. It was detorted and the color gradually changed to normal. Although unfortunately later on there was the missed abortion of the intrauterine pregnancy which was medically terminated. So you see how a timely suspicion and diagnosis and management could save that ovary. Now, how can you ensure that she does not undergo torsion again during the next few weeks of pregnancy? Or any other risk which comes to your mind that during detorting, any other complications which could happen and you should be a little alert of them perioperatively?
Sankalp and Shweta, anyone can take up each question.
We could have done an ovariopexy, an ovarian ligament fixation, so that
with a pregnant uterus sitting there.
Yeah, you can just take a suture and it can be done. It's like a buckling up suture, which can be done.
Okay.
And of course, you can debulk the ovary. If there are multiple follicles, we can puncture and we can make it a bit looser. But yes, in pregnancy, there can be a lot of bleeding too.
Bleeding, yeah.
So maybe we'll just have to detort and maybe fix the ovarian ligament and come till the time she's pregnant.
You feel the same? Everybody feels the same?
Yeah,
Dr.
one thing is
Sankalp wants to add something.
in some of the situations, some of these cases, the ovarian ligament might be very long, and that might be the reason that the ovary is very free and can undergo torsion. In such cases, application of the ovarian ligament, making it a little smaller and taut, also might help in reducing the risk of detortion again later in the pregnancy. And the risk of detorting, which is there, thing is, if it's a hyperstimulated ovary, the chances of hemorrhage is there when we are detorting the ovary. So that has to be kept in mind because there is a pregnancy as well. So we don't want to maneuver too much intra-abdominally as well.
What other risk comes to your mind? Anyone out of all my panelists?
Abha, I think I would feel that the risk of repeat torsion is not very high. And I think in a case like this, I would simply untwist the ovary, put it in the pouch and ask the patient to rest for a week. I think doing plication or other measures are really scary in the presence of a
pregnant. So I think they can be done in case the patient comes to us with a recurrent torsion and then we are correcting
but she
it
wouldn't
again.
come. As pregnancy advances, the ovary will become smaller and smaller.
It will dissolve very fast.
So any other risk which comes to your mind?
I think just slow detortion, so that all the accumulating substance.
Which we have to think about.
At the time of detorting, would you like your anesthetist to be a little more alert?
Yeah, that's what I was saying.
Hypotension.
That all the the products could be released to the circulation. So, but then nowadays I don't think I hear that so much as compared to in my medical college days, where they used to say that you have to detort very slowly.
So would be there with a thrombus which may have formed in this area.
Yeah, so that is the advantage of timely diagnosis. If it becomes a little late diagnosis, probably we would encounter a thrombus in the vessels, increasing the risk of thromboembolism or pulmonary embolism also. And there could be risks of septicemia and peritonitis by the releasing toxins. But all these things happen in the later stages if we are, delaying the diagnosis.
In that case, you remove the ovary, I think.
There was a case where I couldn't salvage the ovary at all, and I had to remove the ovary.
Okay.
So what is the take-home message the group 2 can tell us? What is your take-home message from
I think very early suspicion. Early suspicion is the most important, and a very good Doppler flow study is the key to pick up an ovarian torsion especially. And I think heterotrophic pregnancy is something which I always keep in mind.
Would you tell us who are the ones who would have this complication more often? When you go back to the pathology of the patient and look, why did you take her for IVF? Will that help you in sort of thinking that this girl can have a torsion and this can't? Anything which makes you,
or in other words, in which cases you would feel that torsion is very, very less common and should not be among your DDs or last in the list? In which cases?
Pelvic pathologies, in which there are pelvic pathologies
like endometriosis.
Yes. So whenever there are pelvic adhesions.
But male factor, yes, I am worried.
One more thing, ma'am, such kind of acute pain, sometimes we need to rule out renal colic because such terrible pain, just one-sided, so good ultrasound KUB is very, very important along with the usual color Doppler and ultrasound, because so many times we end up with renal colic.
Your suggestion taken and forwarded to all the delegates that even a KUB may be important in such a case. But then it is the clean pelvises which go through torsion more often than cases which have a lot of adhesions with endometriosis, etc. So
even pregnancy,
pregnancy
is, yes,
just a minute.
Appendicitis also.
Sometimes that is all done. Medical complications.
Non-gynecological reasons.
One more thing I would like to just put up over here is that the more prone cases are the ones which the ovaries are anterior to the uterus, in the just between the bladder and the uterus. Those are the ones which are more prone for a torsion, and the posterior ones usually are safer. Also, one of the other things which I would say as a take-home message is that we cannot always depend on a color Doppler to rule out a torsion. It's a modality which helps us, but it doesn't rule out a torsion in all the cases.
I'm very glad you brought this, Sankalp, because we lost a ovary of our patient because the ultrasonologist could not tell us that there is a complete absence of blood flow, and we kept on thinking that it's just one of the DDs and she doesn't have a torsion thing. So it's very important that we cannot depend on the ultrasound Doppler flow completely. We'll move to the next case. This is more of a narrative. Very little input from the panelists would be there. I'm sorry about that. But this is a 31-year-old lady presented with infertility for 2 years. She had history of laparoscopy followed by exploratory laparotomy with right oophorectomy 3 years ago. Frozen section and histopathology revealed well-differentiated mucinous adenocarcinoma of right ovary with no capsular invasion and no nodal involvement. The gynae-onco team allowed her conception 2 years back, but she could not conceive. AMH was 2.38 nanograms, and she came to us for IVF. We used an antagonist protocol with letrozole all through the cycle to keep her E2 levels low. Rec FSH 200 units for 8 days. Final E2 was just 445, dual trigger, 10 oocytes from left ovary. 2 grade 4 embryos were transferred on day 3. Now we step into a great puddle. 4 days after embryo transfer, she came to emergency with acute pain left lower abdomen. We thought of all the possibilities which we've just discussed with all of you. Well, we did ultrasound, moderate ascites with left hydronephrosis, no evidence of ovarian torsion. MRI was done immediately for her, loculated fluid collection around left ovary with left ureteric compression, injectable analgesics, no relief. Way forward. Group 3. Dr. Rajapriya? Hello, are you there? Hello?
Dr. Rashmi and Dr. Rajapriya.
Rashmi and Rajapriya, are you there?
I'm here, ma'am.
Yeah, Rashmi, way forward. Would you think of anything? We've just given you this much. This is your patient and she comes back. We were in a C.
It's surprising how much of ascites she has developed within 4 days of embryo transfer. And
there is left hydronephrosis.
Left hydronephrosis.
There earlier.
Yeah.
So way forward. Well, we didn't know what to do, so we consulted a urologist. I'm just narrating this case because we all should be sensitized to such things happening. They advised drain collection to remove the left hydronephrosis and pain. I mean, to relieve the left hydronephrosis. Ultrasound guided drainage of 500 cc of serosanguinous ascitic fluid was done and her pain was relieved. Cytology, negative for malignant cells. Fluid had to be drained twice in interval of 2 days, but the pain kept reappearing within 2 days. Eventually, third time, they put in an indwelling peritoneal catheter. Meanwhile, her beta HCG report came positive, pain subsided, and she was very happy. Was discharged in stable condition after 11 days with catheter in situ and oral antibiotics. 7 days after discharge, she came back again with severe pain and vomiting. The catheter was found blocked and hence fluid collection was there again. The catheter was replaced. Now, how long do you think we could leave the catheter and what complications could happen if we left it? We were in a C. We had no one to ask what to do next. Patient was not ready to hear anything about terminating pregnancy. All right.
This looks like an abdominal compartment syndrome, a typical abdominal compartment syndrome where the fluid localized gets entrapped in between the adhesions because she had this history of surgery. So maybe because of the pregnancy and maybe because of a little mild hyperstimulation, she was having a localized collection, which was
Excellent,
really
Rashmi. I'm so glad you brought this forward because this is what we have to think, that this was a compartmental syndrome which she had. And it was with great difficulty that we thought that this diagnosis should be correct. But then when we left the catheter after 2 weeks at 8 weeks pregnancy, she developed high-grade fever for 2 days. Counts were 26,000, polys were 92, blood culture, urine culture, drain fluid culture was still sterile. So she was, we did ultrasound because it was now 6 weeks and we found a single intrauterine live pregnancy. We started her on Magnex and fever subsided. Now we gave her the option that you have to terminate this pregnancy, but the couple refused and opted to continue. Rashmi, you tell us, what would you do for a compartmental syndrome like this?
Ma'am, drainage is one of the options. Definitely, I think it's only drainage which actually helps these patients. And we just hope and pray that this kind of fluid collection is a temporary thing. Like in this case, maybe it's just related to the ovarian.
I think you can read my slide, because it is exactly what you are saying. We had to do that only, and this was our first experience to have a case like this. What you're saying, you can just read. The catheter initially drained 50 to 80 ml fluid every day, but gradually it reduced to 5 to 10 ml per day, and the catheter was finally removed at 22 weeks, and 35 weeks she delivered. So a message from this, Dr. Rajapriya and Rashmi?
I think it's
we have to keep our minds open for everything.
Yes.
These are rarest of the rare things.
But the drain was kept through the entire course of the pregnancy as per the surgeon's advice?
By the urologist till 22 weeks, till the drain fluid became very, very little. She just started draining 5 to 10 ml a day. That was the time when we could remove her drain at 22 weeks.
Abba,
So this is a learning lesson for us also.
Can I make a comment, Abba?
Yes, yes, please.
Two comments. I mean, and this is all retrospective wisdom. Not that I would have done anything differently, but in patients who have malignancies, I generally tend to do a freeze-all cycle, especially if she has an ovarian malignancy. Maybe giving her an agonist trigger and doing a freeze-all, even though the E2 levels were very low, it would have been better. Secondly, because hyperstimulation can strike at any number of oocytes.
Yes.
And in a patient in whom we cannot even dream of having hyperstimulation, maybe erring on the safer side would have been better. Again,
I'm
as I said,
very
this is all
glad, Manish, you
retrospective.
said this, because this is really what we should have done. We should have frozen her embryos, because in a stimulated cycle, transferring maybe created the whole problem for us. So I think this is a very good take-home message, that any patient who's had exploratory...
And in a desperate situation, I think termination of pregnancy.
No, she did not.
In a desperate situation, termination of pregnancy. Yeah, I mean,
we could not have forced her.
Is the one which I think we need to keep emphasizing.
So for the next pregnancy, if suppose she comes to us, would anyone tell her something else or suggest her something else?
I will do what Manish just told, I think. I'll just freeze her embryos and do a frozen embryo transfer.
See, because her E2 levels would have been falsely low because of the letrozole.
Because of the letrozole,
because 10 number of oocytes, maybe the actual E2 would have been higher.
So do you think surrogacy is something which can be
I was
advised
coming up
to
to
her?
that. Would anybody suggest surrogacy?
As a suggestion,
at
yes.
Least.
Because now she must have gone through one surgery too. So surrogacy is also another option.
See, surrogacy will always remain an option, but for her, the risk is from the stimulation, not from the embryo transfer.
Very correct,
Manish.
But the laparotomy.
I don't think surrogacy is going to make, because once you do a freeze-all cycle, the frozen embryo transfer does not put her at a high risk.
Yes.
So provided, such patients didn't have a bladder injury during cesarean. I think this patient had, if I remember correctly.
Yeah, I haven't brought the whole thing here. I think I've written here. Yes, injured and repaired. I've written bladder advanced up to fundus, injured, and it was repaired, and male baby shifted to NNU and was discharged after 5 days. So she was still discharged with a bladder catheter inside.
So something with the kidney and the bladder has created more disaster for her.
Not really, but maybe that laparotomy created the whole disaster. Like Rashmi said, it was a compartmental ascites which caused extreme pressure and pain, and every time that was relieved, her pain went away. We'll take up the next question now.
Yeah, let's move on to the next case. Yeah. So this is the fourth case, and it goes to
real life cases.
Yeah. So it goes to group 1. He's a 34 years old male posted for surgical sperm retrieval for non-obstructive azoospermia under anesthesia. There were no other comorbidities. He was non-obese. Operatively, there was a transient fall in SpO2, and jaw elevation was done by the anesthetist for a better airway and ventilation. SpO2 returned to normal within seconds. On the same day, late in the evening, the patient called us and complained of numbness on right cheek and mouth, deviation of mouth to one side while smiling, and drooling of liquids while drinking. So what comes to your mind? What do you think would have happened to him, or what would you suggest him now? How would you proceed?
It comes like a facial palsy due to post anesthesia.
Yeah, it could be a facial palsy because all the symptoms are going in favor of that. So would you take a neurologist opinion now?
Yeah, definitely. I will.
Yeah, but I think our anesthetist did not agree to that. He said there must be something, a middle ear or some defect which could have triggered this. Just jaw elevation alone should not do that. Manish, would you also want to comment on
exactly
this?
This is what, ma'am, our anesthetist also told the patient, because we told the anesthetist also to speak to the patient. So she said that it has nothing to do with our drugs and our procedure, and she suggested a neurological opinion to be taken, and we did that. Okay. So Dr. Manish, would you like to add something?
I think a simple jaw elevation leading to a traumatic facial paralysis is extremely rare.
Very
But
rare.
no matter what the reason, if the patient has symptoms, in today's era of medical legal safety, we need to take a neurologist opinion. That is
because the patient repeatedly said that I was absolutely fine till this procedure was done to me. So we took a neurologist opinion, and nerve conduction tests were done, and a right-sided facial palsy was diagnosed, which was of lower motor neuron type. And rather, the patient took opinion from two neurologists, and both of them said that it is a case of neuropraxia, where traumatic peripheral nerve injury has happened, probably due to that vigorous panicky jaw elevation, which came to their mind, nothing else. And presently, the patient is on steroids, and we hope that he recovers in 1 to 2 or 3 months maximum. So what are the take-home messages from this case? What would you like to counsel the patients pre-operatively, not only regarding the procedure, but anything related to anesthesia? What written work would you complete? Would my panelists come up with that?
If you see, all our consent forms do mention about anesthesia complications, but having said that, you cannot overemphasize on complications of procedure. That is the challenge that everyone, especially in a procedure like this, if you are doing a testicular aspiration and you counsel the patient about risk of anesthesia, I don't think any other patient will come forward for a while.
Right.
So
but I think,
we have to be very, very candid. We have to underplay, and we have to be factual that the risk of anesthesia is for every patient.
But written consent is very, very
this
essential.
Is very interesting. Yes, this is very interesting.
Very essential.
This patient actually came to us a few days before Diwali, and he was very keen. He was asking that it's a low-risk procedure, nothing is going to happen. And at that point of time, I had to tell him, see, it's a low-risk procedure, but then things might happen. So later on, we were remembering that conversation. And like Dr. Neeru said, that written consents are must. Otherwise, we can land up in problems and medical legal issues.
Especially so this patient, era, medical legal era.
Yeah. And this patient had emotional setback also, because sperms were not retrieved. We had sent a tissue for histopathology, and it was arrest of spermatogenesis. I don't know how the previous report said from somewhere else that sperms were there. So this patient, and she was for donor insemination, and they started telling us that now all these complications have happened. Can you give us a twin pregnancy? Can we have a male child? And all those things started. So because we had all the written informed consents in place, not only for the procedure, but for anesthesia as well, we could get away with the situation, and also in an empathetic
Doctor,
way.
1 minute. Anything more, Neeru or Manish? Because my anesthetist said, no, it cannot happen by a simple jaw elevation. And you have to have a very thorough checkup for the patient to find out what really triggered. There could be a osteoma formation.
We thought of getting a CT and MRI done, but both of the neurologists, they said that it seems to be a lower motor neuron type, and therefore they didn't even order a CT and MRI for that patient.
So, this just raises a question that when we are in an institutional practice, we completely leave it on the anesthetist to make their consent forms, and maybe with the medical superintendent it is made. But when we are in the standalone units, I think it's very important, because how we have ICMR consent forms, maybe that has to be looked into, that what is the standard consent form which is acceptable if you are taken in the court of law. It just makes me ponder after hearing
Any more
this
comments
case.
on this case, and we'll move on to the next one.
The only issue is
Have been a coincidental Bell's palsy.
Exactly, that is what I was coming to. That I mean,
exactly,
it would be impossible to have a causal relationship with this. It could have been incidental, but again, how do we prove this?
Yes.
Yeah,
that is the. This is what my anesthetist told me today, that it could be an incidental Bell's palsy triggered by that jaw elevation, but something more was there.
In any case, patient will always link it.
Maybe. Even we were thinking all that, but he was completely asymptomatic before that.
Especially
So
because
we move on to the next
That
case.
is the reason. Now, next case, I move on.
Yes.
And this is Mrs. X, 28 years old. Now we've come to complications after, we've done embryo transfer. Mrs. X, 28 years old, married for 5 years, underwent IVF for bilateral tubal block, antagonist protocol, FSH 225, 4 oocytes retrieved, 4 blastocysts formed, 2 fresh blastocysts transferred, and 2 were frozen. Beta HCG positive after 12 days, 686. Luteal phase support continued. First scan 2 weeks later showed a single intrauterine gestational sac with a pregnancy of 6 weeks. Cardiac activity there. Right ovary enlarged, multicystic, left ovary almost normal, and everything else was normal. And she was advised a NT-NB scan at 12 weeks. Now, this patient presented in emergency at 9 weeks with severe pain in lower abdomen on the right side, nausea, giddiness, and collapse. Examination showed she was still sort of she was sinking, but not so bad, per abdomen, tenderness in suprapubic and right iliac region. Single intrauterine live fetus of 9 weeks with cardiac activity there, early forming placenta, no retroplacental collection, internal os normal, and there was a heterogeneous mass of 3.5 into 4 centimeters in the right adnexa with increased vascularity, free fluid in the pouch of Douglas, probe tenderness in right adnexa, ultrasound with power Doppler for blood flows, ruled out ovarian torsion. Now, differential diagnosis, we go back to group 2 now. And differential diagnosis, very obviously it looked like heterotopic pregnancy to both of you, or something else?
No, it's heterotopic pregnancy because it's very clear from the way she has presented clinically.
Yes,
Firstly, I mean, it's very clear from the way she has presented.
Now, my questions are, could it have been diagnosed?
No, yeah, I'm just coming to that. The first thing is
the
that
questions are, yeah.
The first thing is her beta HCG, the initial beta HCG value was high, and that was 600 plus. So first beta HCG is high. So the first thing we should do in any case, in all the cases, ideally, we should be repeating the beta HCG after 48 hours to see how much it is increasing.
Okay.
That is the primary thing, because beta HCG is the initial only modality which will help us to suspect an ectopic pregnancy. So the second beta HCG would have given us an idea as to how much it is increasing. After that, when the ultrasound was done, the right ovary was found to be multicystic. That means that the right transvaginal ultrasound on the right adnexa was not very easy. So that might be the reason. So I think the only way we could have avoided it is we should have expected to see 2 fetuses at this beta HCG. When we saw only 1 gestational sac, we should have looked actively for an ectopic pregnancy, that is a heterotopic. And if we don't find it, then we could have repeated an ultrasound again after a week's time, rather than waiting and giving her an NT scanning appointment at 11 to 12 weeks.
Correct. I think you have hit the nail on the head. And we have 2 more questions here. Is ectopic pregnancy?
Ma'am, I have one.
Yeah. Yes,
I have a point. Beta HCGs are very misleading, especially when we are looking at heterotrophic pregnancy. Most of the times in this, because practically we see a doubling, especially in such cases. Even with like a 500 beta HCG, we generally don't see an adverse outcome at all. So I think it was a high degree of suspicion, but nothing else could have really happened with a multicystic ovary. For an ultrasonologist, even to pick it up without a cardiac activity outside is very difficult. It's a challenge. But yes, probe tenderness would have been the only thing.
But then Sankalp did say that a careful...
at 6 weeks needs to be kept in mind.
1 week later again, when we saw that. Now, I want another question, because I've seen IVF specialists counseling their patients that you've come with ectopic pregnancy. Is ectopic pregnancy more common with IVF than natural conception? Sankalp or Shweta, you can go ahead with all the questions, whoever wants to.
IVF pregnancy? Shweta, go ahead. Please. Please go ahead.
So, I took out a 5-year data. I took out our 5-year data of IVF, and what I noticed was that in slightly higher incidence in stimulated cycles and fresh transfer. However, in the frozen ET, they are very low. They are even less than 0.5%.
No, but
So I
otherwise, if
don't
we
think
compare,
that the incidence of ectopic is high.
okay, is
It's
heterotopy pregnancy
not
common
high
with
as
IVF?
compared to the natural conception. Yes,
Okay.
I think
Sankalp?
heterotrophic is more common with assisted conception.
Sankalp, anything different?
No, ma'am. I mean, the ectopic risk, what I agree with what Shweta is saying, no difference in that. The
Right.
only thing I would like to comment over here is pertaining to the beta HCG, that what we follow as a practice is,
Yes.
what we follow as a practice is whenever we have a doubt regarding any patient, say a previous ectopic pregnancy, or the first beta HCG is very high or she's a tubal factor, then we don't repeat the beta HCG after 48 hours. We repeat it after 7 days. And we see the ratio of the 7th day beta HCG and the day 0 beta HCG.
Okay.
And if it crosses more than 15, then it rules out an ectopic to a larger extent. And importantly, in the study which was in which this particular data was published in 2010 in RBM, they even ruled out, they were able to diagnose heterotopic in all the pregnancies, with the logic being if two embryos, both of them are growing and the beta HCG production goes in the same rate, the ratio would be crossing 15. But if one continues to grow and the second slows down because of being an ectopic, the ratio of 7th day versus day 0 will come down to less than 15, and that will raise a suspicion of a heterotopic again.
I think this is a worth trying experiment, which you said in 7 days, if we can have a slight doubt also that we are looking into a ectopic or a heterotopic pregnancy, it would be like work wonders. So I'm glad
Especially
if
if
you
you're
can forward
getting
this paper to
more
everybody
embryos.
and we can work on it and do
Can
a
I make a comment,
multi-centric.
Abha?
Yes,
Can I make?
Manish, please.
I think the
please.
biggest challenge which all of us IVF specialists feel is that every IVF pregnancy you need to have a high suspicion of heterotopic pregnancy.
Yes,
But it is
that with more than one embryo
but it
transfer.
is practically impossible to have that same degree of suspicion when you scan every pregnant patient, because you are actually scared to scan these ovaries. So even though we want to be more vigilant, a significant percentage of patients heterotopic strikes by just out of the blue. I
I
mean,
think what
that
Sankalp
is
said
something.
makes sense that you
So
don't
the
scan,
only,
but after
so I will
7
come to that.
days.
So the issues here are there are no beta HCG cutoffs which can help you
Yes.
differentiating a singleton from a twin. So first
Yes.
of all, if you've seen a singleton tag, do you still look for the heterotopic twin, or you accept a singleton and leave it? Because there are no HCG cutoffs. And the second issue of doubling of a heterotopic versus a single normal with another missed, all these are extremely gray areas. So other than having a high degree of suspicion and very well accepting that this is a limitation and we might miss or we might not be able to diagnose every heterotopic as we should have, that is the unfortunate reality of our branch.
So, Sankalp, you agree
Yes, ma'am.
with this also, but then your suggestion that
Is
maybe
what
a small study could be done for all IVF patients where we do a beta HCG after 7 days and look at the outcome and see how true this statement is? Because it's never
Actually,
come into practice, never heard of it into practice that, if it goes up 15 times.
Actually, ma'am, we are using it since nearly 7 to 8 years
All right.
in our center. In whichever cases we are having a doubt, and actually,
In
touch
every
wood till
case, you
now.
can do it. Every case, it can be done. A repeat beta HCG after 7 days shouldn't pose
Actually,
any
most of the
problem.
patients are not not from the local area, so they go to their hometown, and then repeating another lab becomes a little
Okay.
tricky then.
My
But,
only point is that
But
I
I
think the
agree
best,
with Manish also what he said.
if yes,
Yeah.
if we suspect, then at 5 weeks, because at the end of 1 week we are 5 weeks gestational age and we can actually diagnose an intrauterine sac.
Yeah, that's all right. But heterotopic, whether you'll be able to diagnose, you couldn't diagnose at 6 weeks here.
Well, we can't keep suspecting in each and every case, especially when you start with beta HCG. But yeah, a keen ultrasonologist is the only way you will be
Anything,
able to.
how can you minimize its occurrence?
I think the one way we can minimize or at least diagnose it earlier is to do more and more single embryo transfers.
I think single embryo transfer and a blastocyst. I think frozen ET, previous history of ectopic, a frozen embryo transfer, a single embryo and a blastocyst are the three things what I advise my patients.
And how about pre-IVF salpingectomy or tubal occlusion, which everybody suggests the moment they see a problem in the tube?
So I have seen patients who have developed cornal ectopics after bilateral salpingectomy. So probably these are women who have a primary endometrial receptivity problem, and hence the embryo.
Wow, Manish, please don't disclose.
I think we are discussing the next case here. Yeah.
So let us see what
we'll come to that.
Removal of hydrosalpinx may increase pregnancy rates and reduce risk of ectopic. I've seen everyone on the slightest point of seeing a hydrosalpinx, a small one also, they jump to this conclusion that the patient needs a clipping or a removal of the tube. So let us see whether it really helps and whether we should go forward so much when we see a hydrosalpinx. The next case will describe that. Manish, you have tried to pull out our case from somewhere. We have kept these all a secret. Case 6, Sangeeta, go ahead.
Okay, yeah. So this is a 39 years old female. She came to the OPD with diagnosis of post-IVF triplet live ectopic, 6 weeks and 5 days from a popular IVF center after 6 failed IVF cycles at various IVF centers. There is history of laparoscopic bilateral proximal tubal occlusion 5 years ago for bilateral hydrosalpinx with frozen pelvis. The vitals were stable at this time. Abdomen was soft, no signs of guarding or tenderness. All investigations, including the hemogram, were normal. Serum beta HCG at this point of time was more than 2 lakhs milli-international units per ml. A repeat TVS was done and it confirmed the diagnosis of live triplet ectopic pregnancy with twin live gestations in the right angular or interstitial part and a third live pregnancy in the left isthmic region in an empty uterine cavity. So now, this is a question separate from this case actually. We want to know that for every patient who is conceived through IVF, what all information should the IVF specialist or the ART center give to the referring doctor, to the referred center, where now the patient would be taken care of during the course of a pregnancy. So what all information should the patient bring from the IVF specialist or the center? Which
Dr.
would help.
Rashmi and Rajapriya, group 3, please go ahead.
Yeah, which would help in proper dating, in antenatal monitoring, in proper aneuploidy screenings. Yeah.
We need to give first a proper discharge summary, whether it was a donor egg or it was her own egg, because sometimes it's important for down screening. And we also need to mention the number of embryos, what kind of a stimulation program, and in what stage, whether it was a day 2, day 3, or a blast transfer. So that when they are doing the scan, they will be tracking it with respect to the number of embryos. Now, and also if there was previous any surgical intervention, like how in this case there was a bilateral tubal occlusion done. So these kind of pre-treatment details also should be mentioned so that the concerned doctor can take it from there and anticipate problems. So
why do you think we need to tell them whether it is a HRT cycle or a ovulatory cycle? Dr. Rajapriya, just give the audience a little idea.
Now, if it has been, it has to be understood also whether it is a fresh transfer or frozen transfer also we have done.
Yeah.
And in case it's a frozen transfer, they need to continue the HRT till they are ensuring viability, because a lot of time the centers tend to refer the minute the urine test or the beta HCG is positive.
Rashmi, will you want to add on to this anywhere?
No, ma'am. I think Dr. Rajapriya has almost covered everything. That a proper embryology summary should be definitely provided with the case. A proper case history should be definitely given with the patient. When the embryo transfer was done, then maybe we can even calculate the LMP for, because sometimes there is a confusion in calculating LMP and how many embryos were transferred. All this has to be given, yes, whether it was a donor oocyte or.
So,
regarding the
Sorry for the interruption. Yeah. Sorry for the interruption. Only 10 minutes left.
Yeah, we are going to finish. We are on the last.
Yeah. So in this particular cycle, donor oocytes were used and 3 day 5 blastocysts were transferred. Can we move to the next slide, ma'am? Yeah. So this is the picture where you can see the left ectopic, which was in isthmic, and the right angular ectopic. So how would you manage this patient? What consents would you take? What is there in your mind? How would you proceed? Any one of my panelists.
So this is
Rashmi and Rajapriya.
Cornwall or an interstitial pregnancy. So I remember one case of mine many years back when there was an intrauterine and there was an interstitial pregnancy as well with live embryos in both the sex around 6 weeks. So in that case, we had to save the intrauterine also. So we went ahead with transvaginal aspiration of the sac contents followed by installation of 50% dextrose to kind of fibrose the gestational sac. So maybe
Rashmi Sharma, here what do you do? 3 live ectopics sitting in the cornua or angle, and in
second option may be to go in with a laparoscope and do a Cornwall resection.
Okay, so when you are proceeding with the laparoscopy, what consents would you like to take before proceeding with the laparoscopy?
This is 39-year-old, frozen pelvis, both tubes clipped, 3 live ectopics, both the sides, beta HCG more than 2 lakhs.
Ma'am, in this case, first of all, I would like to go ahead with a conservative approach because this is a frozen embryo, frozen pelvis case we are dealing with. So in the operation theater, if you are able to reduce the sag with proper consent, that we might have to open her up, maybe even do a laparotomy, sometimes even hysterectomy may be needed in such cases.
Yes, yes.
But the first approach, first approach of mine would be definitely a transvaginal reduction.
I think if we can avoid surgery, it will be a great idea. But the woman has to understand that she's in a life-threatening situation, and she's a person who is going to, definitely get a consent for a hysterectomy because of anticipated blood loss.
All panelists, any idea?
Ultrasound-guided aspiration or instilling some potassium chloride.
That already Rashmi has told that you would.
That would be a better option.
Yeah. How would you ensure that at least one pregnancy is not in the angle within the uterine cavity or truly is in the interstitial part or tube? Any way you can find out in this case? Because we were desperately looking to save at least one pregnancy.
3D scans may help, ma'am. A 3D or a 4D.
Yes, sometimes they are inconclusive. So how do you proceed?
You saw this scan?
I think doing a hysteroscopy maybe, the answer in this case.
This hysteroscopy was done and which confirmed normal endometrial cavity with no gestational sac within it. Hence, the diagnosis was confirmed, and these are the surgical steps.
I think we should not start the surgery without a surgeon, whether you are in institution or standalone center. I think a surgeon needs to be there.
But then the first thing was, like Rashmi and Rajapriya said, that they would want to go for conservative management by injecting, in this case, probably methotrexate as a good option. But in the OT, with everything around, because she could start bleeding at any point of time, you are injecting into a very vascular uterus. Right, Rajapriya, you agree with that? Yeah. Rashmi?
Yes, ma'am.
Okay, so we have 5-6 more minutes to go, ma'am.
Yes, we are finishing.
Can I comment, ma'am? Regarding the prevention of ectopic pregnancy in IVF especially, so in my unit, what we have been doing, deliberately transferring the embryos pretty low. Once we have fixed the once we have put in the outer catheter, then freezing the picture, measuring the distance particularly from the fundus till 2 centimeter, and then measuring from that point till the outer catheter. So that is the exact amount of catheter that we are going to put inside. So we have an idea.
Right, Rashmi, everybody agrees that you have to do a load transfer. But here you are loaded with this question now. What you want to do is not that. We are loaded with this case. This case has come to you and you have to manage her. Well, we managed her. We had to inject Petrocin because we could see nothing. We had to eventually resort to laparotomy. Shweta, can you go? Sangeeta?
Yeah, so post-adhesive lysis was done, and post-adhesive lysis bowel dissection, Petrocin was injected. Intraoperative ultrasound was used to confirm complete evacuation of both the pregnancies from right side, and left side was also removed, and then hemostatic sutures were taken. So now some questions come to our mind after this interesting case, that when 3 embryos were placed, especially the blastocysts were placed in the endometrial cavity and both the tubes were clipped, yet the embryos chose to implant away from the uterine endometrium. So what can we interpret from this? I think Dr. Manish he was already...
Complete altered window of implantation.
Yes. So anything else, any investigation procedure?
Just wait, let Manish answer. Let's see what he has to answer.
I think looking at her picture, it is very likely that she has an endometritis, either simple or maybe tuberculosis or something. So maybe we need to evaluate her endometrium before we proceed with anything. A simple biopsy, hysteroscopy, and if required, an endometrial receptivity array. Because the fact that all 3 embryos implanted, the problem primarily appears to be with her endometrium. And These are the patients in whom I would do an endometrial evaluation. Second, with this kind of history of ectopics, given a choice, we can also do a natural cycle embryo transfer rather than a HRT, because that again would lower the risk of an ectopic. And always do a single embryo transfer. Don't, even though she has had multiple failures, she had 3 embryos implanted. So let us do a good donor egg single embryo transfer.
This was a donor egg, Manish. But
So do a
just to
single
add on
embryo.
to what you said, I have started doing endometrial receptivity era and ruling out endometritis in women who've had an ectopic on IVF, where we know that IVF embryo transfer was done with all proper precautions, and it was a single blastocyst frozen embryo transfer also. So maybe endometrial receptivity arrays should be very, very important.
Especially in patients who have had multiple failures as well.
Failures,
Because
yes.
then it goes more in sync of that. I mean, a simple ectopic in the first transfer, you may not look for the endometrium.
Right. So I think we have discussed most of the complications related to ART. We've seen how torsions, timely detection can prevent the ovaries. We've seen post-OCR hemorrhagic conditions. We've seen where complications related to anesthesia can take place. We've seen heterotropic and ectopic pregnancy where the patient nearly she was on the verge of losing her uterus. So now with this, we would just 2 more slides for long-term complications.
Sorry for the interruption. Please wind up.
Yeah,
okay. This is the last slide. This is the last slide. Ma'am, can you just move on? Yeah. So the risk of cancer to the mother and the child, and risk of higher imprinting disorders to the child that can be there. And a word about, can we move on to the next slide? And a word about higher risk of birth defects. Now, this counseling is extremely important that yes, this is a meta-analysis of 45 cohort studies which showed that the relative risk was 1.32. But when we counsel the couples in very simple language, we need to tell them that the absolute risk is marginally increased. Maybe with a background risk of 5%, it just becomes 6.5 to 7%. Can we move on to the next slide?
That's it.
Okay, so thank you so much for that great discussion. There is always light after dark. And with this background discussion and knowledge of the complications of ART, I hope we all would keep on performing safe and effective ART procedures and would help our patients completing their families. Thank you so much.
Thank you. Thank you.
Thank you very much.
So thank you,
Thank you.
panelists,
Thank
for
you very
helping
much.
us to finish in time. Very good discussion. And I've learned and I've taken home few messages from this panel discussion, because these were all real life cases for us, which we faced one or the other time.
Really interesting cases, ma'am.
Yeah.
Thank you, ma'am. It was a very, very
Thank you. Thank you.
Thank you so much.
Thank you all my panelists for putting in such good inputs that we should, really have a publication regarding your answers.
Thank you very much.
Thank you.
Thank you.
Thank you. Thank you.
Thanks.
Dr. Anupam, please announce the next session.
So now we move on to the next session. And to chair this session, I would like to invite, I'll share my screen.
Did I stop sharing or not?
No, ma'am, you haven't stopped.
How do I stop it?
You have stopped. The ma'am has stopped sharing. Dr. Anderson has already started sharing. Let him start sharing. Anupam, just announce the name of the chairpersons.
Okay. To chair the session, I would like to invite Dr. Shweta Mittal, Dr. Shilpi Sood, and Dr. Loveleen Sodhi.
Thank you very much. Without much ado, I would like to start the session. And we have Dr. Claus Anderson. He is professor and head from the Laboratory of Reproductive Biology, University Hospital of Copenhagen and Denmark. He is one of the lead persons in oocyte tissue cryopreservation. And Dr. Claus would be briefing us about fertility preservations beyond malignant disease. So the dais is yours, sir.
Thank you very much, and thank you for inviting me to present for you in India at this time. I think this is very unfortunate time with...
Am I hearing it less, Dr. Claus? I think we are hearing your volume very low.
Shivam?
My volume very low.
Yes,
Yes.
ma'am. Yes, ma'am.
Is this a recorded lecture?
No, ma'am.
No.
No, we can't hear it well. Can we do something about it? Can't hear it, Dr. Anderson? Dr. Anderson?
Yes, yes.
Sir, we can't hear you. Can you do
Very
something
well.
at your end?
So what do we do about that?
You can maybe come closer to the screen, sir. Maybe.
Yeah, I am pretty close to it now.
It is better now. It is better now.
Better now?
Better now. Better now.
Better now. All right. Okay, very good. But let's get it started then. We have 20 minutes, and I've been asked to talk about fertility preservation beyond malignant diseases. So what I would like to talk to you about today is the fact that we now have available normal ovarian tissue outside of the body, and this enables us to look at other options than just preserving fertility in connection with cancer diseases. So this is basically what I would like to discuss with you today. So what you see here is what we normally do here in Denmark. When a woman is undergoing fertility preservation, we take out one of the two ovaries. So we leave one in there and the other one comes out. And as you see on the picture, we have an option to use that tissue. And I think that this is now a drop in the water which is spreading. And when we do have available normal ovarian tissue, we do have a lot of options. And what I would like to do today is try to cover.
Sorry to interrupt you, sir. Sorry to interrupt you, sir. Dr. Anderson, can you use some headphones or anything so it can be clear?
Yeah, I can try and see if I can get that started.
Maybe it is already connected.
Better now.
Yeah, because when you brought in your headphone, it became clearer.
Yeah, it is already connected, sir.
Is it better now?
Yeah. Yes, very much.
Okay, very much better. All right, so let's try and continue this. So I will touch upon other options of using human ovarian tissue. And what I would like to touch upon is using IVM as an add-on method for cryopreserving cortical tissue. This may be used in connection with known causes of premature ovarian insufficiency. There is now an option for the first time ever to offer fertility preservations to patients with ovarian cancer, borderline ovarian cancer, or other diseases within the ovary. We now use this for rare genetic diseases, and it's actually confirmed to have a potential in children. Severe cases of endometriosis may be offered fertility preservation early on in that disease. We can postpone menopause, and we can even use it for anovulatory PCOS women. So this is basically a modern wedge resection. If I do have time, I would like to cover all these aspects. So we are in a bit of a hurry, but let me just get started. I think that the really important part is to understand that when we have ovarian tissue, this is not just oocytes. Here you see a picture of how the tissue is actually cryopreserved. When we have one ovary, we have many pieces of cortical tissue, perhaps 25. And when we transplant this, we are able to regain endocrine function, not only oocytes. We are actually having preovulatory follicles that secrete the whole armamentarium of hormones, which the woman may also benefit from. So I think it's important to understand that we are now talking about organ function and not just oocytes. And normally we talk about women in connection with IVF, that this is poor ovarian reserve patients, and they don't have a lot of oocytes and so on. But the fact is that if you look into the cortical tissue, there is an enormous abundance of follicles. What you see here in the insert is the cortical tissue of a woman who is 26 years old, and every little red dot there represents one primordial follicle. So there's thousands of primordial follicles sitting there, and we now know that they may not be very good for fertility purposes, all of them, but a lot of them are. And we may use them either for fertility purposes, or they will be very good to secure endocrine function. And if you look at it, then you can see that if you consider a girl at puberty, she may have 500,000 follicles. If you look at what she's using during the natural circumstances, she will have menstruations 12 times a year. She will ovulate from year 12 to year 52, that's 40 times. 40 times 12 is 480 oocytes. That's all she uses. All the rest are undergoing degeneration, but they have a potential which we can use We can use them both for fertility purposes and for endocrine function. It's important to understand that we have all these primordial follicles which sustain freezing, but the organ function is just maintained by this one preovulatory follicle. As you see here, this is a human follicle. You see the oocyte cumulus complex, you see the oocyte. This follicle, the preovulatory follicle, will within each individual cycle secure more than 90% of all the circulating estradiol structure. This one follicle is the organ function in this particular cycle. So this is why we can create an organ function after freezing, which is the only organ so far we can do in the human body. It's important to understand that when we freeze the tissue, we only freeze the outer cortical tissue. This is where the resting follicles are located. They sustain freezing, whereas those which are in the medulla tissue, these are the ones we normally use for stimulation in connection with ovarian stimulation. They are far too big, far too complicated to sustain freezing, but these guys do. But when we transplant them, they just continue from where they were, and then they produce the preovulatory follicles. So what we do when we have one ovary is that we collect the outer part, the cortical tissue. These are the follicles which we use for ovarian stimulation. They don't sustain freezing. This is a corpus luteum. So what we do is that we have one ovary, we isolate the cortical tissue, make many pieces, freeze them individually, and then we can saw them out individually. We can saw out 5, 10, 8, 12 pieces as we wish, and then transplant them to the woman, and then we can stretch the ovarian function for many years. This is the number of children which was born published in a review 2017. So this was 130 babies worldwide from transplanting frozen sold ovarian tissue. This has grown considerably since then, but this is the latest review where all the children born from this procedure internationally was summed up. In Denmark, this is what we have. We have more patients being transplanted. This is what's been published, 62. We have only 53 who had a pregnancy wish. So 9 women just wanted to avoid menopause and have menstrual cycles, just young women. And you can see here that we have produced 21 children so far. And this is there's a lot of women who conceive, but we do have an issue with miscarriages. So this is pretty high. And obviously this reflects that this is women with a cancer. Some have had radiation to their pelvis. Some are not very good at carrying a pregnancy. We even have, as you can see here, one woman who experienced a relapse during pregnancy because she had a breast cancer developing in the breast, not related to the tissue. But this is how it stands at the moment, and this is probably what you see worldwide. So the first extra option you have available when you take out tissue is to do IVM. So you can see here we have isolated the cortical tissue. The medulla tissue is normally just discarded. But of course, there will be antral follicles here, and we may look out for oocytes, not follicles, but immature oocytes. And when we do that, it do turn out that there is huge numbers of oocytes, immature oocytes in these bits here. You can see that these are all immature oocytes. Some are large oocyte cumulus complexes, some are small oocyte cumulus complexes, and some are just naked oocytes. So here you can see the germinal vesicle in this particular oocyte. But these oocytes represent an extra option for the woman to become fertile. Up until now, there is 5 children who has been born from oocytes from these very small follicles, Singapore, United States, and Belgium, and it do work. They all come out fine. So why is it interesting with small follicles, which just has a diameter of 1 to 3 millimeters? We know traditionally from IVM that follicles, when they are 10 to 14 millimeters, this is what we normally do with IVM. They don't work very well. Why would we think that they would work if we went to even smaller follicles? Well, actually, there is indications to suggest that this may be the case. And indeed, this is what you do in any animal species out there, where you take out one ovary, you collect the immature oocytes, you mature them in vitro, and then you have IVF. But it doesn't work in humans. One of the reasons may be that we in fact need the oocyte cumulus complex from these small follicles, because it do turn out that FSH receptor expression is very high in the small follicles. So we do have an opportunity to affect the cumulus oocyte complex with FSH and then rescue them and develop the oocyte. And this is coming out in this, and it's certainly coming out also in the follicle wheel as published by Alan Bouchon many years ago. So in IVF, we use these follicles, 2-5 millimeters. This is the one we recruit for ovarian stimulation. But look at the atresia rate in these follicles, 58, 77%. So they experience the intercycle drop in FSH. So a lot of them become atretic. This is what we recruit for IVF. But the ones we are looking at is from the very small follicles here. And look at the atresia rate, a lot lower. So if we are able to expose these oocyte cumulus complexes for higher amounts of FSH, we may have an opportunity to rescue them. We have just published the study in JARC, where we looked at 25 patients, 28 years on average, a normal ovarian volume. We collected on average 36 oocytes from each individual ovary. We don't have that average now. We are a little lower, but in this particular case, we had 2 PCOS women included, and they both provided more than 100 oocytes, each of them. 1/3 undergo maturation. So in any case, we get on average 11 metaphase 2 oocytes, which would be as good as any ovarian stimulation. But this comes on top of the cortical tissue. So the woman actually has 2 for 1 in this instance, because she would both have mature oocytes and she would also have cortical tissue. We are now started to look at using this particular option in women with ovarian cancer, because the cancer is not located in the oocyte, but in the ovarian tissue. So if we can collect oocytes from these women, and they do have their ovaries removed anyway, then we may actually be able to provide these women with a fertility preservation option. And this is the first time ever that this will be an option. So this is another route that we're looking into. And we can actually now see here that we have used almost 900 immature oocytes, and we have divided them into whether they were naked, small, cumulus oocyte complexes, or large. And the interesting part is that the large COCs, where there's a lot of somatic cells, they make it 50% of them. So, and of course, the naked ones are not as good, but 52% can actually make it to metaphase 2 when you have large oocyte cumulus complexes. So this is, I think, a very interesting option and an interesting platform to develop IVM. Let's have a look at premature ovarian insufficiency. Now, these years, obviously, these women would lose their fertility early on, and often they don't have children because they have fewer oocytes and so on. But now, these years, we are now actually starting to identify these women through genetic conditions. So these can probably be pinpointed at an earlier stage. Obviously, this provides these women with the option of either having children very early on, or you could actually take out the ovarian tissue and freeze it for them to have an option to have children later on. And I think that the going into POI, this also comes back to using the tissue as endocrine provider of hormones is very interesting, because it do turn out that POI and menopause are not very good for women. It has causes significant increased risk of cognitive decline and dementia, and there is a sizable neuroprotective effect of estrogen naturally produced. So if they do have their own tissue sitting in there working, creating normal menstrual cycles, they can postpone osteoporosis, cardiovascular disease, and whatnot. So this is an interesting option also. In Denmark, we have now already started to freeze ovarian tissue from women who have imminent POI. I think we have now eight patients between the age of 18 and 27 years who are coming around with normal FSH levels. But we can see that the sign of a POI coming, and if they have a family disposition, if the mother went early into menopause, they are actually combined, they are offered ovarian tissue freezing and oocyte vitrification. Obviously, the having ovarian cortical tissue in the lab also provide us with the opportunity to do in vitro follicle activation. We have not developed the right method of doing that yet. And I don't think that the IVA data which are out there at the moment are too convincing. I think that this is now something which we need to work a lot more on in the laboratory. But if you do have ovarian tissue and you can activate follicles in vitro, then if you have a reproductive age woman, say 35, 38 years of age, you may take out tissue and then activate all that huge amount of primordial follicles which are sitting in the tissue and then transplant it back. And then the follicles will grow, and in half a year, 1 year, you will probably see a number of follicles coming up. And this is then the chance of this woman to have many oocytes collected and then make use of them for becoming pregnant. If you look at genetic diseases, this is also an interesting avenue. And I think, for instance, for thalassemia, which would be pretty common in India, I guess, this is now turning out to be an option for those girls who have thalassemia maya and who have severe impact on their fertility. They need a new bone marrow, they need new red blood cells. If you take out the tissue, ovarian tissue, before they are treated, and then they go through the bone marrow transplantation, then they normally loses their fertility, but then you can put back the tissue later on, and then it actually do work. You can see thalassemia, POI, Turner syndrome, galactosemia, sickle cell anemia, Fanconi's anemia, various mosaicisms, and so on. But this is, of course, very rare conditions. We have cryopreserved tissue from more than 1,300 patients in Denmark. So obviously, this is very seldom. But if you can see here that we have looked at Turner syndrome patients, galactosemia, thalassemia, and this is the normal range of follicular densities in the ovarian tissue. And if you look, this is now age down here. So you can see that the galactosemia patients in the first few years appear to be within the normal range, and then they fall off by the age of 12. The Turner syndrome patients, a lot of them actually do have follicles early on until 15 years of age. And then you can take out the tissue, and then when they would normally go into menopause by mid-20s, but they would still have follicles here. The same for thalassemia and sickle cell disease. Actually, we have had one patient who had thalassemia, had her tissue removed when she was 9 years old. So before there was any ovarian activity in the ovary, she had it cryopreserved in Leeds in 2001. The tissue was brought to Denmark in 2015. The tissue was transplanted back, and she immediately actually conceived after IVF treatment. So this both shows that the patients with thalassemia would benefit from this, and also very young girls. Ovarian tissue is capable of providing fertility. Endometriosis. If you have a case of endometriosis and you see it for the first time, often you will see this is severe endometriosis. She is likely to undergo repeated surgery. And at that point, you may actually identify normal ovarian tissue, which can be frozen and then just left in the freezer until she has either have recovered from her endometriosis, and if it do come out that she loses ovarian function, you may transplant this tissue. So this is now also an option which is followed in different centers around Europe. And then I would like to end up by showing you a suggestion for a modern wedge resection. So now we are having 2020. This is just to show you how you did this in the old day. You ablated cortical tissue by doing these burns on top, and then you destroyed follicles. This had the impact that this woman would regain normal fertility for a year, and then she had an opportunity to become pregnant. This is still performed, but not a lot. But what we now suggest that instead of doing ablation to the cortical tissue, you can actually remove ovarian tissue. We can take it out and freeze it. So we preserve the follicles which are located in the ovarian tissue. If she becomes pregnant following the removal during her natural menstrual cycles, beautiful. If she do not, then we would have suggested to take out immature oocytes at the same time. And then she can use those who reach metaphase 2. If she still not is pregnant, she can just return to the IVF clinic and the risk of her hyperstimulating is reduced. So this comes on top of it, and we suggest this may be an alternative way to suggest to some of these severe anovulatory PCOS women that you see in your infertility clinic.
Sorry for interruption, sir. Sorry for interruption. Your time is up. Please conclude.
My time is up. We would just continue. We would just go. This is the summary slide. You can see that there's lots of other options for using the tissue. And this is the laboratory I represent. This is a cold time in Denmark. We are here at the top of our hospital on the heliopad, and I thank them all for their nice collaboration. Thank you for your attention.
Thank you, Dr. Anderson. I think this was an extensive detail, and it really has evoked a lot of questions, which we'll be discussing at the end of all the 3 talks. And we would be moving on, and I want to request now Dr. Shilpi Sood to take over and introduce the next speaker.
Dr. Shilpi, please unmute. Please unmute.
Thank you, Dr. Shweta. Next speaker is Michael Granberg, Professor and Director, Department of Reproductive Medicine and Fertility Preservation, Antoine Brecklier, University Hospital, France. He's a Senior Deputy of SIG Fertility Preservation, ASHRAE. I invite Michael Granberg for this talk.
Thanks a lot. Can you see me? Can you see the screen or not?
Yeah.
No, not yet.
Not yet. I have to share it. Try to share it one more time. Okay.
Dr. Michael, you just need to click on share screen.
Sorry?
Just click on green button, share screen.
Yeah, I did it.
Yeah.
I did it.
Just open your PPT once.
Let me try one more time. Okay. It should be here.
Do you think logging in again would help, Sumit?
Perhaps.
No, ma'am. No, ma'am.
Yeah. No?
No? Okay, perhaps it should work now. Is this fine? No?
No, we're not able to see your screen.
You cannot see my... I will try to reconnect one more time. Just 1 second.
Yes.
Are you able to see a green button on the bottom of the screen, Michael? No. Okay. In the meanwhile, we can take the question and answer.
Dr. Claus, I was just wondering that what has been the youngest age for a female where you have actually gone ahead and done an oocyte cryopreservation for the girl? And do you sincerely recommend ovarian tissue cryopreservation along with oocyte cryopreservation when you're looking at these very young girls for fertility preservation?
I just want to clarify your question. So you're asking whether we have cryopreserved oocytes, not ovarian tissue. So you're asking about oocytes, or are you asking about ovarian tissue?
I was asking what is the youngest age where you would recommend an oocyte tissue or an ovarian oocyte cryopreservation?
oocyte cryopreservation.
Yeah,
No,
the youngest.
The oocytes are from antral follicles. Antral follicles in prepubertal girls are not very healthy, because they are not supposed to be healthy because they are undergoing atresia. So it's not a very good idea to do IVM for the prepubertal girls. But this, they don't mature very well. But if you do have antral follicles in women who have their natural development of follicles in the ovary, it's a lot better.
So Dr. Claus, I remember in the talk you said that when oocytes are cryopreserved, the risk of transmission of malignancy is very low vis-a-vis ovarian tissue cryopreservation. What is your practical experience in the risk of transmission?
Well, I mean, if you have a BRCA gene and you have any disease, ovarian cancer, this is not transmitted by the oocyte, because the oocyte is not having any malignancy. This is something which develops in the girl later on, and whether you have an increased predisposition for it is a different matter. But you don't transfer the malignancy to the mother if you transplant an oocyte. This just doesn't happen.
There was another question. I think we can hear the next talk and then come back to questions. Yeah, Dr. Claus, please be around.
Is it working or not?
Yes, it is.
Okay, good. Thank you. Sorry for this problem. First of all, I would like to thank all the organization for the invitation. Unfortunately, I cannot be with you due to the COVID, but hope we'll have another opportunity to see each other. So my talk today is about the random start, the double stim, the adjuvants in the oncology emergency condition. So all this about regarding the problems of ovarian stimulation in cancer patients. I have no conflict of interest. Over the past decades, major advances in diagnosis and treatment have markedly improved the rates of cure for many young adults and children suffering from cancer. And as a result, there is an increasing number of young survivors for whom the quality of life represents a major issue. The problem is with cancer patients is that very often they will have to face chemotherapy and radiotherapy, which will destroy more or less the totality of the ovarian tissue. And as you can see on the slide, on the left side, you have plenty of primordial follicle within the ovarian cortex, and following the chemotherapy, a dramatic decrease in this number of primordial follicle. However, in this patient, the pregnancy desire is extremely important, and these survivors have been shown to be more concerned about their future fertility than age and gravity matched women. And some women ask for less toxic chemotherapy if they know that, even though they know that it could be less effective, some patients ask for a less effective chemotherapy, but if they know that this chemo will impact less their ovarian function. So definitely the fertility after cancer is a major concern, and for these patients, safety might always be in the background. But we know that for these women, the possibility of having their own children by transmitting their own genetic is very, very important. So based on this background, fertility preservation has been developed, and it is now fully integrated in the management of young patients, male and female, suffering from cancer, and even children. So what are the possibilities? Medical treatments, most of them are GnRH agonist administration during the chemotherapy, oocyte cryopreservation, embryo cryopreservation following ovarian stimulation or in vitro maturation, and ovarian tissue cryopreservation. To date, Control of iron stimulation followed by oocyte cryopreservation or embryo cryopreservation represent the most established method for female fertility preservation. It is based on the administration of high doses of exogenous FSH, and this treatment will last more or less 10 to 12 days and will be associated with an increase in the serum estradiol level, which could be problematic for some diseases such as estrogen-sensitive tumor, breast cancer, endometrial cancer, and other cancers which could be sensitive to estrogen. So what are the specificities of cancer patients? There cannot be compared to infertile patient, even though the treatment with combining ovarian stimulation and egg retrieval is more or less the same as that we perform in infertile patients. These patients are different. Why? Because due to cancer, they have higher thrombosis risks. They have sometimes some disease that could be estrogen related, such as breast cancer, endometrial cancer, and some ovarian cancer as well. And even in other malignancies, there are still questions regarding the estrogen sensitivity of melanomas. The cancer treatment is relatively urgent for most patients, and so time is missing, and we have more or less many patients only one round of ovarian stimulation possible. And it's in play the management of this patient will include many specialists and manage many specialists, and it will be a multidisciplinary approach. So definitely these patients are different. So what is extremely important for these patients? Not delaying cancer treatment, getting as much as possible, because it's the main issue. If we want a baby in the future, we need eggs, and safety is always important as well. So regarding the thrombosis risk, in this patient, we have a study reported in 2014 in these patients who are supposed to be at high risk of thrombosis due to cancer, and it has been reported that despite the stimulation, there was no increased risk of thrombosis in this patient. So this is interesting for us, because if we consider that stimulation is important, it is not. This cancer patient should not, for most of them, not at high risk of having thrombosis following the treatment. What about the protocol? The GnRH antagonist protocol should remain the standard of care. Why? Because the live birth rate, ongoing pregnancy rates are as good as those one observed with the GnRH agonist protocol in infertile patient. But in this situation, you all know that it's a less aggressive approach with an important reduction in OHSS rates. So that's the reason why we cannot take the risk of OHSS in these patients. We have to try to reduce it as much as possible. That's why the GnRH antagonist protocol is probably the most indicated in this patient. In addition, GnRH agonists are associated with fewer days of stimulation, so interesting when time is missing, and even in infertile patients with higher clinical pregnancy rates. So for this reason, this is particularly important for these women. So you all know how it works, with initially during the early follicular phase of the cycle, stimulation with exogenous FSH, and then either flexible or fixed GnRH antagonist administration until the trigger shot with GnRH agonists, because these protocols are interesting for cancer patients to reduce the OHSS risk. We have the possibility, as you know, to trigger with the GnRH agonist. Please keep in mind that in these patients, especially when there is an alteration of the general state, it is important to make sure, following the trigger with GnRH agonist on the following day, to make sure that LH and progesterone have rise, to be sure that, to make sure that the trigger shot has worked. So I described you the stimulation during the early follicular phase, but is it possible to stimulate this patient whatever the phase of the cycle? Definitely yes. And why? Because we have different waves of follicular recruitment during a single menstrual cycle, and we have three waves which have been reported. And for this reason, and especially in these patients who are not candidate for an embryo transfer following the stimulation, we do not matter about the endometrium. And that's the reason why, if we have some antral follicle, and we have always antral follicles, as you can see on the slide, we always have the possibility to administer FSH to try to recruit some more follicle and to enable a follicular growth until maturation. So this is the GnRH antagonist protocol with a random start. So we can perform this whatever the phase of the cycle, either during the luteal phase with a co-administration of FSH and GnRH antagonist, and for women with during the late follicular phase, it's possible to trigger the ovulation with a GnRH agonist, not with HCG, due to the long high life of the HCG. So trigger with GnRH agonist, and 3 or 4 days later you can start exogenous FSH combined with antagonist. So we know that if we focus on the stimulation during the luteal phase, usually it takes 1 or 2 more days when compared to stimulation during the early follicular phase, and with a higher total dose of gonadotropin, and in the end, more or less the same number of oocytes recovered, whatever the phase of the cycle during which the stimulation has been started. So this random start is particularly important in cancer patients because it has been demonstrated not to delay the cancer treatment, which is a crucial issue in this patient. So the random start in oncologic patient is physiologically feasible. There is no difference in terms of number of eggs recovered versus the conventional start. There is no detrimental impact on oocyte quality in terms of embryo euploidy rates in poor responders. We do not know in oncologic patients. And there is an absence of adverse effect on neonatal outcomes and long-term child health, which needs to be evaluated because we do not know exactly what we do in this situation. Data are missing because the random start and stimulation, even in infertile patients during this luteal phase, is relatively recent. So we miss some long-term data on outcomes regarding the pregnancies and the health of the kids. Another important issue is the number of eggs that could be frozen in this cancer patient. You know that it's important even in infertile patient. The number of eggs is more or less related with the success rate of an IVF cycle. But in these patients, for which usually the number of stimulation will be limited, most of the time only to 1 cycle. So if we have the possibility to to perform dual stimulation to combine two successive ovarian stimulation. This could be an option and a way to improve the number of eggs that could be frozen. So you can see on the slide here on the left part, the number of eggs recovered, the number of eggs that could be recovered following one cycle, 9 in total. And if we combine two cycles, it's 16 oocytes that could be frozen. And in terms of mature eggs, 6 following one stimulation and 10 if you combine 2 stimulation. So in this patient, in this study reported by Tsempras in 2017, you can see that the number of eggs with during the second cycle during this dual stim was a little bit reduced when compared to the number of oocyte yield following the first stimulation. But in the end, if you combine the number of if you count the number of eggs recovered following 1 or 2 stimulation, the dual stim will allow us to increase the number of eggs available for these women, and then probably the success rates and the chances to have a baby. So the double stim is in oncologic patient physiologically feasible if time before cancer treatment allows it. It will allow an increasing the number of oocyte vitrified, which is an important issue for success. We do not know exactly as what I told you before with the luteal phase stimulation. No data regarding the neonatal outcomes and the long-term child health. And we do not know exactly the safety of this protocol in terms of oncologic outcomes. But it seems safe, but the data are still missing, and we need some more data to be able to draw robust conclusions. What about the stimulation in estrogen-sensitive malignancies? Is there a risk of hyperestradiol? Actually, we have an increase in serum estradiol levels following stimulation, 10 to 20-fold the physiologic values. This increase will be transitory from 4 to 10 days, but theoretically, it could have an impact, as an example for breast cancer, because you know that estrogens is an important factor of breast tumorigenesis. We know that stimulation, hyperestradiolaemia will increase the proliferation of breast cells, as you can see with the Ki67, and that could be so there is a theoretical impact of this hyperestradiolaemia, which could be detrimental. But if you remember what happened during the 50s and the 60s, oncologic patient, breast cancer patients were treated with high doses of estrogen to try to increase the sensitivity of the cells of the tumoral cells to the chemotherapy. So, and these patients had relatively good results. So it probably hyperestradiolaemia is not very, very detrimental in this patient. So the risk is still unclear. We are mainly based on a precautionary principle with no stimulation most of the time when tumor is still in place, a stimulation conceivable following surgery, always to be discussed with oncologists for sure. And due to this unclarity, we developed some specific protocol for this patient, either using tamoxifen during the stimulation, so combination of exogenous FSH with tamoxifen to reduce the effect of this hyperestradiolaemia, or with another possibility with letrozole. The first one with tamoxifen, combining tamoxifen and FSH, has been very used in Israel by the team of Dror Meirov. And you can see that the number of oocytes was exactly the same with or without tamoxifen administration, with a theoretic safety, because the estrogen, the hyperestradiolemia should not act on the tumoral cells. With letrozole, with aromatase inhibitor, exactly the same. During the stimulation, combination of ovarian stimulation, exogenous FSH with letrozole to keep the estradiol level to the normal ranges. And you can see the first study reported by Kutluk Oktay in 2006. And you can see that on the day of trigger, the peak of serum estradiol was definitely lower in patient under letrozole versus patient with conventional ovarian stimulation. The Oktay also compared tamoxifen protocol and letrozole, and he showed that the number of mature oocytes vitrified following letrozole administration was higher when compared to the TAM group, and that's the reason why most of teams now use letrozole instead of tamoxifen. What about the safety of this protocol of aromatase inhibitor? When patients are stimulated following breast surgery, no problem. At 5 years, no increased risk regarding survival. The problem is that when this treatment is the stimulation is performed before chemotherapy, when the tumor is still in place. Safety has been shown, but only in 14 patients, so more or less nothing. We still do not know what we do in patients stimulated, even with letrozole, when the tumor is still in place. So what about, before concluding, what about the anti-estrogen therapies in oncologic patients? They have been used due to the principle of precaution. There is no impact on the number of oocytes vitrified when compared to conventional antagonist protocol. The effect on neonatal outcomes and long-term child health are still unknown. We missed long-term safety data in terms of oncologic outcome. And another question is, are they really needed? And what could be the problem of just only one single ovarian stimulation, even though we increase the estradiol level? So to conclude this presentation, for ovarian stimulation in women seeking fertility preservation for medical reason, the GnRH antagonist is probably the protocol which could be recommended. In urgent oncology fertility preservation cycle, random start is an important option. And in ovarian stimulation for fertility preservation, estrogen-sensitive diseases should benefit from letrozole or tamoxifen. This patient could get candidate to the administration of anti-estrogen therapies. Thank you for your attention.
Thank you, Michael. This was a very lucid talk. Now we will move on to next talk.
Dr.
Lovely.
Hello, everyone. I'm sure there would be few, if any, infertility practitioners who have not heard the lectures by Dr. Sandro Estes, or who have not read his publications. And we are really fortunate to have him amongst us today. He is the clinical and scientific director at Androfert, Andrology and Human Reproductive Clinic at Brazil. And he has been the recipient of Star Award at ASRM for the last 5 years. And today he will be talking upon current insights on gonadotropin therapy in male infertility. Over to you, sir, for your deliberation.
Dr. Sandro, you need to just unmute yourself. Yeah.
Can you hear me?
Now we can hear you.
Okay. So first of all, thank you very much for the kind introduction and also the opportunity to participate. Special thanks to my dearest friend, Dr. Sonia Malik. I would also like to greet the other panelists, Professor Greenberg, and also my dearest friend, Professor Anderson. So my talk today is going to be on the gonadotropin therapy in male infertility. So I will try to cover three specific objectives. The first one will just provide you an overview of the importance of male infertility treatment, even in the ART era. Second point would be to understand the rationale for gonadotropin therapy and its main indication in male infertility scenario that could support ART practitioners to improve success. And then I will discuss with you how we can actually apply the knowledge to a clinical practice. So male infertility is a disease of the reproductive system caused primarily by factors involving semen parameters abnormalities, genetic and congenital conditions, anatomic, endocrine, functional, or immunological abnormalities of the reproductive systems. There are also chronic illness and sexual conditions incompatible with intercourse. Although male infertility is still under-recognized scientifically, epidemiologically, socially, psychologically, financially, and politically, as you can see in this slide, the number of couples facing infertility across the globe in which there is a male factor involvement is quite big. So this is important for the clinicians actually to appreciate that male infertility is like a pandemic. So what is the relevance of treating male infertility factor if we have ICSI? Well, ICSI, even in the best hands, will not allow pregnancy rates of over 50%. And although the initial ICSI experience has shown that sperm quality was not a major factor, as experience accumulated, then sperm quality outcomes, specifically in the extreme levels, including sperm DNA fragmentation and the azoospermic factors, actually could impact on ICSI outcomes. Another important issue is that male infertility has been associated with impaired overall health, decreased life expectancy, and lower quality of life, and also reduced fecundability in longer time to pregnancy, recurrent pregnancy loss. I mean, I'm talking about natural conceptions. But when we move for IVF and ICSI and even IUI, we know that, as I mentioned before, the sperm parameters, specifically when we have a sperm chromatin damage, they could have adverse effect on reproductive outcomes. And there's also concern that using ICSI without treating the male factor, we might transfer sperm genetic abnormalities using IVF and ICSI, thus affecting the health of resulting offspring. Well, with that in mind, when we go for the clinic, we see many infertility patients on an everyday basis. And if we do a comprehensive male infertility evaluation, the clinician will be able to identify about 50% of patients in which there's something to offer. This could be medical and surgical treatments that could be able to restore or improve either natural fertility or ART outcomes. So today I'm discussing with you the impact of medical treatment, specifically gonadotropin therapy. So to understand what we can do to our male patients facing, let's say, conditions that might be alleviated by gonadotropin therapy, it's important to review very quickly the role of FSH and LH in spermatogenesis. Well, this is well known that both molecules are extremely important to support the production of healthy sperm. So the main function of LH will be to stimulate intratesticular testosterone production by the Leydig cells. So intratesticular testosterone production will be extremely important, regulating maturation of round spermatid to mature sperm. I mean, this is a step called spermiogenesis. This is one of the last steps in sperm production. So the testosterone that is produced inside the testicle is the one that is important. So this is an important key point here, because some doctors and urologists, they might consider administering testosterone to patients with low testosterone levels. And this is a big mistake, because this could cause supraphysiological testosterone level in the peripheric blood, but it will never match the amount of intratesticular testosterone which is needed for supporting spermatogenesis. So the intratesticular testosterone production is about 100 times higher than what we measure in the periphery, and we should never give testosterone replacement therapy for infertility patients. We need to think on a way of improving Leydig cell function by stimulating with LH or HCG. Well, FSH is extremely important as well, and FSH is actually associated with an increase in sperm quantity. So in synergy with intratesticular testosterone, FSH is important for cell proliferation. And another thing to keep in mind is that spermatogenesis takes about 7-4 days in humans to take place. So every intervention that we do for a male infertility patient could be asking the patient to quit smoking, or any treatment like fixing a clinical varicocele, or either now in the condition of gonadotropin therapy, we need to wait about a little bit over 2 months to appreciate, let's say, the effect of that particular intervention on spermatogenesis. So keeping these conditions that I mentioned before in terms of the importance of FSH and LH on in male infertility scenarios, then we can kind of list at least 3 scenarios in which we will be able to kind of offer a gonadotropin therapy. The first one is when we have hypogonadotropic hypogonadism. This condition is when we have deficient endogenous gonadotropin production or action. And the second condition is when we have intrinsic spermatogenic impairment, either quantity, and then we have the example of non-obstructive azoospermia, and when we have in terms of quality, specifically when we have sperm DNA damage and also idiopathic infertility. So I will explore during this talk briefly these 3 conditions. And it's important to say that gonadotropin therapy, because of, let's say, the opportunity to improve quality and quantity by improving intratesticular testosterone production and also providing support with FSH, this gonadotropin therapy has become an integral part of male infertility treatment, supporting ART doctors as well. So we have several drugs that can be used. We basically have recombinant and urinary products in which we can deliver both FSH and also LH in terms of providing LH activity using HCG. Although HCG has been used quite for a long time in terms of supporting Leydig cell function, and this is, you know well, because both LH and HCG, they interact with the same LH-HCG receptor at the Leydig cells, and HCG has a longer half-life. It has been, let's say, the drug of choice for supporting intratesticular testosterone production. But there are several studies now showing that LH itself, like recombinant LH, can also provide support for intratesticular testosterone production, as you can see in this graph. I mean, in the axis, you see the testosterone production using recombinant HCG here. And then in the Y, you see testosterone production when we give 150 international units of recombinant LH. So you see that both drugs can support, let's say, increasing intratesticular testosterone production, although the potency is higher with HCG. So at our center, which is a referral center for male infertility in Campinas, Brazil, we developed this acronym, which is ITESGO, Individualized Testicular Gonadotropin Therapy, in which we individualize our therapy according to the patient clinical characteristics. For example, patients with hypogonadotropic hypogonadism, and this is a condition in which there is a deficient production or action of both LH and FSH. The condition can be caused by congenital factors, could be acquired as well. For instance, a pituitary surgery, or even testosterone replacement therapy, and also, systemic diseases. The condition could be also idiopathic, but the bottom line is that when we have a patient with hypo, the FSH and LH levels that we measure in the peripheric blood will be below 1.2 international units per liter. And as a result, azoospermia will ensue. So azoospermia is due to the lack of adequate testicular stimulation by pituitary gonadotropin. So it's quite easy in this scenario to provide treatment, because the only thing we need to do is replace what is missing. So then we need to define if the hypo is congenital, is child onset hypo, then the treatment would be an association with HCG and recombinant or urinary FSH. So our protocol is listed there. We combine both HCG and recombinant FSH. But if the condition is adult onset hypo, then we start with HCG alone, because the germ cells have been primed in adult onset hypo with FSH before, and LH as well. So several patients will respond to HCG alone without the need of adding recombinant or urinary FSH, although some patients will need to do it. So the treatment is actually, we follow up the patients monthly, checking the blood levels of FSH, LH, testosterone, and estradiol. We do the physical examination, the ultrasound scan, and the semen analysis. So the goals in this treatment is actually to have sperm in the ejaculate, allowing natural pregnancy or pregnancies by IUI, IVF, and ICSI. So the evidence concerning gonadotropin therapy in hypo males is quite good. We can restore spermatogenesis in up to 90% of patients, with reported pregnancy rates of up to 65%. So sperm count is usually higher when we combine HCG with FSH versus HCG alone, but there is still lack of randomized control trials exploring different drugs and regimens. So the treatment is long and therefore a little bit costly, and the follow-up with hormone testing and semen analysis is mandatory. So when patients start to have sperm in the ejaculate, we always offer sperm banking to these patients, because they might need to kind of stop treatment. Unfortunately, hypo is quite uncommon in the clinical practice. The most patients we see in our clinic is actually patients with spermatogenic failure, non-obstructive azoospermia. So in this scenario, it's completely different, because then in non-obstructive azoospermia, we have intrinsic testicular defect. That could be congenital, like cryptorchidism, could be Klinefelter syndrome, Y chromosome microdeletions, could be acquired conditions such as testicular cancer, testicular trauma, torsion, post-inflammation like mumps or caries, and could be idiopathic. Unlike hypo, azoospermia in a man with a non-obstructive azoospermia is caused by lack of sperm production due to intrinsic testicular deficiency. So in this case, most often you find high FSH levels, so higher than 7.6, and then you find normal or in the upper limits LH levels. So this is a condition that we need to make the differential diagnosis. But a common trait that we find in most patients is actually low testosterone levels and also small testes. So what's the rationale then to give gonadotropin therapy for patients having already high FSH Well, the point here is that we are willing to increase intratesticular testosterone production that I showed you before, that is very important to kind of the last steps of sperm maturation. So most studies actually explore use of HCG to increase intratesticular production. As you can see in the right part of the slide, in the top part, intratesticular testosterone levels after administration of HCG increases remarkably. And the other important thing is that when we increase intratesticular testosterone, then there is a reset in FSH action, because the higher testosterone in circulation and also an increasing estradiol levels that usually follows HCG administration will decrease the pituitary secretion of FSH, then normalizing FSH levels, which is important to reset the receptors that we have at the Sertoli cells. So this high intratesticular testosterone that can be achieved with use of HCG would be able to allow us to improve spermiogenesis, spermatogonium proliferation, and also upregulation of the androgen receptors that is important actually for action and spermatogenesis in the testes. This has been shown in some studies. And the importance also, as I mentioned before, would be to reset FSH to normal levels. So this is critical to increase expression of FSH receptors and restore Sertoli cell function. Well, this phenomenon will never happen if you give clomiphene citrate, for instance, or any other estrogen modulators, because in that condition, you will increase even further FSH production, and then you will cause downregulation of FSH receptors at the Sertoli cells. So I feel, and our experience shows that a gonadotropin therapy is a better option for men with non-obstructive azoospermia. So why to do that? And the answer is very simple. In men with non-obstructive azoospermia, even using the best protocol for sperm retrieval, our success rates do not go above 50%. So several groups, including ours, have explored the opportunity to improve spermatogenesis with the final objective of increasing sperm retrieval success rate and eventually having sperm in the ejaculate. So in our clinic, the ITESGO protocol for non-obstructive azoospermia, then we have two conditions. We have, let's say, a patient with hypergonadotropic hypogonadism, I mean, high FSH levels and then low testosterone levels. For these patients, we give HCG, small doses of HCG twice a week. And then we add recombinant FSH or urinary FSH. We prefer recombinant products in our center. We only add recombinant FSH if FSH levels are reset to below 1.5 international units per liter after giving HCG. So we start with HCG and then add FSH if needed. If we have a patient with maturation arrest in which, I mean, the spermatogenesis is halted at some stage from spermatogoniad to spermatid, and these men, they have normal testicular size, normal FSH, and normal testosterone levels, the rationale here is to give FSH. So then we start treatment with FSH alone, and only if needed, we give low doses of HCG to support, let's say, intratesticular testosterone production to the optimal levels. So again, we do the same follow-up as I showed you before. And our goals in this scenario, we will be to have testosterone levels between 500 to 800 nanograms per deciliter that we measure in the peripheric blood. And then we will aim to have, let's say, improvement in sperm retrieval success. In our case, we always use microdissection testicular sperm extraction for men with non-obstructive azoospermia. Here, very briefly, the protocol that we have developed and published a few years ago in Asian Journal of Andrology. So this is a protocol that I showed you before using gonadotropin, specifically we use recombinant HCG for improving intratesticular testosterone production. Then we add recombinant FSH when needed. So we start with HCG, small dosage, twice a week. We adjust the dose of HCG to achieve the testosterone levels between 500 and 800, which is equivalent to 17 to 28 nanomoles per liter if you use that unit. And then we kind of add FSH when the FSH levels drop to below 1.5 international units per liter. So in case we have high aromatase activity and then we have high estradiol levels, we consider giving aromatase inhibitors as well. So the duration of treatment is about 3 to 18 months. And then we follow up as I showed you before. So the objective is actually to improve success rates by sperm retrieval, but eventually using this protocol, we may have some patients in which we will be able to find some sperm in the ejaculate, like in this case report that we did with the group of Peter Humayden in Denmark, using this very same protocol. And then we were able to have sperm in the ejaculate. Sperm was vitrified. We did vitrification in this case. And then we were able to achieve ICSI with a vitrified sperm from the ejaculate without the need of sperm retrieval and the delivery of a healthy baby. So for non-obstructive azoospermia, the summary evidence indicates that gonadotropin therapy might increase sperm retrieval success and enable return of sperm to the ejaculate. However, the evidence is based overwhelmingly from observational trials and case series. So we still need randomized control trials comparing gonadotropin therapy with no treatment and also different drugs and regimens. The best candidates include hypogonadal men, like men with low testosterone levels, small tests like Klinefelter syndrome, and men showing histopathology, maturation arrest, and hypospermatogenesis. So, several men will fit into these categories in the non-obstructive azoospermia scenario. So this is basically the information for non-obstructive azoospermia. So the last condition that I will briefly discuss with you is idiopathic infertility, which is defined by abnormal semen analysis or abnormal sperm function, like high sperm DNA fragmentation, in the absence of an evident male infertility factor. So again, gonadotropin therapy in this scenario might help increase sperm concentration. Well, in this slide, I present you the evidence.
I would just request you to wind up a little fast because we've overshot the time.
Okay, yeah, I will. So this slide shows that we can increase sperm concentration by using gonadotropin therapy, and this evidence is based on randomized control trials, with also some evidence indicating that the pregnancy rates are increased. And sperm DNA fragmentation, again, randomized control trials and observational studies showing that gonadotropin therapy, specifically FSH in this case, might be used to improve, to alleviate sperm DNA fragmentation. Although this is not the only option, there are many other options we need to consider to alleviate sperm DNA fragmentation as we put together in this paper. But gonadotropin therapy is one option. And then in our scenario, we test for, in patients with idiopathic infertility, we test sperm DNA fragmentation. If it's high, we try to identify if there's any correctable condition that might be associated with sperm DNA fragmentation, and then we offer this treatment for the patient. And if sperm DNA fragmentation is still high and the patient is a ICSI candidate, we use testicular rather than ejaculated sperm for ICSI. So if there's ICSI failure and then we measure sperm DNA fragmentation in testicular sperm, and then we give FSH 150 international units twice a week for a minimum of 3 months as a way to help alleviate sperm DNA fragmentation. So for idiopathic infertility, we have data showing that it might increase sperm quantity and quality with an overall positive effect on pregnancy, either natural and IVF ICSI. So then the best candidates includes the normal gonadotropic males, specifically males with some sort of the most common polymorphisms affecting the FSH receptor. But as I said before, there is still lack of large studies, randomized controlled trials. So the take-home messages here would be for gonadotropin therapy in male infertility, just consider the male infertility condition as an important critical element adversely impacting the overall health and ART outcomes. The FSH and LH-driven testosterone plays a critical role in providing the optimal condition for the production of healthy sperm. Gonadotropin therapy as an element that needs to be included to support ART treatment in specific groups of patients as a way to increase sperm quantity and quality. And the main clinical scenarios for gonadotropin therapy in supporting ART treatments include the hypogonadotropic hypogonadism, non-obstructive azoospermia, and idiopathic infertility, specifically oligoastenoteratozoospermia and high sperm DNA fragmentation. So with that, I conclude, thanking all my teammates of the institutions I'm linked with, and thank you all for your attention.
Thank you so much, sir. That was indeed a nice and deep insight into the subject. And I would request Dr. Shweta to start the question.
We have only 10 minutes now for discussion. Dr. Loveleen, please note, all the chairpersons, please note, we have around 10 minutes and then we have to wind up for the oration.
Yeah, so I would quickly sum up my questions. There were a couple of them for Dr. Anderson, but I think most important, the delegates wanted to know what is the media you are using for IVM and for cortical tissue preservation, and how do you assure the survival of the tissue clinically? Sir, I think you are muted. Professor Anderson, I think you're muted.
Sir, kindly unmute yourself.
We still can't hear you. No.
Better now?
Yes, yes, we can hear you now.
It is better now. Excellent. So I'll take off the headphones this time. So I think to make this short, so we have an opportunity for other questions. The media we use is all published. So please just have a look on PubMed or write to me, and I'll be happy to provide you with the articles in which it is described exactly how we do it. And what was the other question, please?
So the other question was that how do you ensure survival of ovarian tissue once it's cryopreserved, and do you look at the density, and how do you achieve very, very minimum strips? Is it through microtome or is it manual?
We prepare the strips manually. So we make sure that they are 1 millimeter thick. This is normally the thickness of the ovarian cortical tissue, and this is where all the primordial follicles are located. So we do this manually. And
how do you ensure oocyte survival? I mean, the tissue survival.
And so this would be follicle survival. And
yeah,
we
follicle survival.
This is also published. Please go and have a look on PubMed. We have developed a method where we use this neutral red, which stains viable follicles. And when we stain the tissue with for viable follicles after sawing, we can see that we have a survival of follicles of almost 90%. So there's a very small reduction in the number of viable follicles during the freezing process. But during the transplantation process, there's a massive loss of follicles. And this is where we are now concentrating to try and optimize the transplantation process.
So do you prefer a heterotrophic transplantation or an orthotopic?
This is normally, we actually do both nowadays. So because we would normally have a small atrophic menopausal ovary, which will be unable to accommodate for more than 5-6 pieces of cortical tissue. Nowadays, we would probably, as you saw from the pictures, transplant 10, 12, 14 pieces of tissue. So we would put whatever the ovary is able to accommodate into the ovary, and then we would position the remaining pieces of cortical tissue in peritoneal pockets.
My last question to you, and then I'll hand over to Dr. Shilpi. The question asked was the role of hydrogel encapsulation for follicle maturation. Is it?
Yeah, no,
doing
this
that?
is, yeah, for follicle maturation. No, human follicles, growth of human preantral follicles is a very delicate and difficult matter. And nobody is able really to grow them to any significant degree to obtain mature oocytes. So this is something that you would still need to work heavily on. Indeed, we do use 3D hydrogels to encapsulate the isolated follicles in order to grow them. But this is not something which is clinically feasible at this point in time.
And are you doing a slow freeze or vitrification for your?
I think we do slow freezing, as the vast majority of people do in the world. There's in the Far East, in Japan, they do vitrification, but for the rest of the world, slow freezing is the method of choice.
Thank you so much. Dr. Shilpi.
Professor Michael, are you there?
Yes, he's there.
Yeah. Professor Michael, there's a question, like any specific investigations or specific tests before we are taking for random test stimulation for a patient for cryopreservation?
No, nothing specifically required, just an antral follicle count and, if possible, an AMH in emergency, but if not, just an antral follicle count to adjust the starting dose, but that's it. And if you have a progesterone measurement, you can make sure that you're in the luteal phase of the cycle. That's it. But whatever, you do not need anything else. Should be fine.
Any use of adjuvants to improve the oocyte yield?
Sorry, I missed the question.
Any use of adjuvants to improve the yield? The oocyte yield.
To improve the oocyte,
Do you use any adjuvants?
No adjuvant to improve. Just following the trigger, as I told you in my talk, we measured the LH level and progesterone to make sure that the trigger has been successfully hacked on the follicle, but that's it, nothing else. And if we expect a small number of eggs in the end of the procedure, we're used to flush the follicle 3 times.
Okay. What do you think, like any particular malignancy has effect on the oocyte yield and the quality of oocyte yield?
Probably not a problem of the malignancy by itself, but the overall general state of the patient may impact on the ability to follicle to respond to FSH. The problem is not at the time of the surgical procedure, except if these patients fail to respond to GnRH agonist trigger. But if the trigger has been done and LH and progesterone have risen on the following days, there's no impact. But when the general state of the patient is impaired and is not that good, these patients often respond quite a bit less than patients who are healthy or with breast cancer as an example, because breast cancer do not impact on the general state of the patient. So we've seen this in patients with hematological diseases, lymphoma or leukemia patient.
So can you
Dr.
tell
Lovely.
me the youngest? Yeah.
Dr.
Lovely.
Can you choose or select your patients of idiopathic infertility who would do well with the gonadotrophin therapy? Before you put everybody on therapy, can we select our patients?
Which therapy?
I was talking to Dr. Estes. The question was for
sorry.
Sorry, could you repeat that?
Yes. Can you select your patients to see which patients of idiopathic infertility would do better with gonadotropin therapy? Are there any indicators for us to select?
No, actually, if the patient has idiopathic infertility, I mean, you have ruled out other factors. I mean, the factors that you could correct, you might kind of consider giving FSH therapy for this patient population. I mean, there's no specific threshold that you need to consider. Well, there are some studies in which they look at FSH receptor polymorphisms, specifically the serine 680. I mean, this was a research article in which they found that this specific patient population, they responded better. But there's only this study to my knowledge. We don't test FSH receptor polymorphisms in our patient population. So basically we do, let's say, a trial of a FSH therapy for this man, and then we analyze the results obtained. But you need to use for at least 3 months any therapy, as I said before, mainly due to the duration of the spermatogenic cycle, which is about 74 days.
Dr. Steves, can I ask a question? You know, the proponents, Dr. Ramaswamy and group, they propose giving clomiphene and also alternate therapy of clomiphene and letrozole for men who have idiopathic azoospermia, who are going for microtesy, so as to increase the intratesticular testosterone, typically with a borderline high FSH like 11 or 12 with little low testosterone. And you advocated HCG and gonadotropin. So how do you differentiate between the two?
This is completely different. I think there are two options.
Yeah.
You can go for this, let's say, less expensive regimen in which this is estrogen modulators, as you know. What happens is that you will increase the, let's say, pituitary secretion of FSH and LH when you give clomiphene, for instance. So what happens is that these patients with non-obstructive azoospermia, usually they have, let's say, they have been exposed to high levels of FSH for quite a long time. And the FSH receptors that are there in the Sertoli cells, they are kind of stimulated continuously. And then what happens is that you might get downregulation of these FSH receptors. So when you give clomiphene, then you increase even further the FSH levels, and then you kind of promote exacerbation of this downregulation. So the proposal that we do is according to the Japanese group of Professor Shiraishi. It's completely different. What we are trying to do here is, like them, increasing intratesticular testosterone that can be achieved by giving HCG or clomiphene citrate. But on the other side, when we increase intratesticular production using HCG, the adverse but good effect, let's say, is actually inhibition, a negative feedback to the pituitary, and then FSH levels will go down. So you have a patient, for instance, of baseline FSH of 12, 15, and this patient will have then FSH levels of 3.2, which is excellent. So which means you start kind of to have more receptors expressed at the Sertoli cells, making it more, let's say, functional to kind of support the spermatogenesis as a whole. So then you have the dual effect, an effect of testosterone, intratesticular testosterone, which is important for the late stages of sperm maturation. And then you have the effect of FSH for, let's say, proliferation. So we find this protocol, let's say, completely different than the approach that you just mentioned, but it's quite interesting to see the effects in the population of non-obstructive azoospermic men we treat.
Thank you so much, Dr. Estes. And we would like this to go on, but then time is a constraint and we must close the session. Thank you very much to all the speakers, the chairpersons, moderators, everybody. And we now move on to the next session.